two, shake this, one, two, one, shake this, one, two, shake one, two, this, one, two, shake. Hey, check one, two, check this, test one, two, check.
This 6th CardioCon being one of the best conference in Mumbai. Today, let's celebrate the wonderful Guru Krupa Heart Foundation and Charitable Trust led by Dr. G.P. Ratnaparke sir. Let's, let's learn about Guru Krupa Heart Foundation and Charitable Trust. Compassion and commitment towards society. We have done fantastic things like organizing free medical camps to help people in need and even offering medical checkups for doctors. Our free ambulance service ensure quick in help in emergencies. But that's not all. We have adopted night schools, providing free service to kids in need. We have also arranged medical conferences regularly. In village, we have brought technology for kids, education, and help families with essentials. Plus, we have planted trees and improved public facility, as you can see the projector screen. Now, I would like to invite Dr. Shashank Shah, Senior Family Physician in Ville Parle and convener for today's 6th CardioCon. Let's have huge round of applause. Thank you.
Thank you, Dr. Ram. Good morning, honorable chief guests, guests of honor, speakers, and all invaluable doctors. Welcome to the 2023 CardioCon 6th conference hosted under the leadership of our own Dr. G.P. Ratnaparke sir. I am honored to be here to address this remarkable gathering of 1,000 of brightest mind in medicine. You are here because you are passionate about making difference in lives of your patients and about advancing field of medicine. This conference is an opportunity for you to learn from each other, to share your knowledge and expertise and discover the latest advances. It is also an opportunity to celebrate your accomplishment and to renew your commitment to your profession. As a convener of this event, I am humbled to see the impact that you have on your patients. You are unsung heroes of our society and we are grateful for your dedication and service. This year's conference has theme of innovation medicines, the future of healthcare. We have assembled the world-class rosters of speakers will share their insights on latest advances in medicine research, technology, and practice. I encourage you to take an advantage of all that this conference has to offer. Attend these sessions, network with your colleagues, and learn as much as you can. In addition, I would like to thank Dr. G.P. Ratnaparke sir to give me opportunity to serve you as a convener of today Mega CardioCon 6 conference. Also thank all committee members of this event for their hard work and dedication. Thank you for making this conference possible. Finally, I would like to welcome all the doctors in this room. You are the best of the best and we are grateful for your presence today. Thank you. Have a wonderful conference and please make a most of today. Thank you. With no further ado, I would like to hand over to our first MOC, Dr. Ashwini Chauhan, to begin with Dhanvantri Puja. And Dr. Ashwini Chauhan is practicing since 19 years and she is fortunately First Lady of Medical Club of Ville Parla Juhu. I welcome Dr. Ashwini Chauhan on the dais. Thank you.
Thank you, Dr. Shashank Shah, for the kind words. Good morning, everyone. We'll start with Dhanvantari Stavan. For the same, I will like to request Professor Dr. Anil Sharma, our first guest, and Dr. G.P. Ratnaparke sir and Dr. Rajesh Ghatkar sir to please come forward for lighting the lamp. And Dr. Bakul Mehta sir, he is the ex-AMA president, the senior family physician, MCV president Dr. Ram Chavan sir, Dr. Anil Kumar sir.
आरोग्यं धनसम्पदा शत्रुबुद्धिविनाशाय दीपज्योति नमोऽस्तु ते दिव्यादिव्यारे दीपत्कार कानि कुण्डलमोतिहार
Dr. Smita Ghatkar ma'am also to join. For 2 minutes. शङ्खं चक्रं जलौकां दधतमृतघटं चारुदोभिश्चतुर्भिः सूक्ष्मस्वच्छातिहृदयां शुकपरिविलसन मौलिमं भोजनेत्रं कालाम्भोद्वोज्ज्वलाङ्गं कटितटविलसन चारुपीताम्बराढ्यं वन्दे धन्वन्तरिं तं निखिलगदवन प्रौढदावाग्निनिलं प्रौढदावाग्निनिलं प्रौढदावाग्निनिलम् ॐ Thank you so much. You all can be seated. A team is not a group of people that work together. A team is a group of people that trust each other. I am very much obliged to Guru Krupa Heart Center and Charitable Trust, Chairman Dr. G.P. Ratnaparkhi sir and Dr. Smruti Ratnaparkhi ma'am for giving me this opportunity for the first MOC of this CardioCon. And I'm thank you to all of you for presenting here and trusting us for the 6th CardioCon here. Now, without wasting much time, let me call our first speaker, Professor Dr. Anil Sharma. He is a renowned cardiologist.
Sorry to disturb you, Ashwini. शकील लियाकत अंसारी, उनका पाकिट मिला है. कंफर्म करो आप शकीले हो, क्योंकि इसमें दाढ़ी नहीं दिख रही. कोई शक.
So our topic is aggressive lipid management beyond statin. What's next? Professor Dr. Anil Sharma is a renowned cardiologist and outstanding teacher who has a significant contribution in the growth and development of interventional cardiology in India. He is working as a professor and HOD of cardiology department in Bombay Hospital. He has also worked at prestigious Mount Sinai Hospital, New York, USA, and University Hospital, Torino, Italy. He is one of the few Indian cardiologists who achieve fellowship in complex angioplasty from Italy. He has been performed more than 26,000 procedures in last 26 years and received many awards, including Gem of India, Dr. Rajendra Prasad Vedyakiya Award, Mumbai Achievers Icon Award 2023, etc. Here I welcome Professor Dr. Anil Sharma, who has a dream to make India free of heart attack by lifestyle modification. Please, sir.
Thank you, Dr. Ashwini. Ashwini is the first nakshatra. I think she is the best name suggest to start as opener. Anil means wind. It is moving slowly, you will enjoy it. This is, इससे नहीं हो सकता क्या? तो इससे ही करूँगा मैं खाली, मेरे को कुछ नहीं करना. Good morning all. First of all, thanks to Dr. Gajanan Ratna Parkhi, with whom my association is more than 25 years. We have grown together and I am happy to see him in good health and so much successful, and his fan followings and his well-wishers I can see. I am very happy. Next 30 minutes we are going to discuss about the aggressive lipid management beyond statin, but we'll first discuss, as I said, I am a professor, so I will going to discuss about the 30 facts. So need not necessarily go into all the details of the slides. I'll talk about the few concepts, like what is absolute risk reduction, what is relative risk reduction, and so and so. So we start with what is the background, what is atherosclerosis, what is lipids, what is lipoprotein, how low to go, how to start. Statin, what is the problem with the statin, what are the limitations, what is the advantage, and then non-statins, and then the recent advances and what we are going towards the next couple of years. So we all know the commonest reason, number one killer is atherosclerotic cardiovascular disease. What is atherosclerotic cardiovascular disease? Atherosclerosis is deposition of cholesterol on the walls of the vessels. Atherosclerosis. Athero means cholesterol, sclerosis means hardening. Cardiovascular means heart and vessels. So it is primarily, if you connect with the daily practice, it is coronary artery disease, myocardial infarction, unstable angina, stable angina, and stroke, break. So these are the four things means. What is the commonest reason? In the inter-heart study, the commonest reason for this atherosclerotic cardiovascular disease, or MI, acute MI to be precise, was lipids. Now what are the lipids? We all know protein, fats and lipids. So what is the lipid? What is lipoprotein? And what is the LDL, HDL, lipoprotein A? All these things we need to and have understanding, then we'll go the how to treat it. So hypercholesterolemia prevalence, how common it is? In the rural it is 15 and 30% in the urban. Why 30% in the urban? Because of lifestyle. I always say Panch Tantra by Vishnu Sharma and Panch Mantra by Dr. Anil Sharma. Dimag thanda rakhna hai, keep cool, stress avoid. Number 2, tobacco, smoking, alcohol, don't allow it to go inside. Number 3, breathing exercise or pranayam. Number 4, about the diet, avoid the junk food, fast food. And number 5 is the bus number 11, that is your two lower extremities, use them. So these 5 mantra by Anil Sharma. So that is why the difference between rural and urban. So lipoprotein, now suddenly from lipid, what is lipoprotein? Lipoprotein is lipid plus protein. So lipoprotein is a carrier. Lipids, basically when we talk, there are so many complexity of the lipids, but you remember there are only 2 things. One is cholesterol What is the purpose of cholesterol? It is for sex hormone. This is for cell membrane. This is for bile. And another is a triglyceride. Triglyceride means tri. So with the glycerol, there are 3 fatty acids, that is energy, urja. So this is lipoprotein. Protein is a carrier. Protein is a carrier. So they travel in the blood, and there are various combinations are there, like it is a low density lipoprotein, high density lipoprotein, very low dense lipoprotein, and VLDL. So there are 2 pathways by lipid. One, what we eat is chylomicron. It moves, travel in the blood, and it reaches to the cell where it says, what it says to the blood, triglyceride le lo. And how triglyceride is taken? There is a lipoprotein lipase. It just kept this, remove the triglyceride and leave remaining. So then it becomes VLDL remnant. It goes to the liver deposited. Then liver is a factory, we all know. What is endogenous? Then liver produces that VLDL, very low density lipoprotein, means it again contains triglyceride and cholesterol. Again it travels into the blood, and again there is at the muscles and cell levels, it removes the triglyceride for energy, remaining it travels into the blood. So these are the basically triglyceride for energy, cholesterol is for various purposes, but there is a excess blood cholesterol is there. The excess cholesterol is there that deposited into the cell wall. You can see here. Just a minute, control L. Yeah. So you can see here, keep on deposited, and then there is at this time on the top of atherosclerosis, there is a clot formation, that is atherothrombosis. But is there any advantage of lowering lipid? Yes. You can see here, there are 4 molecules, 2 are deposited. When it is reduced, 2, there is only 1 is deposited. So lowering the LDL, which is the most dangerous thing, which is a bad thing, villain, it is to be controlled. Now how to control? It depends on the what is the patient's risk is there. See, so many trials has been there from starting from the 4S in 1990s, the first trial in the secondary prevention, and then afterward we have so many like high statin, then we had ezetimibe, then we had PCSK9 inhibitor, then we have latest the bempedoic acid, then we are now coming the inclisiran, and so many genetics we are working on. So that's what it says. The 1 millimole, that is 38.7 lowering of the cholesterol, reduces the 22% relative risk reduction. What is relative risk reduction? What is absolute risk reduction? I'll just take 2 minutes here. It's very important to learn. So if we say that lowering the roughly, let us say, to be precise, rather than 38.7 versus 22, just take 40 milligram lowering of LDL, reduces the 20% risk. What 20% risk is? If we are giving it to 100 patients, it is not going to help 20 persons. It depends on the risk of the patient. Suppose the underlying patient, the group, younger patient with negligible risk, it is a 10% risk. Other side, there is a multiple risk factors, established CABD, elderly, diabetic, smoker, hypertension, let us say risk is 40%. So that is if it reduces, let us say 40%. So in the low risk benefit, low risk group, 40% of 10%. Means if 100% patient take the medicine, nothing is going to happen because risk is only 10%. 10% will have disease if no statin. But if you give statin, 40% reduction means you will benefit 4 patients. So 4 will be beneficiary. But if you give to those patients who have in high risk, if you give to 40%, there's 100% patients, it will reduce the 40%. So 40% of 40, it will be 16% will be benefited. So same statin in lower risk group will benefit 4 persons, while in the 100 higher risk benefit, it will benefit 16%. This is just to understand. And how we decided? So there you can see these slides. You can see up to the 60, the lower the statin, lower the LDL level with the statin, better it is. Now there is the treatment effects on LDL. It targets for 100 versus 70. And it was shown that less than 70 is better than 100. But they'll mange more. This is improve it trial. The entry point, the patients, two groups, both were 70, on the top of the 70 with the highest possible statin, one group on the top of simvastatin, they were given agitimib, and other group only statin. Again, over the 7 year, there is a 2% absolute risk reduction. So 34% risk in those who are on statin only, and 32% on those who are put on agitimib also. So again, lowering 53, it is better. But again, they'll make more. Then this is about the PCSK. This is an Indian study which was compared versus this LDL 40 versus 80, and it showed that even higher the better statins, because it again significant risk reduction is there. Again more, Fourier trial, PCSK9 inhibitor, 60% risk reduction. So LDL 30, no problem. You keep on lowering, lowering, lowering. Should we give it to all the patients? No. Why? Cost increases, side effects increases, and PCSK9 is again injectable. So which patient you give, that will decide. So what are the current guidelines? There are again 3-4 categories. I will not go into the unnecessary details of this very difficult slide, busy slide. Just remember 4 groups. One group is primary, no atherosclerotic disease. Primary prevention, again, what are the risk factor? Diabetes, second group. So one group is other group except the diabetes, whether it is age, family history, smoker, and so and so. Other group is diabetics. Third group is family history. And fourth and one of the worst group is those who already had an event. So that is atherosclerotic disease. So again in this group also, there are, how to know, there are very high risk groups. So these are the risk groups which are again had event in the last 1 year. And so many other criteria you can see on these slides. So higher the group, higher the risk, lower the better. This is the European Society guideline. What is the basic difference? In higher risk, American says it should be less than 70. Then European, it was 2018 guidelines. 2019 guidelines, ESC European says higher risk, it is less than 55. Again, there is a more risk, current risk, try to keep it more than less than 40. So higher the risk, they have proven that those who have higher risk is more and benefit is also more. So decide on whether the high risk is higher, we have to give more medicines. So what is Indians? We are more by the genetics, as well as our risk factors are less controlled. We get disease younger, so we need to be more. What Indian guidelines says, just remember 4-5 things. I am not going to details. Everybody's LDL should be less than 100. If we have 1 or 2 risk factors, 70. If it is diabetes or atherosclerotic, other multiple risk factor or ASCVD, then it should be 50. And if it is the recurrent event, it should be 30. So everybody 70, majority 100, majority 70, and those who are in high risk maybe 15, even 30. So that is how all trials have proven. And they should be started at the earliest, because what they tried, that if we compare with those who are only congenital disease, who have low cholesterol, they did better than those who have been controlled cholesterol by the medicines. Still with the high statin, only 1/3 patient risk with reduction was there. 70% risk could not be reduced, and there was some risk of stent intolerance in 7 to 19% cases. So what was this thing? Assess the risk versus benefit. Agitimib, it reduces the absorption of cholesterol, reduces the cholesterol, upregulates the receptors. So this again, as I discussed already, it reduces over the 6 years. Higher the risk, higher is the better. Then came the PCSK9. What is PCSK? PCSK is the regulator of the LDL, this is a receptor. So we inhibit the inhibitor, so it increases the receptor. What receptor does? It takes the LDL out from the blood inside the lipid. So it reduces the cholesterol. There have been Fourier trial, wonderful trial on the stabilized. There is another trial, that is the Odyssey trial. It was in the ACS patients. Both showed that significant 20%, around 20% reduction over more than 2 years in the event. And that is another trial. It was not only LDL, it is not about the events, it was the IVUS, intravascular ultrasound. We went inside the artery and showed that the plaque volume was reduced significantly. You can see the orange color. So this is L number of the trials you can see. So with the moderate intensity, 30% reduction cholesterol, high intensity 50%, statin plus ezetimibe 65, statin plus PCSK 75. If you use all three, it is 85% reduction. So it's still, these are the fourth one is the bempedoic acid. How we can start step by step. High cases you can start right from the beginning. So how low is even can be achieved? Patient is born, it was the Nobel Prize winner, both are Nobel Prize winner. They said 25 to 60 is the, when somebody is born, the cholesterol required minimum is 25. It is at the, if fetus, when somebody is born, it is up to 60. And it becomes increase in 60, 70, it crosses 100 by the age of 18. So bempedoic acid, we'll see, inclisiran, then other, again, I'm not going to discuss, I think Dr. Jahala is going to discuss about all these things. So absorption, this ezetimibe, and there are different mechanism of actions. Bempedoic acid is work a little bit earlier than in the same pathway than statin. What is the main important thing about the bempedoic? It reduces around 20%, 15 to 25 minutes. Those who are already on statin, it reduces 15%. Those who are without statin, intolerant, it reduces 25%. With ezetimibe, it reduces around 35%. Two things important about the bempedoic acid, uric acid, and those who have high risk of, like those who are on steroids particularly, there is some risk of tendon rupture is there. There are 4 trials, and then outcome trials also has come. Outcome is, we are reducing labels, that's okay, but is it preventing the death? Is it preventing the event, means heart failure, hospitalization, stroke? So this is a significant. Even in intolerant patient, this has shown there is important. And there is a, what we are now moving towards is, there is a about, we are going. So PCSK is now is if making the PCSK ineffective, is the antibodies. Then beyond this is the inclisiran. There are 2 ways working, ASO and siRNA. What are these things? It is like a small interference RNA, and that is an antisense oligonucleotide. They work, one work in the nucleus, another work in the cytoplasm. It does not allow PCSK to be formed. This is, we are moving towards, the inclisiran trial is ongoing. By next year we will come to know. Advantage of inclisiran is that twice a year injection 300 milligram will be enough. So once and we are done. So it is twice a year take injection and 50% reduction of the lipid lowering. So these are again genetics. We are going to the DNA. This was published in the American Heart Association. 2 oral PCSK9 inhibitors is still lot of way to go. But just don't concentrate on the statin alone, because our target is not statin, not LDL alone. We have to take care of the other risk factors like diabetes, inflammation, maybe HSCRP, lipoprotein A, so many things. But I think Dr. Darshan is going to discuss. This again anti-inflammatory like Qualcott and Lodoc trial. Lipoprotein again, division is reduced, but whether it is going to reduce the event, we do not know. Again, the Orion trial is going on. So how far we have come into therapeutics from 4S in 1995, we have reached to the, so to conclude my talk, LDL is the villain, it is proven value. Start, if LDL is more than 100, everybody should be on statin. If it's a higher risk, try to go with the higher statin. If it cannot be tolerated, you can add ezetimibe. Still cannot be controlled, add bempedoic acid. You can add, but if it still cannot be controlled in the very high risk group, which already proven ACVD, recurrent events, and those with the high risk like diabetes, CKD, all unstable patients. And sooner the better. Other important thing is about the adherence. That is what I showed is about this risk reduction. Thank you very much. Yeah. Yeah, once statin is lifelong statin. That is must. That is must. So again, as I said, there are little differences between ESC and American Association. There is a, I would say, targets and thresholds. So how study is being done? American Association is about the thresholds, and ESC's target means So ESC is more aggressive, and our lipid association is even more aggressive than ESC. So once statin has to be in statin. And what trials has shown, those who are born with some inborn genetic problems where LDL is low. Let us say somebody's LDL is 50 because of some disease, and other person whose LDL was 100, and at the age of 40 we reduce it to 50. The difference with the trial showed that those who have 100 became 50, the event rate means, let us say 18% benefit, while those who are inborn, the benefit was 54% or 52%, or roughly 3 times advantage. Means earlier the better, more the lowering is better, and adherence is the very important, because 50% of the patients down the 5-year lane stop medicine. Heart attack, take medicine, after some time they say it is cured. Nothing is cured, it is improved. Even if you say heart failure, they had earlier recovered heart failure, they changed the terminology, because they say nothing is recovered, it is improved. So there is a technical term is, recovered means you have everything is settled down, nothing to worry. Improved means improved, but you can deteriorate also. So once statin, always statin. No questions? So you can discuss later on. Just last question please. Yeah, quickly. If it is intolerant, we have to add. But on the top of fenofibrate,
Yes, sir.
fenofibrate is no single trial has proven that it reduces the triglyceride. I think in the next talk is on that triglyceride. Dr. Darshan has come.
And so between
Yeah.
atorvastatin and rosuvastatin,
Practically all are possibles. I think it depends on which company people are going to meet you.
Thank you, Professor Dr. Anil Sharma, sir, for the lucid lecture. For the felicitation, may I call upon AMA President Dr. Anurag Bhatte, sir, for shawl distribution. Andheri Vileparle Physicians Association President for bouquet distribution. MCVP President Dr. Ram Chavan, sir, for bag and gift distribution. Dr. Smriti Ratnaparkhi, ma'am, for silver lamp distribution. And Dr. GP Ratnaparkhi, sir, for memento and Ganpati distribution. I will request Professor Dr. Anil Sharma's better half to please join for the felicitation. Please, ma'am. Please. Our next lecture is on the role of HDL, triglyceride, non-HDL cholesterol in management of coronary heart disease and neglected lipids. For the same, the lecture is going to give by Dr. Darshan Jhala, sir. He is MD, DM Cardiology, studied at KEM Hospital and St. GS Medical College in Mumbai. Practicing since last 35 years, attached to Lilavati, Nanavati and BSES MG Hospital, performing all invasive and non-invasive and cardiac procedures. He has special interest in complex pacemakers and echocardiography. Sir is the principal investigator in the relay study of dabigatran. Please welcome on dais, sir.
Thank you, Dr. Ratnaparke, for the invitation. Uh, this is an interesting topic. Can I have my slides? Yeah. So, uh, Dr. Lalit Sharma told us about the importance of LDL and how we should bring down the levels and what are our targets, etc. And he took us through all the complex guidelines, etc. Uh, that was all extremely very informative. The thing is, we get these reports. So now I think most of us just look at the total cholesterol, LDL, triglyceride, get rid of the patient. Well, that's actually a little slightly beyond that is something that we need to target. So if you take the total cholesterol, that has all the atherogenic lipids, everything. Now all atherogenic lipids are carried by a protein called the ApoB. So there are two types of ApoB, ApoB100, ApoB48. But let's not get into all that. So the lipoprotein ApoB, the cholesterol carried by this apoprotein are atherogenic. The rest of it is, whatever little cholesterol is left out is carried by HDL, and that is ApoA. So basically if you were to take total cholesterol and remove the ApoA part of it, what you are left with is a very simple way of looking at the total atherogenic lipids. That's what we are doing. When we are looking at non-HDL cholesterol, HDL is made up of ApoA. So you take total cholesterol, remove ApoA, carried cholesterol, what left is ApoB100, ApoB48. And these are the atherogenic lipids. So it's a very simple concept. LDL is one of those, but there are others where lipids are carried, bad lipids are carried by other molecules as well. So instead of going into very expensive tests, doing flow cytometries and maybe some radioimmunoassays or doing some various sophisticated tests, we do a simple test. If the laboratory has not given you this value, you can calculate it yourself. Take total cholesterol minus the HDL and you get non-HDL cholesterol. So, and that is why if you have a non-fasting level, you can straight away calculate non-HDL cholesterol. Most of the laboratories also give it, it's very simple, total minus HDL. So that's a very easy way of estimating cholesterol from here. So why do we need to estimate non-HDL cholesterol? We all know that most of the laboratories give you calculated LDL. They use a formula called the Friedewald's equation. But when the triglycerides are more than 400, calculated LDL is not reliable. In fact, even when the lipids are, the triglycerides are between 200 to 400, many of our Indian patients have. Our typical Indian hyperlipidemia has high TGs, and many of them are in the range of 200. So our Indian studies have found that when the levels are between 200 to 400, calculated LDL is not reliable. By the direct LDL can be done, but it's expensive and not all laboratories. In fact, most of the laboratories don't do direct LDL. So that is why rely on something which is unreliable? Instead of that, look on something which is very easy to calculate, and that is non-HDL cholesterol. And since it is a measure of all the atherogenic lipids, it probably is a better indicator of several large scale studies have proven this hypothesis, that when you look at patients who have, for example, they have reached the LDL goal of say 130 or 100. Amongst these patients, for example, let's take patients who have reached their LDL goal of 100. If you take patients who are at 100 with non-HDL elevated versus those with 100 with non-HDL not elevated, those with non-HDL elevated do much better. Their event rates are much, much lower. That means when you take a gold standard like LDL, there are two types of people with LDL also controlled. Those whose non-HDL is not controlled versus those whose non-HDL is controlled. So in effect, if you look at statistically, you have better predictive value of getting a future event even with your LDL is controlled by looking at the HDL, non-HDL cholesterol. So how do you calculate non-HDL cholesterol? It's very easy. Just add 30 to your LDL level. So if you're targeting LDL at 50, your non-HDL should be 80. If it is more than 80, that means you are not controlled properly. So you need to intensify treatment, maybe add drugs, which Dr. Sharma has already told you. So basically you should aim at getting the number of non-HDL correct. LDL will definitely fall in place. LDL may in fact go lower also, it doesn't matter. So if you want a better prediction of future cardiovascular events, look at the non-HDL cholesterol also, because it's more predictive. So this is basically how the plasma proteins are. So you have all these here. Out of that, when you remove the non-HDL cholesterol, that is, you subtract this cholesterol from this, you get the non-HDL cholesterol, and then that is a measure of all other these, including some amount of LPA. So you don't need to estimate LPA separately. If you have taken non-HDL cholesterol, you get an idea about the LPA cholesterol as well. It is particularly informative in diabetic patients who have higher TG levels, which most of our Indian patients have. Diabetic patients have significantly higher non-HDL as compared to non-diabetics with almost identical LDL levels. Means we all say that diabetics are high risk. Why are they high risk? Even though their LDL is controlled, because their non-HDL is not controlled. And this is a simple measure by which we can estimate further risk stratification in diabetics. A non-HDL also equates to excess ASCVD risk, because it also predicts small dense LDL particles. So small dense LDL particles are difficult to estimate in the laboratory, and they are more atherogenic. So if your non-HDL is elevated, it is also a measure of small dense LDL. So you don't need sophisticated, expensive laboratory tests. Just this one single measure will give you all the lipids involved in atherosclerosis. Just control non-HDL cholesterol, your LDL definitely will get controlled, but you have in fact a better way of predicting future events. So what do guidelines say about non-HDL cholesterol? So basically Indians have high prevalence of T2DM, and that is why, and obesity and metabolic syndrome, all of which are characterized by high triglycerides, and these have the higher incidence of small dense LDL particles. So Lipid Association of India recommends non-HDLC as a co-primary target. In fact, even if you make it the primary target, it should not be a problem. So LAI, our own Indian association, has recommended non-HDL as a co-primary to be addressed with LDL. So bring down the LDL, if non-HDL has fallen, fine. If it has not fallen to that level, bring it down further. So that is how the guidelines are also supporting this. And like I said, the non-HDL level is to be 30 milligrams above the LDL level. So if you are targeting, as Indians, very high risk patients, LDL at 50, then your non-HDL should be 80. If you are targeting LDL at 30, your non-HDL should be 60. If it's higher than 60, that means there are some lipids still left out. So then don't look at the LDL, bring down further by using further medications. So non-HDL, which is equal to total cholesterol minus HDL, is a better predictive of ASCVD events. Even Lipid Association of India recommends this as a co-primary target. And monitoring this level is very easy because you can do it in a non-fasting state. Having addressed non-HDL, does it mean that once you control non-HDL, are you done? Well, unfortunately, no, there is still a residual risk which remains in some individuals. So triglyceride values more than 200 were associated with plaque progression even when LDL and non-HDL were well controlled. So where are we going now? This residual risk is from what is called remnant cholesterol. What is remnant cholesterol? Total cholesterol minus HDL cholesterol minus LDL cholesterol. So what remains is triglyceride rich lipoproteins. Now, one important thing we have to understand is we always look at triglyceride levels. Actually, triglycerides are never carried in the blood like triglycerides. They cannot dissolve in blood, they are fats. What are triglycerides? There are three fatty acids linked to a glycerol molecule, and they are not water soluble. So you cannot carry lipids, triglycerides in the blood. It becomes a suspension. So you can't carry it like that. So there are proteins to which these are attached. So basically when you are looking at triglycerides, you are indirectly estimating those lipoproteins. Because triglycerides are easy to estimate and lipoprotein analysis is difficult, we always look at triglycerides. But the triglycerides are a surrogate marker for the proteins which are being carried. Those proteins carry triglycerides as well as they carry cholesterol as well. So these are what are called triglyceride rich lipoproteins. So when you remove the HDL cholesterol part and the LDL cholesterol part from the total cholesterol, what remains are remnant particles. Remnant particles are also atherogenic. And that is where the importance of triglycerides come. So when you reduce triglycerides, you are not reducing triglycerides, you are reducing the total atherogenic proteins which are being carried. So this is an important concept because we all have confused ideas as to what are triglycerides. Actually, there are no triglycerides existing in the blood that way. So that is why it was realized that when the triglyceride levels are more than 200, in other words, when the levels of those TGRLs are high, as represented by triglycerides, there is still a residual risk. And that is why we need to target that. And that is what we all talk about is triglycerides. And this was proven that when you look at the outcomes for triglycerides in various levels of triglycerides, you can see that when the triglycerides start falling, the outcomes also improve. So the best is as low as possible, and higher triglyceride is worse. So this has been proven that high triglyceride levels are bad and low triglyceride levels are good. So this is what we already discussed. So this is exactly how it is. Most of the triglycerides are carried in chylomicrons, which come from gut. Quite a bit of is manufactured in the liver in the form of VLDL, which the diabetics manufacture in more quantity. Intermediate density is not very important. LDL carries very little triglycerides. HDL has no triglyceride practically. So most of your blood triglycerides will be in chylomicrons or VLDL. Now chylomicrons are interesting molecules. We have all heard that when triglycerides are more than 500 or 1000, you don't get atherosclerotic disease, but you get pancreatitis. The reason is these molecules are so huge that they cannot enter the endothelium. They cannot penetrate into the vessel wall, and that is why they cause more of large vessel, means vessels larger than the capillaries to get blocked because physically. And that is why you don't get too much of atherosclerosis, but you get pancreatitis. So this is the paradox of triglycerides. Very high triglycerides are not associated with that much of atherosclerotic disease, though of course those patients can have high cholesterols, that's a different thing. But per se on their own, you get more of pancreatitis rather than this. But medium levels, say up to 200 to 400, triglycerides are definitely atherogenic and they need to be tackled. So like I said, where do these triglycerides come from? There is an enzyme called the lipoprotein lipase, which splits the triglycerides which are absorbed from the gut. This is split into its components by the LPL, and LPL then reduces the amount of triglycerides in blood by splitting off the triglycerides and taking it away from the circulation. So obviously it is logical to understand that if you have some malfunction of the LPL, the triglyceride levels will rise and there might be accelerated atherosclerosis. So these partially hydrolyzed molecules by the LPL are known as TGRLs or triglyceride rich lipoproteins, and they are the ones which contribute to residual risk of atherosclerosis even when your non-HDL is controlled. TGRLs do not require oxidation. LDL requires oxidation to get inside the endothelium. TGRLs don't require oxidation. They can be straight away picked up and put inside, and they can act as irritants and create inflammation and then plaque progression. So these are even more dangerous than LDL cholesterol. They can be prothrombotic as well because they have some mimicry like molecules with the plasmin, and that is why they can produce thrombotic events also. VLDL, which is manufactured in the liver, which is also a TGRL, can also penetrate directly into the intima. So you have these remnant particles and you have VLDLs, which can both enter the vessel wall and produce atherosclerotic plaques. So it's easy to understand that those things which reduce the LPL activity will cause more remnant particles, more triglyceride-rich particles, that is ApoC3, the ANG-plate3 and 4. These are some enzymes which reduce the activity of LPL. And that is why increase the number of TGRLs. While ApoC2 and ApoC5 both increase the LPL activity, they reduce the TGRLs and they are protective. So there are two implications to this. First of all, certain genetic diseases which have these molecules circulating can either have an increased incidence or a lower incidence. Also, it gives us an opportunity to manipulate these pharmacologically. So if you were to reduce the levels of ApoC3 or ANG-plate3 and 4, your triglycerides will drop. And this is exactly how the future genetic manipulations are going to happen by various molecules which we call as serans. Dr. Gupta mentioned about that, Dr. Sharma mentioned about that once. So these serans, and these provide us with great opportunity to genetically manipulate using enzyme and genes. So this picture will give you an idea as to how future is going to be and how we will be manipulating triglycerides. How do we control hypertriglyceridemia? Body weight control is extremely effective. Restrict carbohydrates, alcohol, and saturated fats. Medications can be considered when patients do not respond adequately to the measures. The most important medication which is now available is icosapentol, which is a fish oil supplement, 1000 milligrams twice a day, or actually ideally 2000 milligrams twice a day. Significantly reduces, and it has been proven in the trial as well, reduced trial. Unfortunately, fibrates are the ones which are more commonly used. We have no official evidence that fibrates reduce events. They reduce triglycerides, but we don't know whether they reduce events or not. Well, logically speaking, probably they do, but we don't have evidence. So we continue to use it, but I would recommend that we should stop this practice of randomly writing atorvastatin with fenofibrate. Don't do that, because unless there is an indication, intervene for triglycerides with accepted drugs like icosapentol. Initially it was only one person, now there are many companies which have come in. So they can be used, and I think there are some vegetable sources also, so that should not be a problem with patients who say that we don't take fish oil supplements. So I think that should not be a problem because they are effective drugs and they have been proven in trials. Of course, some of the newer therapies are to manipulate the ApoC3 gene, and by reducing the ApoC3 levels, you can reduce the TGRLs. And of course, antisense oligonucleotides, like I said, the serans, they can also reduce the triglycerides by almost 70%. European Society recommends that you should estimate these TGRLs in non-fasting state. The reason is, most of us are in non-fasting state for a long time. The fasting state is only for a short time. So even though the laboratories tell you that the triglycerides are high, but that is what is affecting me. So I should look at non-fasting state and get my risk factors done rather than producing an unphysiological state of fasting which never happens and estimating the levels which are actually not representative. So in fact, like we look for postprandial glucose or post-glucose levels of glucose, there is a triglyceride surge And people are trying to correlate with that as to how much is the surge. We don't have the numbers, but the point is that look at non-fasting state. I think from this conference, if you go on with the idea of estimating lipids in non-fasting state, I think a lot of good has been done. So we should pay more attention to triglycerides in addition to LDL cholesterol to reduce ASCVD events further. And the drug to be used after lifestyle measures is icosapentol. 4 grams preferably, but start with 2 grams per day. Finally, we come to this complex question as to what about HDL? So about 10 years back, everybody was hyping about HDL. Observational studies showed that consistent inverse relationship between baseline HDL-C cholesterol and cardiovascular risk. I mean, higher the HDL, lower the cardiovascular risk, and lower the HDL, higher the cardiovascular risk. It was always known in observational studies that it was kind of a contributor to ASCVD risk, and less than 40 milligrams in males and less than 50 milligrams in females was supposed to be atherogenic. HDL works through removing fat from the peripheral tissues, taking it to liver and throwing it out. So that is how HDL works. It picks up, it's called a scavenger. Picks up the LDL, bad cholesterol molecules from the tissues, maybe from the blood vessels as well, takes it to the liver and gets it out. So reverse cholesterol transport. It is supposed to be anti-inflammatory and antithrombotic. 1 milligram increase in HDL, and there is a 3 to 4% risk in decrease in the risk of mortality. And low HDL or dysfunctional HDL is associated with increased events. So these are all observations. Now, there is something in biology called epiphenomenon. Epiphenomenon are two phenomena which are not linked, but they go together. So when the future trial, some of the trials did show that by using niacin and certain other simvastatin, etc. combinations, you could raise the HDL and improve the benefits. But remember, these are old trials, and some of these trials were done without statins. So these drugs like niacin also reduce LDL cholesterol. So we did not really know. We thought the benefit was because of HDL rise, but it was probably, subsequently we realized that it was something else that was improving the results and not raising the HDL. Because there was a trial which said aim high trial, meaning it aimed HDL to be at a higher level, and that is what it was. It was simvastatin alone with simvastatin plus niacin. And the endpoints were cardiovascular death, non-fatal MI strokes, and acute coronary syndromes. So in this trial, what we had was, there was no improvement in cardiovascular outcomes. The major atherosclerotic coronary events did not reduce despite favorable rise in HDL and fall in triglycerides. And the second study called the HPS2, which used niacin with laropiprant, also showed no benefits. Finally, a major drug class came that was called the CETP inhibitors. Torcetrapib was the drug which was used. This drug increased HDL levels by 70%. Most of the patients developed HDL levels of 100 from whatever levels they had. But the trial had to be terminated early because there was increased mortality. And this was because of increase in blood pressure and increased aldosterone levels. So though HDL rose to tremendously high levels, it was not protective. In fact, it turned out to be bad, detrimental. There were many such drugs, deltatrapib and anacetrapib. All of these drugs are now abandoned, and they are no longer being used for raising HDL. Another study, CAN-HEART study and the stroke study also showed no benefits of raising HDL. Another nail in the HDL coffin was by genetic studies. These studies are not done by us, they are done by nature. There are populations who have very low HDL, practically non-detectable. in Tangier disease, but they are not associated with atherosclerotic disease. So that proves that HDL seems to play not a very important role on its own. And like we say, everything in moderation. So now we are in fact proposing a situation where very high HDL cholesterols are detrimental. So don't do that. Very low HDL cholesterols probably are detrimental. So somewhere in between the levels that we have are probably the best. As of today, there is no point in targeting therapies to raise HDL because we have no evidence. And why does this happen? Because HDL is not a single molecule. HDL has multiple molecules under the guise of one single name, that is HDL. So if you look at HDL2, it is a protective molecule. But HDL3 is not a protective molecule. And when your laboratory gives you the level, it gives you a combined level. So there would be drugs which would be raising HDL2, we don't have them. There are no trials which have shown specifically raising HDL2 giving protection. So as of today, with our limitations, I'm not saying that in future there would not be a better drug. As of today, let's not waste time trying to raise HDL. Let's concentrate on LDL, non-HDL cholesterol, triglycerides, and of course controlling other things like blood pressure and diabetes and things like that. So don't get too much worried about the HDL levels as of today. So as of today, because of the variable nature of HDL, no drug is available which will give us benefits. So let's not worry about it. Actually, there is an observation that when you have low HDL, you have high triglycerides. So maybe what we are doing is manipulating the triglycerides where the HDL starts rising because of a relationship between them. So maybe these HDL is a bystander and the real culprit is triglycerides. So this is what our current understanding is coming to, and this is where the manipulation of those genes like ApoC3, which reduce the triglyceride, is coming into picture. Indirectly they raise HDL also. So maybe the HDL is not the primary target, but the other primary targets are there which as a consequence raise HDL. So this is where we stand today. So target LDL, non-HDL, triglycerides, and forget the HDL. Thank you. Yeah.
Also, because you have written rightly that you have to give up to 3 grams. You know, you have to start incrementally increasing 250 milligrams, and then over 6 to 8 weeks, you go to 2.5 to 3 grams, as you have rightly shown. So, is it still available, Nialip of Dr. Reddy?
Nialip is not available, but sir, some other unknown laboratories are available. But I don't know whether we should use them because, see, the evidence is against it. You may raise HDL, but you don't know what kind of HDL you are raising. So that's why the trials like torcetrapib, which was a very promising drug, which raised HDL to more than 100 milligram per DL. But in fact, there were more cardiovascular events. So I don't think we should target this. Probably the only reason to use niacin would be to probably bring down LPA. Because apart from PCSK9 inhibitors, there are no drugs for LPA. There is a drug in the pipeline, which is again a CERAN, which was recently presented in the ESC. So that is specifically targeting LPA, but it's in phase 3 trials just now. Long way to go. So only reason to use niacin would be to try and bring down LPA if you can. I don't think it does. Even PCSK9 inhibitors, they do bring it down, but not that much. So if you have an 100 LPA, it comes down to something like 70 or something. But that would be probably the only reason why I would use
tablet Nialip, is it still available?
No,
Dr.
it's not
Reddy?
available.
Not available.
Not available. Some other companies are available.
So what about the saroglitazole?
Sorry?
Saroglitazole was the brand.
Saroglitazole. Yes.
Brand was the Lipizim.
Yes. Lipaglyn is the drug, and there are some other companies also which have now come out.
patient, it really...
Yes, yeah, it's a good drug, but unfortunately being an Indian drug, it is not used in any of the trials. But I do use it. It's a good drug.
You're using it?
Yes, I use it, and even I use it even in non-diabetics also. Yeah, it's not mentioned because this was guideline based.
Okay.
Sir, what is the main culprit for causing the CVA and MI, TG or LDL?
LDL. The answer is LDL. There is no question. LDL or non-HDL cholesterol means atherogenic. But secondary target is TG.
Sir, difference in...
Yeah. Don't ask for fasting sample. There is no need. If you are looking for predicting cardiovascular events, non-fasting cholesterol. See, they are pathologists. They don't treat patients here, so forget it. Take-home message is non-fasting levels. Yeah, you don't ask your patient to fast. The LDL levels don't change, and the triglyceride levels, higher they are, the worse they are. So you look at the highest levels. Thank you. Yeah. Not required.
Friends, Dr. Darshan Jhala sir is with us since the beginning of the CardioCon. That means from the first CardioCon when we started. So he is constantly with us. So please give a big round of applause. And for the felicitation, may I call upon AMA President for salt distribution and others. Moria. Moving to our next topic. Our next topic is latest advances in the field of interventional cardiology. For the same, the lecture is going to give by Dr. Ghanshyam Kane. Sir, he is one of the best cardiologists in Mumbai and he has experience of 37 years. Sir has completed his MBBS MD cardiology from Goa Medical College, Panji. Sir is very familiar with stenting, rotabular procedures, atherectomies and balloon valvoplasties. Over the years, he has worked on coronary interventions with several international experts from USA, France, Germany, Italy, and England. Sir, please join us. Dr. Ghanshyam Kane, sir.
दोन्ही लाव ना कॉलर माइक पण लाव नाही 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 बिलकुल नाही I'm comfortable now. Huh? These are slides and this is point. Okay.
Good morning, friends. It's a pleasure to be here with all of you in the morning, and I have quite a few known faces, so it gives me real happiness to be here. But at the entrance, I got a little mesmerized because I'm coming for Ratnaparke's meeting for the first time, and I said, "Wow, what a number of people. You rarely see such great number of people attending meetings like this. So it's a real pleasure. So my topic for the day is recent advances in interventional cardiology, and we can actually go on speaking for hours together on this topic because the breakneck speed with which advances occur in every field, and cardiology is obviously the leader. So it is very, very difficult to finish off all the advances. So I'm going to concentrate on some of the advances which are in major use in practice today, which help us to give better cardiac care to our patients, and mention in brief some of the other things which are likely to come in the future in India and in the world, so that we have an overview of where we stand today and where we look forward to tomorrow. So, where's my slide coming there? Okay, yeah. So I passed my DM cardiology in 1986, and the interventional cardiology started in India in 1987. So I was lucky to be starting with the birth of interventional cardiology in India. So I have seen almost all the things that have happened in India in interventional cardiology. So that's a great thing. And we were the first ones at Sion Hospital to do angiography in acute MI when Dr. Gandhi was the head, where nobody used to dare to do an angiography in acute MI at that time. And with A.B. Mehta as the head, I was involved in the largest trial of primary angioplasty in acute MI in the whole country. And we have presented a series of 600 primary angioplasties in our CSI conference way back in the 90s. So that was one of the major advances which I was exposed to. However, the whole story started with Mr. Andreas Grunzig, who was a German cardiologist who always dreamt. He had worked with people who had done peripheral angioplasties with catheters and some balloons. So he had the dream and the vision to think of that how can we do this in coronaries, and how can we relieve patients' angina or chest pain in coronaries. So he did the first one in 1977 in a patient who was an engineer who had intractable chest pain, unstable angina, and he had a single vessel disease, proximal LAD. So he was very careful in his endeavors, and he and his wife, who was a nurse, she helped him. You can see this was a part of their hall or the kitchen where they were putting the balloon in process and the wire with the balloon. So he invented the balloon, which was the primitive one. Today we say it is primitive, but that's how he could do only proximal stenosis. And he was so careful that he declared that you have to do this angioplasty only in very, very selected patients. This is not to be used in everybody. So, and another important thing about him was he was very generous. He wanted to spread this to all the people around the world. So he is the first one to start teaching courses in interventional cardiology. Nobody before him. So you can see some of the giants who came after him were his sort of students or were his companions who were learning from him how to do, and then he spread it all over the world. And 10 years later, it also came to India. So that's sort of a, see, we stand today where we are because we stand on the shoulders of these giants. That's a saying which every time we repeat, and it is absolutely true, because unless somebody has done so much of work, the progress cannot come for the later years. And we should not forget people before Andreas Grunzig from whom he was impressed, the people who started coronary angiography, people who taught us how to puncture the femoral artery with a needle. So all these were advances. People who did transluminal dilatation in the peripheral arteries, it always started like that. And Grunzig worked with some of these people like Charles Dotter or Zittler, and he came up with this idea. The next person whom I would like to mention is Dr. Geoffrey Husler. He was again ahead of his time. When Grunzig was trying to promote his technique in very, very selected people, he, despite having learned from Grunzig, always thought further, and he started doing complex angioplasty. Initially, there was a friction between these two, but subsequently the advances in technology were so fast that we could do all this very easily. So Geoffrey Husler is credited, to the best of my understanding, with starting the angioplasty in an acute MI. Forget about angioplasty. Angiography in acute MI was also a big thing at that time. So he showed first that you can do an angioplasty in an acute MI, and I have been lucky to attend one of his courses in 1980s, 88, 89. So all these people are no more there, but we stand on their shoulders and we did whatever we are. So just before going into this, so we know that it's a balloon angioplasty. Initially it was only balloon angioplasty, and now we have newer and newer balloons. I just want to go on a little bit of this. We have something called as a OP and NC, or a very, very high pressure balloon, because we realized soon that you cannot get proper expansion of our stents without high pressure balloons. So this is one thing which I would like to mention, which gives us pressures. Normally we use 10 to 14 to 16 to 20 atmospheres. Sometimes you need this to expand it, and this is one of the balloons that we can use for that. Then we have a recent advance in which we use what is called as a cutting balloon. Normally we had a balloon which is made of only polyethylene or polyvinyl chloride, but the plaques which are sometimes hard, which are fibrosed, and with minimal calcium, you can cut the tissue with a cutting balloon. So this was an advance in which you can create a cut and then subsequently expand with our normal balloons and get a very good result. The whole idea is the stent. I'm not going to talk much about the stents because everybody knows about the stents, but the stents work for a long time only if you expand them properly and only if they oppose very well to the endothelium. So to get that, we require all these accessories, and I'll show you all the things which are used today. By and large, 90% of them are finally to get you to a stage where you can stent properly, accurately, size it well, put it to the length that you want, and expand and oppose it to the wall so that you get the same lumen as a normal arterial lumen. Suppose the artery is 3 millimeters, your stent has to expand to 3 millimeters, whether it is a fibrous lesion, whether it's a calcific lesion, whether it is what is called as an undilatable lesion, where you require other methodologies that we use today to understand and then apply them as and when we need them. So one of the major advances which is likely to stay and which is going to be the mainstay in many of the cases in the future is what is called as a drug-eluting balloon or a drug-coated balloon. We have realized time and again, if we put stents in very small arteries, they do not work for a long time. Stent works the best when the artery is 2.75 and above. If it is below that, the chances of restenosis are higher simply because the lumen of the artery is small, and some cholesterol is always going to get deposited despite stenting. So nowadays we have smaller vessels, we bifurcation, where we do not want to put stent because we are aware that the chances of restenosis are higher than the normal stent which we put in proximal arteries. We now have what are called as drug-eluting balloons. They have been developed over a period of time. They have been there for a long time, but the concept is now getting formalized and we are able to use it in clinical practice with benefits. So it's a drug, it's the same drug which is on the stent. You don't want stent. So you coat the same drug on the balloon. That itself took so many years because the balloon, the drug is to get washed out. So they have different technologies so that the drug will remain at least for 3 to 6 months on the balloon. And then once you dilate the artery to the size of the artery, like say 2.5, then you put this drug over this balloon and deliver it there. And that has been giving good results with the newer drug-eluting balloons that we have. And this is the technique that is used. So that's coming in a big way, especially in vessels where we do not like to stent. We can go into that, which are the vessels where we do not like to stent, but especially smaller vessel, diffuse disease, distal vessels. So previously we used to not stent them and leave them like that, or they used to go for surgery, where surgery itself is very difficult because you have to cut open the artery and remove all the plaque to put a graft. So that was the problem. So this is some of the results that we have seen, how good it gives with this. Now, I would venture into something which Grunzig thought at that time. When we dilated the arteries, he realized that what we are correcting is the anatomy. Suppose you have a stenosis which looks like 50 to 70%. Is this really producing ischemia? Because we have realized over a period of time that sometimes the stenting may be done in an artery which is borderline, and we may not be sure, but we still do it because there is nothing else to do. So we were correcting only anatomy. So now we have something called as physiology in the artery, where we do this FFR or fractional flow reserve, we call it, wherein we can realize whether the particular block which we are not very sure, is it 50%, is it 70%? Many times it happens because angiography, which is our gold standard today, is a two-dimensional view. It does not give you a three-dimensional view. So many times in eccentric lesions, we are not very sure. So we obviously do stress tests, we do thallium, so those tests. But suppose somebody has come on the angiography table and now you want to make a decision. Should I do an angioplasty on him or should I not do? Am I doing the right thing for him or am I not doing the right thing? So you can do this on the angiography table and convince yourself that this patient has physiologically significant block, not only anatomical but physiological. And for that you have to do this FFR. So it is a maximum achievable blood flow in a stenotic artery divided by the maximum flow in the same artery without stenosis. Don't go into the details. What we basically do now, it gets correlated with the pressures. So Grunzig was with the idea, we could take only proximal pressures. Then you have a block, you don't know what is the pressure distally. Now you can measure the pressure on the guide wire itself. So you can measure the pressure distally, you can measure the pressure proximally, and the ratio gives you the FFR, and an FFR of 0.80 means 80% flow is going distally. So you don't have to do anything. 80% is good enough to do nothing and do preventive measures so that that plaque or the block can maybe reduce further and patient can do without an angioplasty. But if the FFR is below 80, then you know that this is a physiologically significant block and this needs to be opened. So this concept has been taken in a big way, and whenever we need it, we do employ this, and this is actually by guidelines has become standard now. So whenever you face a problem and you are not in a dilemma whether you should do or not, then you should be doing an FFR in that patient, in that particular lesion, and make a decision which is more accepted in our cardiological practice. Next comes is all this time when we were doing angioplasty, it was a visual. We see an artery block and then we think this artery is 3 millimeter, which by and large works. That's how we do it all this time. But sometimes you get fooled. And why do we get fooled? Because suppose you have diffuse disease in an artery, then you cannot determine what is the exact size of this artery. Because everywhere there is plaque. If the plaque is only in one portion and you have a tight block and the rest of the things are normal, then you can determine. But suppose there is a diffuse disease, then how do we do this? So nowadays we talk of what is called as a precision angioplasty. Means before we start with the balloon and the stand, we determine what is the type of the plaque that we are having. Is it soft plaque which will get relieved with the balloon and then you put a stand? Does it require a cutting balloon as I showed you, or does it require rotablator? We have so many methodologies available today and they are to be used in the right patient. If you have heavy calcium, you are sure you are not going to be able to dilate it whatever you do. So you need to shave off that calcium. So you have rotablator, you have something called as intravascular lithotripsy, like how you have lithotripsy in the stone, we have it in the coronary artery. So those are the advances. But before we determine that, we have to know what it is. So imaging is coming in a big way. We are using it in everyday practice today, though because of the cost we use it in selected patients where we want it, like left main, bifurcation, total occlusion. These are the places we definitely use imaging by and large. Other patients also, there are proponents who say every patient should be imaged so that you give him the best. But most of the countries, even in the best of the places, they cannot afford it because it's costly. So you have to selectively reserve it. And every hospital should have it, because if you have a problem while doing what you thought did not require imaging, you should be able to image that patient at that time also and do the needful. So what are the imaging things that we have? We have multimodality imaging today. You have the most commonest we use is what is called as optical coherence tomography or OCT, and the other one is, do we have a timer, because I won't know where I'm going. Okay, so you have OCT and IVUS, which are the most important we use today, and there are conditions. Now let me tell you something. All the things that we have today have not been able to identify non-invasively which is the plaque which is likely to give rupture. And that is the reason why we have not been able to prevent heart attacks which come up suddenly. We have been able to get patients who have angina on walking, angina on exercise. Those patients come to you. But we know all our youngsters, it's a menace today in India. We have 50% youngsters who get heart attacks, and they are absolutely well 1 minute prior to getting that chest pain and the MI. So this is because it has been identified with invasive techniques like OCT and this, that you have something called as a vulnerable plaque, which can rupture any time. Now the whole research is going on to identify that. These imaging techniques can identify vulnerable plaques, but it is an invasive technique. So our efforts are going on in the research world to find out non-invasive ways of identifying it. So far we have not been that successful. So that's why we will not be able to prevent these sudden heart attacks which occur because of plaques which are vulnerable. So that's going to be the next one. So imaging is very important, and vulnerable plaques basically depend upon the lipid content, which can be identified by a test called as NIRS spectrophotometry. It's an invasive technique. Now people are working on non-invasive techniques. So lipid plaques or plaques with a very thin endothelium, that's called as TICFA or thin cap fibroathyroma. These are the ones which are likely to rupture. We have seen that now in our patients when we do OCT or IVUS or NIRS, but we have not been able to do that in an OPD basis to find out who is a likely person. So that's the future. So OCT gives you all the 3 layers of the artery in vision. You can see that, you can see the endothelium, you can see the media, intima and adventitia. Don't bother about it, but just understand that this is the technique which is used. And the next one I'll show you, when you implant a stent, you can literally see here, these are the stent struts which are marked out with arrows, that they are touching the endothelium, and that's why your stent is well expanded. So in stent we have two things which we want to know. One is our stent well expanded? And second thing is our stent well apposed? It should touch to the endothelium, then only the endothelium will grow over it, and the stent will become a part of normal body. If the stent does not touch the endothelium, then it is very less likely that the endothelium can grow over it. So if you can do an imaging, you are 100% sure. If you feel that the stent is not apposed, you go with a higher pressure or you go with a higher sized balloon, get it apposed well, then your chances of the stent working for a much longer time are much better, because you have literally seen it work there. So that's why this OCT and all are useful. It also helps you to identify. It's very easy now. See, I showed you that endothelium and all. Now here is a crack in the endothelium. This one. So this is called dissection. So this happens sometimes when you do angioplasty. So you have to be sure that you have covered all dissection. All dissections cannot be identified by angiography sometimes, unless you are very careful, you take multiple views and all. So these technologies are helping us to do things in a much better way. Just to show you, it also helps us to identify thrombi in the coronary artery. You can see that there is a red thrombus and there is a white thrombus. There's a way to distinguish. That's not important for all of you, but that's more important for us. This is the most important slide as far as OCT is concerned. The reason for that is, if we do OCT in an acute MI patient, you basically identify 2 types of things. There are 3 types of things, but basically 2 types of things. One is this working? Is the dissection which this arrow shows, and the other is called as just a thrombus without any plaque rupture. You can't see any rupture there, whereas in the first one, you can see the rupture here. I don't know, this one. Here you just see good endothelium all over, but there is a thrombus. So there are 2 differentiations here which are coming up in a big way, what is called as a plaque erosion and plaque rupture. If you have plaque rupture, you have to put a stent, because there is a cavity with thrombus will remain and give embolization. If you have a plaque erosion, it is now thought of that you can treat these patients medically without putting a stent. But how do we know this when we see it? So unless you do an OCT, it's not going to be seen. So these are the advantages of all these technologies. So then next comes the intravascular ultrasound. So this also is a competitor to OCT, and this also is very important. It has its own advantages over OCT, and OCT has its own advantages over IVUS. So it gives you all this. It gives you the size of the artery, it gives you the size of the adventitia, it gives you the size of the plaque and the consistency of the plaque. Is it calcific? Does it require rotablator? Does it require something else? So all these things are seen on it, and you can make out types of plaque. Calcific plaque generally requires something more. Fibrous plaque can be done with a balloon. Fibrofatty plaque, chances of distal embolization are higher. Something like that, yeah. So just to give you an idea overall, obviously this is not that easy. And you can see here on IVUS the calcium. You can see that 80 degrees calcium in the first slide here. Okay. And you can also see in the slide B there is a calcium all around. Now if you have 360 degrees of calcium, no balloon is likely to work on it unless the calcium is very thin. IVUS does not give you the thickness. So you are blind still if you do IVUS. So if you do, and this is a differentiation between OCT and IVUS, the OCT gives you the exact thickness of the calcium. So you know that I require something more than a balloon to start with, and only then I can put a stent. Otherwise, if you put a stent and it is not expanded well, you are in trouble. In the sense, that stent is going to get closed sooner or later, as maybe in few days, few months, or usually it happens within a month. So these technologies help you to make out that you require this. And you can see here, IVUS shows you the calcium, because calcium in IVUS does not allow the sound, ultrasound to pass through. So you cannot see beyond the calcium in IVUS. Whereas OCT is a light-based technology, it allows you to have the things behind the calcium. So you can literally see how thick is the calcium. See, it is marked out here, the structures beyond that yellow thing is all calcium, and it's very thick. So you know that you require something more, and I'm going to show you the thing which is in vogue today. And this is just to show you why OCT shows you much more than this. It all depends upon the resolution. Now if you can see here, the CTs, okay, the resolution is not in here. Okay. So OCT has a resolution of 10 microns, means if two things are placed at 10 micrometer distance, you can say that these are two different things. Whereas IVUS has 100 microns, angiography has 200 microns, CT angiography is 600 microns. So you can make out from 10 to 600. So OCT is the best to show you the thing. And one of the advances that we have previously, whenever we see calcium, is to use a rotablator. And many times it works most of the time, but some patients it did not work. And why it did not work, we didn't know it at that time. Because the calcium was so thick and so broad that rotablator can take off only the internal calcium, but the medial calcium and all was not going. So you have a new technology like what we use in kidney stones and all, what is called as intravascular lithotripsy. And this has a unique mechanism in which it sends sonic waves which can go up to the adventitia, so it can crack the calcium in situ. It does not produce any perforation, and this has been proved beyond doubt now. So here is a patient which I can show you. There is a lot of calcium which you can see on OCT and angiography in the first. Second is IVL 3.5 has been used, so you can see those pointers which show you the cracks which occur because of IVL. And once the cracks occur in a calcium, it expands very well. And lastly, third one, you see the stent being put and well expanded. What I was telling you is what we want is, that is good, all these things are good. But nowadays the people are working on non-invasive techniques of identifying this. And one of the things which is going to come in the next future, recent future, is non-invasive FFR. When you do a CT in a patient presenting with chest pain in the casualty, you will get a fair idea where the plaque is. And if you can also do by CT, you can do FFR, you will also know whether this is causing significant ischemia. So then you take the patient to cath lab. So something like that is coming up, and we look forward to it so that we can manage our patients much better and select our patients for angiography much better. Having said that, this is about coronary interventions. Everybody knows valvular interventions are come in a big way, and TAVR or transcutaneous aortic valve replacement is coming in a big way. And it started in 1989 with this gentleman from Netherlands who put a stent-like structure in the aorta with a Teflon in it, and he showed that it works in the aortic position. And the first human thing was done by Alain Cribier in 2002. So 2002 is the birth of TAVR or valvular interventions. 1977 was the birth of coronary angioplasty. So it took almost that many years. So he did it in this patient who was almost dying, and he had no choice. So he accepted the procedure. The patient has to give a consent, and he did well. He lived for some months, but that was the beginning of the today what we are standing on this. So now you can take out this patient. This is a 100-year-old, still enjoying her life, still is good enough, though she is frail, she has lots of comorbidities, she has undergone prior CABG, COPD, peripheral chronic AF, but still has the zeal to life. So these are the patients whom the surgeon would not want to touch. They are called inoperable patients. They were the patients taken up. So this technology has been studied in the best possible way in the world. No other technology has been studied in this ideal way. So the first trial was in inoperable patients, so no question of any comparison. They did well. So the next trial was in patients who are very high risk. Surgeon takes it but tells you that you may die on the table. So those were the next patients taken. There also this technology survived and fared well. The next thing was high risk patients where surgery also would be good. So should we do this or surgery? There also this technology showed almost equivalent results. And the last thing it was studied was in low risk patients, because a lot of aortic stenosis patients are young. There also the technology has succeeded. However, we believe that in patients below 65, surgery is the treatment of choice simply because this technology is new, not because it's not good, and we do not have results beyond 10 years. So we don't know what will happen at 15 years. So we want to wait and see first the technology works well so that it can be used in younger and younger patients. Anybody above 65, it's a heart team approach where you discuss with the patient and the family and decide what they want, what are the pros and cons, so that has to be explained. So all these things have to be understood. So it's a very exciting development, and a number of companies, you can see this is just a snapshot of some of the valves which are available. They are much more than what I can show you here. So the technology advances at breakneck speed, at the speed of light, I would say. We just can't keep in touch with all the advances that are occurring. So these are becoming specialized field where some people get more trained and they do this. So it's like that. So you also have patients have severe MR, they are not fit for surgery. You have what is called as a mitra clip which can be put. And this was the first surgery done by Carpentier, who was the pioneer of mitral regurgitation surgery. So he had devised this, that you put a stitch in between the two leaflets of the mitral valve so that you reduce the opening of the mitral valve. So that technology has come in without surgery now. It is working in selected patients. It's not for everybody. So this is how it is done. Another important thing is we see a lot of patients of atrial fibrillation and they develop stroke, and many of them are not suitable for anticoagulation because they're old, 80, 85, and then still living, but they die of stroke because you have not given them anticoagulation. So we now have a concept that we know that 90% of these clots are formed in the left atrial appendage. So technology has evolved how to close this left atrial appendage, so you reduce that chances to zero. So this is being now very well used in Western countries. It is coming up in our country too, and it will be established as a procedure in the near future. So having said that, we talk all about interventions, and we have, I want to just give you a glimpse with one slide of what is the future. So there are so many things which are coming up, something called as 3D printing, nanotechnology, tissue engineering, where we can do biological valves which will last for your life. This technology is already around the corner, where you will put a valve, or surgeon or the cardiologist will put that, and the valve will not degenerate. So that is called biological tissue engineering. And we must, as cardiologists, genomics is coming in a big way, which will help us to treat many of these diseases. And we should not forget preventive aspects of cardiology. It's not only invasive. So there is a lot of things, artificial intelligence, sensors, people who have unconsciousness or vague symptoms, you can put a sensor. It used to be invasive sensors. Now you can just put a patch which will remain for months together, and it will pick up all the signals. So we will be also helping patients if you have chest pain, they can transmit their ECG to the center on a watch that they wear. So these are the advances which are going to help us to do things in a much better way. Thank you very much for your attention. Huh? Pardon, sir? IVL? Yeah. So laser also, I forgot to mention that. Laser also is coming up in a big way, but everybody thinks laser can do anything and everything. That's not so. It is only used in patients with lot of thrombus which you cannot clear with other technologies. So thrombus can be, and it is used in, at the moment it is used in patients with chronic total occlusions where your wire passes, but nothing can enter that because it is hard. So you just make a slight hole with a 0.9 millimeter laser and then you go with the technology. It is not a technology to be used in everyday practice. It is to be used in specific.
Sir, what is the normal value of FFR and what do you mean by IFR?
Good. So FFR was the first thing which came. It has been well proved. So it requires adenosine to be injected and you have to do maximum vasodilatation. That's the ideal thing to be done. IFR came in the field because it's an instantaneous FFR basically. So you don't require to inject this and it's based on just the pressure differences. So you don't produce any hyperemia. So it is at rest. So there are a lot of controversies which is better. So both are equally good. So sometimes people have done both. And what we feel and the experts who done both feel, if one of these tests is abnormal, you should go ahead and do the angioplasty.
What is the benefit of IVL lithotripsy?
Yeah, this is the one. I showed you that, na?
Yes.
So if you have all circumferential calcium in the media and not only in the intima, which you can clear with rotablator, you have to use IVL, otherwise you won't be able to complete that procedure.
What is the normal value of FFR?
80.8.
Thank you, sir.
Yeah. Yes. Yes, calcium score is done by the CT. So the problem is if the calcium score is higher than 100, generally the CT people only tell you that this CT scan is not going to help you because the calcium does not allow you to see the underlying plaque. So if the calcium score is higher, most of the centers don't do the CT. So because you cannot identify, and even if they do it for whatever reasons they are doing it, the reasons you will and I will not know, they will know it. But they mention there, kindly confirm this with angiography because they also know that it cannot show you everything. Sorry. I'll come here.
Thank you very much, sir, for the informative lecture. Now I make call upon AMA President, APPA President, MCVP President, Dr. Smriti Ratnaparkhi ma'am and Dr. GPR sir for the felicitation. APPA President Dr. Ashish Deshmukh sir, AMA President Dr. Anurag Bhatte sir, MCVP President Dr. Ram Chavan sir. Please give a big round of applause. Moria. I am requesting all of you to please be seated as there is going to be a bumper draw worth 7,000 rupees and it will be applicable for the persons who will be present in this hall. So all are requested to be present in the hall. And the bumper draw is by the auspicious hands of Dr. Ghanshyam Kane sir.
Hello. Okay, you are very patient audience. And I know that according to the fourth Newton's law, cerebral perfusion is inversely proportional to the sacral pressure. I will give 1 minute to think over it. Newton's laws are not so easy to understand. The cerebral perfusion is inversely proportional with the sacral pressure. तो 3 घंटे से या 2 घंटे से आप बैठे हो तो नेचुरली सेरेब्रल परफ्यूजन कम हुआ है तो your grasping capacity might have been reduced. So secondly, those who are sitting constantly here, they should be benefited. So we will have a bumper lucky draw. We have lucky draw, and those who are sitting here only will get the lucky draws. Okay, so your patients should be paid properly, right? So the lucky draws will be by the auspicious hands of our professor, one of my teacher, Dr. G.R. Kane sir.
Please give a big round of applause.
A.R.S.S. Shah. Aarti Shah. Mobile number last 3 digit 966. Aarti Shah.
I am again requesting, please
Those who
be
are present
seated.
will get the things.
Those who are present in the hall, they are.
Upar rakho. And this is
The bumper draw.
This is bumper draw. Every second lecture, every third lecture, you will get the bumper draw. Okay? So be in the hall. Aarti Shah.
Congratulations, Dr. Aarti Shah, for winning the bumper draw.
Now there will be lucky draw for a smaller gifts, right? Hi. Okay. Okay. किसको चाहिए? प्रवीण छाजेड, डॉक्टर प्रवीण छाजेड. डॉक्टर कविता शाह. डॉक्टर डी एम गांधी. नीचे से निकाल रहा हूं, सो पहले जो आए थे उनका. हीना जियंदानी. Yeah, you go. Okay. Dr. Ashish Deshmukh, President of Andheri Parla Physicians, will go down and give the gift. Hina Jiandani. Dr. Praveen, something like a doctor's handwriting. 9820153978. Ticket number 373. Mr. Praveen, something CH, S, E, I don't know. Real doctor. मैं नीचे दबा रहा, तू नीचे नीचे रहा और तो ऊपर लेना. ओके, मैं नीचे से ले रहा हूं सो दैट जो पहले आए दे शुड नॉट फील कि अपनों को नहीं मिल रहा है. सबसे नीचे से ले रहा हूं मैं. क्या बात है, तू फार्मासिस्ट है क्या? फार्मासिस्ट क्या ओनली रीड द थिंग्स. शेट्टी, प्रवीण शेट्टी है? नहीं, ठीक है. डॉक्टर कल्पना भावे. जो लोग अब्सेंट रहते हैं ना, बाकी लोगों की चेहरे पे खुशी की लहर आती है. डॉक्टर कलसी सर, किधर है कलसी साहब? अरे आ गया आ गया. ठीक है, फेंको. हाँ, अर्ली बर्ड में भी है. डॉक्टर जयंती लुनिया. डॉक्टर जयंती लुनिया. जयंती की जयंती? जयंती। हमको लगा कोई लड़की होंगी उस दिन। तो सब लोग डाउटफुल नजर से देख रहे थे आपको। I know. नाव नहीं है। 835। नंबर पढ़ना थोड़ा मटके जैसा लग रहा है मेरे को। जब जो गांव वाले
कूपन नंबर 835
वैसा नंबर आता था ना।
is the person available in hall?
बहुत खेला है शायद। नहीं ना? We have enough of lucky draws, don't worry. Dr. Dayaram Bhanushali. सर ज्यादा खुशी मत हो जाओ, बम्पर ड्रॉ गया आपका। नेक्स्ट इसमें भी नहीं लगने वाला अभी। कुछ तो मिला। आई नो यू आर। क्या बात है, वेरी गुड। सर इज अ घाटकोर मेडिकल एसोसिएशन प्रेसिडेंट। गिव अ बिग
Please give a big round of applause to Dr. Bhanushali sir.
And he was quite conscious, asking so many questions also. Doctor, okay, last. Dr. Pradeep Kakkad. Dr. Pradeep Kakkad. Dr. Pritesh Jain. Dr. Pritesh Jain. Last one. Last one for this moment. After every second lecture, there will be lucky draw. There will be quiz. There will be bumper draw after every second lecture. Okay. But Baba, you are expert. नहीं. नहीं पढ़ पाया ना?
Coupon number 355. Is he present in the hall? Yes, please.
Damania. So thank you. You take over.
Now we move on to our next topic. It's the management of heart failure. What's new in 2023? For the same, the lecture will be delivered by Dr. Praveen Kahale sir. Dr. Praveen Kahale sir is an interventional cardiologist at Kokilaben Dhirubhai Ambani Hospital. Sir is MD-DM from Mumbai University, passed cardiology in 2004 from Nayar Hospital, currently practicing at Kokilaben Dhirubhai Ambani Hospital. Sir was observer in advanced heart failure in University Hospital of Chicago in 2015. Sir is the lead cardiologist in heart transplant program at Kokilaben Dhirubhai Ambani Hospital and has done 20 heart transplant. Here I welcome Dr. Praveen Kahale sir.
ये स्लाइड के लिए ये पॉइंटर मैं इसी से आगे पीछे करूँ, इसमें लेज़र पॉइंटर कहते हैं। Good afternoon everybody. So basically today my presentation is on heart failure. So you all know heart failure is very common as our aging population is growing. Heart failure is increasing, and what we speak is heart failure with reduced ejection fraction. So depending on ejection fraction, heart failure is classified as reduced, mid-range ejection fraction and preserved ejection fraction. So basically what my topic today is heart failure with reduced ejection fraction, and you can see the topic name is worsening heart failure. So worsening heart failure is a very simple terminology, English word, that patient is become worse or patient is not doing well. So this is a new terminology. So before I start with my presentation, if everybody of you know that there is something called Fantastic Four or Foundational Four therapy for heart failure, can anybody say those 4 drugs for heart failure? Aldosterone antagonist. So this what we call is 4 foundational therapy, and we usually call Fantastic Four. So you all know this, there is an increasing, so you may get little confused that अभी तक हम बोलते थे heart failure hospitalization. So this is a serious event. So what is worsening? Worsening also meaning actually same, but it is not only hospitalized. If patient become too much breathless, he has to go to an emergency, get an intravenous Lasix. Then worsening means admitted patient also and outpatient emergency visit patient also who are getting intravenous diuretic. So there is a more broad definition, क्योंकि हमको ये पता है जो एडमिट होता है उसका फ्यूचर, जितनी ज़्यादा बार एडमिट होता है उसका फ्यूचर उतना खराब होता है. एंड सेम थिंग इज दोज हु आर breathless or they have symptoms are become bad. So this is a typical progression that patient is stable, then one become breathless, and then they get admitted again and again, and then they go into something called as advanced heart failure. And once there is an advanced heart failure, doctor will say this patient may not come out. Or if it's a young, then they may ask for a transplant or a device therapy. So this is the most important slide to make you understand about heart failure, how serious is disease. So what we say that heart failure mortality and event rate. So when we try to understand coronary artery disease, हम लोग क्या बोलते हैं कि भाई statin देंगे, दवाई देंगे, antihypertensive. What you do is you reduce event rates. And what is event rate? What you call is MACE, major adverse cardiovascular event. तो अगर हम कोलेस्ट्रॉल टैबलेट दे रहे हैं, डायबिटीज दे रहे हैं, तो what we want that patient should reduce cardiovascular mortality, non-fatal myocardial infarction and non-fatal strokes. So cardiovascular disease should be reduced, and that is what we study in clinical trials. In heart failure, what you study? Heart failure, hospitalization as well as death due to cardiovascular disease. So अगर आप left side में देखेंगे, so you have what you call the risk, intermediate risk, high risk, low risk and very high risk of ASCVD. जो left छोटा वाला bar chart diagram है, it shows कि how do we say our patients are high risk. So अगर patient में 3%, 5% event होते हैं, तो we say 5% event is high rate risk. आपके पास calculator होता है, you all know Framingham score. A patient come to your OPD, you can calculate, tell कि आपके एक साल में what is the chances of a ASCVD or heart attack risk. So इस तरह calculate करते हैं और हम कहते हैं कि if there is a 10% chance of cardiovascular event, you are high risk coronary artery disease. But what is in heart failure? Even patient you give this all Fantastic Four, patient come to your OPD. So what you call stable outpatient, if you see the stable outpatient का भी जो risk है, event rate in 1 year is 10%. Mean 10% will get hospitalized or they will die. So what here the mortality of heart failure with reduced ejection fraction is just like a cancer. अगर मैंने चारों दवाइयाँ दे दी है, patient OPD में आ रहा है, still the risk is 10%. But if patient get worsen, either he is rushed to OPD for more diuretics, 10 mg torsemide is become 40, injectable diuretic or get admitted, then this patient is more sick. I hope you understand कि जो OPD में आ रहा है और अब उसका symptom ज़्यादा severe हो गया है, तो his event rate become worsening become almost 40%. So 40% is like any, actually more than many of the cancer. So what you can see on the right side, stable outpatient and worsening heart failure. So worsening heart failure, the event rate is 40%. So now if I want to try a new drug, I have to try this sickest population, because already four medicine are there, and if a new drug has to prove that it is also good, it has to prove in this sick population of what we call worsening heart failure. So once patient start worsening, OPD patient event rate is 10%, 10% है, but when they become worsen, so ये 40% होता है. So this diagram is a hemodynamic pressure monitoring. What is hemodynamic pressure monitoring? What we do, we put a small sensor called pulmonary artery sensor, हम lungs के अंदर डाल देते हैं pulmonary artery में through femoral vein, and it can measure the pulmonary artery pressure. So अगर आपको पता है तो pulmonary artery pressure is a reflection of left ventricular diastolic pressure. जितना ज्यादा left ventricular diastolic pressure होगा उतना पेशेंट को dyspnea ज्यादा होता है. So traditionally हम लोग क्या करते हैं, patient is educated, we tell that heart failure patient घर में जाना है, weight check करना है. If your weight increases, that means पानी जमा हो रहा है, and heart failure you have to take more diuretics. But however intelligent a doctor is, however intelligent patient is, patient again come back, वजन भी बढ़ता नहीं है, and patient become breathless and get hospitalized. So what does that mean? पहले हम लोग सोचते थे कि अरे वजन चेक कर लेंगे और पेशेंट को वी कैन कीप अवे फ्रॉम द हॉस्पिटल, बट इट इज नॉट पॉसिबल. तो हमको इससे क्या समझ में आता है, व्हेन वी पुट एन इंट्राथोरेसिक प्रेशर, व्हाट वी सी दैट देयर इज सम asymptom before patient get hospitalized, there is the increase in the pulmonary artery pressure. So ये pulmonary artery pressure क्यों बढ़ता है? Because probably abdominal fluid goes to the lung और पेशेंट को वेट गेन नहीं होता है. शुरुआत में जब हमने प्रैक्टिस शुरू की हमको लगा हार्ट फेलियर इज वेरी इजी, हम डायूरेटिक दे देंगे एंड पेशेंट विल बिकम बेटर. बट व्हेन वी सी इन प्रैक्टिस हाफ ऑफ द पेशेंट देयर इज नो वेट गेन. 50% आर टिपिकल, जिनके पैर में स्वेलिंग आती है, ब्रेथलेस है, हम एक लैसिक्स देते हैं और 3-4 लीटर यूरिन निकल जाता है. बट 50% दे हैव इंक्रीज इन अ प्रेशर एंड देन दे गेट हॉस्पिटलाइज्ड एंड देयर मे नॉट बी अ वेट गेन. तो इसको हम बोलते हैं कि पेशेंट इज प्रोबेबली देयर इज सम, rather than fluid gain, there is a fluid shift in the body. तो इससे हमें ये समझ में आया है कि it's not only the diuretic, हमको कुछ और दवाई देनी पड़ेगी which will modify the risk. So traditional thinking was that this fluid retention, it is driving worsening heart failure. But now, though हमको 20 साल से पता है कि it's without weight gain patient get admitted, but this catheter gives us information that it is many a time it is the worsening heart failure, patient become bad and then they start retaining fluid, which means that beyond diuretic we need to think something else, a drug which works on hemodynamics. So you all have seen that there is lot of advancement in cardiology, but still a heart failure with reduced ejection fraction, patients do not get the medicine which are proven last 20 year, 30 year, because डॉक्टर क्या सोचते हैं, कुछ साइड इफेक्ट हो जाएगा तो, व्हाट वी से, परस्यू साइड इफेक्ट्स, बीपी गिर जाएगा, पोटेशियम बढ़ जाएगा, पल्स कम हो जाएगा, पेशेंट आके बोलेगा कि डॉक्टर क्या दवाई दे दी, एंड मेजॉरिटी ऑफ डॉक्टर आर नॉट ट्रीटिंग हार्ट फेलियर. सो अ ग्रुप ऑफ कार्डियोलॉजिस्ट थॉट कि ये ऐसे कैसे है, कैंसर पेशेंट इतना बोल्ड होते हैं, कार्डियोलॉजिस्ट इतना क्यों डरते हैं. कैंसर पेशेंट का डायग्नोसिस होता है, ऑन्कोलॉजिस्ट कम, ऑन्कोलॉजिस्ट बोलेगा कि 2 दिन बाद एडमिट होना है, हम हमको 4 ड्रग्स देंगे, आपके बाल चले जाएंगे, आपको उल्टियां होगी, लूज मोशन होगा, बट यू हैव टू मैनेज विथ इट एंड लिव विथ इट बिकॉज यू आर डीलिंग विथ अ डिसीज विच इज वेरी बैड. वो पेशेंट एक्सेप्ट करता है, और अगर साइड इफेक्ट हो गया, हीमोग्लोबिन इन्फेक्शन हो गया, इमरजेंसी में आ जाना, विल गिव यू इन्फेक्शन, एंटीबायोटिक वी विल गिव ये GSF एंड वी विल इंप्रूव यू. बट कार्डियोलॉजिस्ट एंड फिजिशियन इतना क्यों डरते हैं. तो सम फिजिशियन स्टार्टेड दिस स्टडी विच इज कॉल्ड अ वेरी रिसेंट स्टडी पब्लिश रिसेंटली कॉल्ड स्ट्रॉन्ग HF. और इन्होंने क्या किया है कि पेशेंट को पहले हफ्ते में ही हाफ डोज दे दिया, 100 mg मेटोप्रोलॉल, 12.5 ऑफ स्पाइरानोलैक्टोन और ACE और ARB ऑफ 50% डोज. 3 हफ्ते में बुलाया और डबल डोज कर दिया, और बीच में उनको मॉनिटर किया. दोज हु आर नॉट टॉलरेटिव वर एक्सक्लूडेड, बट दे डिड नॉट डू इंटेलिजेंट डिस्कशन. कार्डियोलॉजी में इंटेलिजेंट डिस्कशन होता है, पहले ये देना चाहिए, फिर पूरा डोज बढ़ना चाहिए, देन यू ऐड दिस. नथिंग इंटेलिजेंट, वेरी बेसिक, लाइक अ कैंसर, गिव 3 drugs, कॉल देम आफ्टर, गिव द. सो व्हाट दे कुड सी that 50% patients at the end of 1 month have achieved the target dose of 3 drug. ये जब ट्रायल शुरू हुआ था, that time SGLT2 was not there, ARNI was not there, only 3 basic drug, and definitely as you can see on the right corner, the study was terminated before because the इट वॉज अनइथिकल. इतना अगर पेशेंट को बेनिफिट हो गया, ये टारगेट डोज में पहुंचे और उनको बेनिफिट भी हुआ, एंड द इवेंट रेट वेंट डाउन एंड यू कैन सी एंड ट्रायल वर प्रीमेच्योरली स्टॉप. कि जो रूटीन केयर वर्सेस एग्रेसिव केयर, इवन अ रूटीन केयर शुड बी गिवन एन एग्रेसिव केयर. सो द डिसीज इज लाइक कैंसर, बट मेजॉरिटी ऑफ टाइम इट शुड ट्रीटेड एज अ कॉमन फ्लू. So this is a strong HF, and strong HF is very influential study that 2021 guidelines, now they say sequencing is outdated. पहले ये दो, पहले वो दो. तो शाहरुख खान पहले आया, आमिर खान उसके बाद आया, सलमान खान उसके बाद आया. बट डायरेक्टर क्या देखता है, पहला रोल उसको ऑफर करेगा, दूसरा नहीं, जिसके लिए सुटेबल रोल है वो देगा. सो व्हाट गाइडलाइंस है, विच एवर ड्रग पेशेंट इज टॉलरेटिंग यू गिव देम. तो सीक्वेंसिंग वाज हिस्टोरिकल, क्योंकि बीटा ब्लॉकर पहले डिस्कवर हुआ है इसलिए पहले देना है, ऐसा नहीं है. whatever is suiting, whichever drug suit. If patient is hypokalemic, you start aldosterone antagonist early. If patient is tachycardic, you start this. If patient is not tolerating, is hyperkalemic, then use other drug. So this is what is a new change in the guidelines. Now with this background of this fantastic 4, we have now a fantastic 5th, and this drug is called vericiguat. Now what is vericiguat? Vericiguat is a new drug, and it is a, what I say, a old wine in a new bottle. Old wine in a new bottle. Why I say? Because it is working through a very old pathway of nitric oxide. हम लोग हार्ट फेलियर में नाइट्रेट देते थे. Even people have tried sildenafil in pulmonary hypertension, heart failure में, but they did not work. Now this drug works on the same pathway, but it is a little different mechanism, and it has shown in the clinical trial called Victoria that this drug works. So यहाँ आप क्या देख रहे हैं, जो various trials है, left side में है paradigm heart failure which is a ARNI trial, you have DAPA HF and Emperor HF which is SGLT2 trial, and on the most right side is a Victoria trial. और इसमें हम क्या बता रहे हैं कि all these drugs they are पहले standard therapy देते हैं और फिर medication group standard therapy में top up करते हैं, and what you see is there is a reduction in the event rate. So it reduces heart failure hospitalization and cardiovascular death. But यहाँ पर जो विक्टोरिया में जो population study है, that is the most sickest population, जैसे मैंने आपको पहले बताया था कि this is worsening heart failure population. So what Victoria trial is? Victoria trial is patient with worsening heart failure जो एडमिट हुए रिसेंट 6 महीने में, या जिनको आईवी डायबिटिक्स के लिए इमरजेंसी में भाग रहे डिस्पाइट ऑल स्टैंडर्ड मेडिकल थेरेपी, उनको उन्होंने दे एडेड अ टॉप अप ड्रग ऑफ vericiguat, and you have 5,000 patient, 2,000 patient in a standard arm and 2,500 in the vericiguat arm. And what did they found was improve in a heart failure hospitalization. So this is the mechanism of action, that you have drug with various pathways, SGLT2, beta blocker, ACE inhibitor, and you have, this is the sickest population which studied this drug. So this is the biochemistry of cyclic GMP. So if you know this vericiguat, this is a group of drug, they are called soluble guanylyl cyclase stimulator. So what is guanylyl cyclase? You can see this alpha beta, this is an enzyme called guanylyl cyclase. It converts GDP to cyclic GMP, and cyclic GMP is an intracellular messenger which is good because it reduces fibrosis, improve the cause vasodilation. It is same like what is nitric oxide is doing. तो nitric oxide left side में है, what does it does? Same mechanism with nitric oxide, but आप सबको पता है when you give sorbitrate or ये there is a nitrate tolerance because endogenous nitric oxide get depleted because of endothelial dysfunction. People have used sildenafil, you all know Viagra and all. They are reducing the phosphodiesterase inhibitor, reduce the metabolism and increase the nitric oxide. But both drugs have failed in heart failure. So same mechanism, but now we have a new drug which directly stimulates this enzyme, and they are called soluble guanylyl cyclase stimulator. तो इससे वही mechanism है where cyclic GMP increases. And in this clinical trial, what you see that this is a distribution of patient. So cut off GFR also. Now this drug is what? Which is more and better tolerated drug. So 90 to 100 patients reach the target dose of vericiguat because there is no major effect on the blood pressure. What is this chart is showing? Cut off GFR. If you have ARNI before 30 GFR, it is a red caution. If you are using your SGLT2, the cutoff GFR is 20, but in Victoria, the cutoff GFR was 15 because this drug doesn't have a renal metabolism, and population was worsening heart failure population. So the population is one which has 40% or the highest event rate, and what we see is 10% reduction in the event rate in this drug, and what you say number needed to treat is 24. So if you treat 24 patients with Vericiguat, you reduce one cardiovascular endpoint, which is hospitalization or death. So tolerability. So as we see that we have fear कि ये drug tolerate करेगा नहीं करेगा, and we have inhibition in giving heart failure therapy. Here the advantage is the drug is very well tolerated, blood pressure reduction is not much, syncope is not also increased, and very easy to reach the target dose. Target dose is 10 milligram. So you start with 2.5, after 10 days make it 5, after 10 days you make it 10 milligram. So when we call our ARNI patient, हम उनको बोलते हैं अरे चालू करेंगे, BP check करो, घर पर monitor करो, come to in 7 days. But when we start on Vericiguat, we tell them at after home only, you can make from 2.5 to 10, or 2.5 to 5, and 5 to 10 you may not be visiting us to check how are you doing or are you tolerating. What happens on NT-proBNP, you all know N-terminal BNP is one of the marker of heart failure. When you give this an improvement in NT-proBNP, no effect on sodium and potassium. So if there is a hyperkalemia, you all know one of the big problem in giving ACE, ARB and aldosterone antagonist is increase in potassium, because many of the heart failure patient has a CKD, which is a comorbidity. So no effect on electrolytes and no effect on the renal function. This is a renal function on patients on Vericiguat. So this is one of the analysis that you should add maximum drug. जितनी ज़्यादा दवाइयाँ heart failure patient को मिलेगी, they will do better, event rate is less. So this we have already doing in blood pressure and diabetes. Drug with different mechanism of action, we may not reach the target dose, but at least you should have more drugs in the prescription, because drug with different mechanism of action will have synergistic effect. So this is what is a change in thinking now as far as heart failure is concerned. So this is an Indian consensus statement. We all cardiologists from India came and went this consensus statement that which are the patients which are good for Vericiguat therapy or this new therapy, and that is what we say, that definitely those who are worsening heart failure, getting hospitalized despite maximum medical therapy, these are the candidate, and as we have already spoken, no electrolyte disturbance and cutoff GFR is 15. So this is what a heart failure, because they are not getting treatment correctly, what we are now doing is we are putting a checklist. बीटा ब्लॉकर मिला क्या, पल्स रेट क्या है, पल्स रेट टारगेट पर है क्या, ACRB है तो नहीं है, and then the doctor in a heart failure clinic fills up that why this drug is not there. So everything should have explanation, then only we can improve the therapy. And similar, we have at Ambani Hospital in our clinic, which is a heart failure checklist, and this not only include medical therapy, how is their diabetes going on, how is their renal function, how their comorbidities are well treated, and even vaccination. Majority of these heart failure, they require pneumococcal and influenza vaccination. This has to be done. So the new drug, rather than a new drug with the old mechanism of action, now has a proven, and it is what we say is another disease modifying drug, and it has proven that the sickest patient definitely get benefit. So definitely when you start this drug therapy, I have already covered this. We have a 3 doses, patient not much complex therapy, patient itself can, you don't need creatilocolide or hemodynamic monitoring. Definite patients are those who have ejection fraction less than 30%, symptomatic, recent hospitalization or coming to a clinic with increasing diuretic dose or an emergency visit for intravenous diuretics. A BP more than 100, patient should have a good volume status, diuretics have optimized, and eGFR more than 15 are the suitable candidate. So this is how there are, apart from understanding from strong HF trial, that if you add 4 drugs, all 4 drugs, your number needed to treat is 4. मतलब अगर आप चारों ड्रग देंगे तो 25% patients are getting benefit, and when you add this another drug, your advantage comes, and from strong HF what we are telling, now you can initiate this drug early. You don't wait, because we will have never trial. For example, every drug works independently. ऐसा नहीं है कि if you see SGLT2 ARNI trial, there were no SGLT2. SGLT2 trial, there was no vericiguat. Vericiguat trial, there was no SGLT2. But in different population, we all now understand. अभी हमारे पास ऐसे trial तो है नहीं, alpha blocker plus beta blocker plus ACE plus ARB. And but we are combining this intelligently in hypertension. So same process we should see that which drugs fits well, which drug, whether the drug is first old drug or new drug, but which drug fits well, you need to initiate. And vericiguat is one of the drug which takes up of majority of cardiologists fear while initiating this therapy. And when you initiate, what you do, your risk event rates come down. So if your event rate is 42, then you have number needed to treat of 40 per 100 patient year. If the patient event rate is 42, you bring to 40. So an absolute reduction, what we say, absolute reduction of 4% and relative reduction of 10%. इसका मतलब अगर आप 20 लोगों को treat करोगे, तो 1 patient will be beneficiary. These are the 3 doses. Every 2 weeks we step up. Usually 2 weeks they say, but in practice we do 10 days because one strip is 10 tablets. It's not 14 tablets. So once the first strip is over of 2.5, we tell them to go for 5 and 10 milligram. So, so this is now again in all guideline, European as well as the ACCHA guidelines have taken vericiguat as one of the important drug when patients become bad. And now from quadruple therapy, there is a third process is going is quintuple therapy. So those patients who are bad, they are now a candidate for quintuple therapy, but in practice, you may not see, there will be intolerance to one of the drug. Either they will not tolerate aldosterone antagonist, either they would not tolerate ACE-ARNI or ACE-ARB. But yes, but when you add multiple therapy, the tolerance of other drug improves. अगर आप SGLT2 शुरू करते हैं, then more patient can take aldactone because that will neutralize the hyperkalemic effect of aldosterone antagonist. So the concept what we have learned in diabetes, what we are practicing in hypertension is a polydrug therapy, low dose at least the initial period, because the initial period first 1 month is a most high risk patient where we have most fear in adding new drugs. So there are 2 ways when you take decision making. One is risk of commission. So what is going to happen if I bombard these patients with drug? There would be some side effects, some adverse effect, but I think if you say that disease has a mortality like cancer and how easily an oncologist prescribe to a cancer patient drug therapy, I think we are way behind in confidence and way behind in the fear of the treatment. Risk of omission, if you don't give, their survival goes down, their hospitalization goes down, their symptoms worsen and the quality of life goes down. So it is very important the shared decision making in these heart failure patients. And I think with that, thank you for patience listening. I hope your cerebral perfusion is not down. Many patients many people went out to reduce their sacral pressures. Thank you.
Sir, when will you advise LVAD and CRT so far the cardiac failure is concerned, not treated properly by the YMDA and ARNI?
See, first thing we have to see that one patient has to be treated properly. And once you give all treatment, now you can understand if patient has a very broad QRS, LBBB hai, and mitral regurgitation, ventricular size is big. So definitely these patients are bad patient. If patient has a big scar in the ventricle, LAD territory में बहुत बड़ा scar है, so obviously these patients are not going to improve. So these are the patients who become bad, and then we have all other treatment like the left ventricular assist device and the heart transplant. Obviously both of the treatment would have contraindication and indications.
When we have to do the cardiac transplant, can we put in for the window period of these things actually LVAD?
Yes, that is called as a bridge to treatment. So it's a bridge treatment. So if patient is, this has happened as Dr. Kane was telling you that tower was first done in prohibitive patients, जिसको कोई हाथ ही नहीं लगा सकता, ऐसे भी मरना है तो आप टावर करो. So many of time same thing happened with an LVAD. ऐसे कई सारे मरीजों को LVAD लगाया गया that there is ब्रिज टू डेथ कि अब ये रिकवर नहीं होंगे, बट इट हैज बीन सीन दैट कुछ लोगों का एलवेट वापस निकालना भी पड़ा. सो देयर आर स्टोरीज विद द न्यू जनरेशन एलवेट जिसको हम बोलते हैं हार्टवेट 3, वो जब कई बार लगाया गया है, यू हैव टू विड्रॉ एंड पेशेंट हैड इंप्रूव्ड विद दैट ट्रीटमेंट.
What is the benefit of SGLT2 in cardiac failure?
So SGLT2 in cardiac failure, the benefit, if you see that it helps, one, it is good renal function, it improves renal perfusion, it reduces the renal fibrosis as well as the myocardial fibrosis. It has been shown to reduce the interstitial fibrosis, and in clinical, so this is basic science. In clinical practice, what you see, in clinical trial it reduces events, patients become better, heart failure hospitalization, even death is reduced. So this is even if patient is non-diabetic, because many a time when in a heart failure patient, I used to write, up to chalo there is more awareness, but last before 1 year, if there is an SGLT2 inhibitor in a prescription, the chemist ही उनको बोलता है कि आपको diabetes है क्या, and patient phone करता है कि भाई whether आप मुझे diabetes है क्या, then I have to tell this is a pumping increasing medicine and this is not given to you for sugar.
How long you pull on LVAD?
Depends. As I told, it depends from patient to patient. If patient has no severe pulmonary hypertension and they tolerating anticoagulant, because one of the criteria for LVAD should be warfarin. NOACs are not effective. You have to anticoagulate, otherwise device will choke. It is like a mitral prosthesis. So people have stayed for more than 10 years on LVAD, and there are people who improve और LVAD निकाल भी दिया है. As I told you, explantation भी हुआ है.
It's very costly.
Yes, definitely. Costly, invasive, patient has to charge the battery and all.
Sir, most of the cases when we are using the triad for cardiac failure, patients subjectively have improved. But the LV ejection fraction when we do a 2D echo does not show that much of a difference. When we are giving verisuquet, that point of time, sir, we are actually dealing with the metabolic process of the cell, myocardial cell, and nitric oxide is being. That point of time, we expect that the ventricular cell or myocardial cell should actually contract much better because we are improving the metabolism. With nitric oxide, we are giving better perfusion to the
Yes, that is.
But still, we don't get the ejection fraction good.
Yeah, what happens is what we call is a reverse remodeling. So if the your heart size is 5 centimeter with myocardial infarction and heart failure, it increases. And how can you make it smaller?
We are shrinking.
We shrinking, and the terminology is reverse remodeling.
Reversing.
So beta blocker are very strong drug. They do the best of the reverse remodeling. There are trial to show ARNI, MRI trial to show ARNI. Yes. As far as verisuquat is concerned, the drug is not yet that study in ejection fraction, because it is studied in clinical setting, because we all know that if the patient gets hospitalized due to heart failure, these are a very high risk patient, and if you could reduce this event rate, we do see some reduction in a mortality also.
So one small question. If cost is not a constraint, will you start the quadrant of the heart failure drugs simultaneously?
Yeah, again,
you will do that.
We do that. We see it depends on patient. Depends on patient. For example, right now, today morning, I had a patient who I did a primary angioplasty at 3 to 4 days back. Now his EF was 30% and I made him rehab. I do very aggressive rehab. In day 3, day 4 he is doing cycling. We thought he is doing well. But he is complaining failure. Then I got again one echo and I saw there is a mitral regurgitation. So this is a ischemic MR. So I started him on ARNI in hospital with BP of 110. He is already on SGLT2 inhibitor. He is already on aldosterone antagonist. He is already on beta blocker. And this is 7 days post MI only. He is not what you call is a established heart failure that we are discussing now. But I have added ARNI 50 milligram twice a day. Patient BP was 90 yesterday. And my RMO told, "Band karo, band karo." I told, "No, nothing. Today it is 100. And I have added verisuquat also because I don't expect this patient to improve very fast.
Fair enough. Thank you, sir.
Thank you, sir. Thank you, Dr. Praveen Kahale, sir, for the informative speech. Now for the felicitation, may I request AMA Secretary, Dr. Priyambada Sharma, MCVP Secretary, Dr. Neeta Mamtora ma'am, APA President, Dr. Ashish Deshmukh, sir, to please acknowledge the speaker with the shawl bouquet. May I please request Dr. Rajesh Ghatkar sir to be on dais for the felicitation of our speaker, and Dr. Smita Ghatkar ma'am to acknowledge the speaker. Moria. Now there will be inaugural function. For the same, I will invite Dr. Smita Patil ma'am to conduct the inaugural function. Thank you so much. And there will be more bumper prize after the inaugural function. So I am requesting everyone to please be seated in the hall. Thank you so much. In between the inauguration, there will be a bumper draw anytime. So please, I am requesting everyone to be seated.
Prajwalan. Please, sir. Dipali.
Thank you, Dr. Smita. Please join your hands for Ganesh Vandana. Lamp. स्वस्ति श्री गणनायको गजमुखो मोरेश्वर सिद्धिदः बल्लाळस्तु विनायक स्तवतमहे चिन्तामणि स्थेवरे लीण्याद्रौ गिरिजात्मज सुवरदु विघ्नेश्वरश्चोझरे ग्रामे राञ्जन संस्थितो गणपति कुर्यात् सदा मङ्गलम् मङ्गलम्. Thank you.
Thank you, Dipali. Such a melodious sound. Now there will be Deep Prajwalan by our chief guests, Govindaji, Sunitaji, Sudesh Bhosleji, Ratnaparkhi sir, Smruti ma'am, and Presidents MA, MCVP, and APA.
हवे हटा सावन के घटा
कसं काय वृंदाला फक्त सांगा, ऐका, वृंदाला फक्त सांगा, गोविंदा आणि सुनीताचं रेडी ठेवा, एवढं सांगा ना. I request everyone, please be seated, doctors. अबे हटा सावन की घटा, आ खुजा बत्ती बुझा के सो जा, इंटुकले मंटी पे खड़े लिए घंटी, बार बार बजा लिए घंटी, कुल्ला घुमा के पश्चिम को पलट ले, बहुत हो गया फुटले वटले, शाना बन क्या. Do I need to say the name of our actor? Of course, wait. अपना विरार का छोकरा सुपरस्टार गोविंदा, जिसने अपनी जबरदस्त एक्टिंग और सुपर्ब डांसिंग से पूरी दुनिया का दिल जीत लिया. 1986 में फिल्म इल्जाम द्वारा बड़े पर्दे पर इन्होंने डेब्यू किया और फिर ये फिल्मों का सिलसिला चलता ही रहा. लव 86, स्वर्ग, भाग्यवान, राजा बाबू, आंखें, कुली नंबर 1, खुद गर्ल्स, बड़े मियाँ छोटे मियाँ, क्योंकि मैं झूठ नाही बोलता, पार्टनर. 130 पेक्षा जास्त सिनेमामधून गेली 25 वर्ष गोविंदा आपलं मनोरंजन करतच आहे. स्वर्ग सिनेमा पाहून तेव्हाच्या सगळ्या प्रेग्नंट बायकांनी असा मुलगा व्हावा म्हणून नवस बोलले होते असं सांगितलं जातं. गोविंदाचा एक फॅन क्लब आहे जो त्याचा प्रत्येक सिनेमा फक्त त्याच्यासाठीच पाहतो. मग हिरोईन कोण आहे, को ॲक्टर कोण आहे, साईड ॲक्टर कोण आहे, त्याचा आम्हाला काही फरक पडत नाही. आणि हे मी इतक्या ठळकपणे सांगू शकते कारण असं एक जागृत उदाहरण माझ्या घरात आहे. माझा नवरा जर केबलवर गोविंदाजींचा पिक्चर चालू झाला तर आमच्या घरातली बाहेरची सगळी कामं थांबतात आणि आम्हाला बसून तो पिक्चर बघायलाच लागतो. तुम्हाला वाटेल ही काय सारखी गोविंदा गोविंदा करते, पण काही लोक आपल्या मनात इतकं घर करून राहतात की आपण त्यांना आहो जावं म्हणूच शकत नाही. जसा आपला अमिताभ, आपला धोनी, आपला सचिन, तसा आपला गोविंदा. गोविंदाला स्क्रीनवर पाहून क्वचितच एखादा अरसिक असेल की ज्याचे पाय थिरकले नसतील, कारण त्यांचा डान्स हा फक्त त्यांच्या पायातून किंवा शरीरातून होत नाही, तर तो 99% त्यांच्या सुंदर चेहऱ्यावर असतो. मी तुमच्या सगळ्यांतर्फे त्यांना एक अर्ज करते किंवा आपल्या सगळ्यातल्या मनाची जी इच्छा आहे ती बोलून दाखवते. हम तुम पे मरते हैं, हम तुम पे मरते हैं, हम अपने मोहब्बत का ऐलान करते हैं, हम तुम पे मरते हैं. तर असे आपले ॲक्टर, डांसर, हाँ नहीं उनको कोई ऐतराज नहीं होगा. ऐसे सुनो ऐसे सुपरस्टार लोगों के लिए भगवान अलग टाइप की बीवियां बनाता है. वो हमारे जैसे नहीं रहते जो जरा भी कोई देखे तो परेशान हो जाए. उनको तो चलेगा. अरे तो now I request our GPR sir Smruti Ratnaparkhi ma'am to felicitate Govinda ji with shawl, bouquet. मैं भाभी जी के लिए वापस बोलने वाली हूँ. घेऊन ठेवा. मोरया मंगल मूर्ती. गणपति बाप्पा. लोग इतने मेस्मराइज्ड हो गए कि उनको मोरया बोलना भी भूल गए वो लोग. I'll come. तालियां. देखो गए 25 साल से हम लोग गोविंदा जी को इतना अप्रिशिएट कर रहे हैं. दुनिया की चकाचौंध में उन्होंने अपना नाम बनाया, हम लोग को इतना एंटरटेन किया, बट उनको संभाल के रखने वाली उनकी पत्नी सुनीता जी के लिए ज्यादा तालियां होनी चाहिए. अँड ॲज यू ऑल विल ॲग्री, जोपर्यंत स्वतःची बायको साथ देत नाही माणूस काहीही करू शकत नाही. स्वतःची बायको प्लीज. एक दूसरे से करते हैं प्यार हम, एक दूसरे के लिए बेकरार हम. अरे ओ चुम्मा मेरी जाने मन, बाहर निकल आज जुम्मा है. रूप है तेरा सोना सोना, सोनी तेरी पायल, झंझना कर ऐसे बरसे जैसे. इसके आगे मैं नहीं गा सकती हूँ, नहीं तो वो बोलेंगे कि स्मिता तुम ही गाओ, मैं अभी बैठ के सुनता हूँ. तो अशी अनेक सुपरहिट गाणी आणि ज्या गाण्यांवर थिरकल्याशिवाय आपली कोणतीही पार्टी पूर्णच होऊ शकत नाही, त्या गाण्यांच्या मागचा एकच आवाज म्हणजे सुदेश भोसले. परमेश्वर कधी कधी अशी माणसे बनवतो की जग अचंबित होऊन जाते. संगीताच्या दुनियेतले हे दोन भोसले, एक आशा आणि एक सुदेश, या दोघांनी भारतीय संगीत आणि भोसले आडनाव दोन्हीही साता समुद्रापलीकडे पोचवले. अशोक कुमार, राजकुमार, संजीव कुमार पासून अनुपम खेर, जावेद जाफरी, सलमान खान पर्यंत अनेक सुपरस्टार्सना आवाज देणारा हा एकमेव अवलिया कलाकार. तेजाब पिक्चर तुम्हाला सगळ्यांना आठवत असेल. त्या सुपरहिट सिनेमामध्ये पूर्ण सिनेमा अनिल कपूरचा जो आवाज आहे तो सुदेशजींचा आहे. लक्ष्मीकांत प्यारेलालजींनी अमिताभ बच्चनसाठी गाण्याचा यांना फर्स्ट ब्रेक दिला आणि मग सुदेशजींनी इतिहास रचला. असं सांगितलं जातं की सुदेशजींनी गायलेलं गाणं ऐकून स्वतः बच्चन साहेब विचार करायला लागले आणि त्यांनी प्रश्न विचारला, ये गाणे का रेकॉर्डिंग मैंने कब किया था. ते सुद्धा स्वतःचा आणि त्यांचा आवाज वेगळा ओळखू शकले नाहीत. यापेक्षा काय हवंय. सिंगर आई आणि आर्टिस्ट वडिलांचा हा अष्टपैलू मुलगा, ज्याने संगीतामधलं कोणतीही ऑफिशियल ट्रेनिंग घेतलेलं नाही आहे. यांच्याबद्दल खरं तर मी कितीही बोलले तरी ते कमीच आहे. सो मिमिक्री के बादशाह सुरीले सिंगर सुदेश भोसले, प्लीज गिव हिम अ बिग राउंड ऑफ अप्लॉज. And I request Dr. G.P. Ratnaparki sir, Smruti ma'am, Dr. Ram Chavan, Dr. Anurag Bhate to felicitate Sudesh Bhosle ji. President Appa. गणपती बाप्पा, मंगल मूर्ती, उंदीर मामा की. जरी आपण सगळे आपल्या जी.पी. रत्नपारखी सरांना खूप चांगले ओळखतो, तरी त्यांच्याबद्दल थोडं बोलल्याशिवाय मला माझ्या मनाला समाधान मिळणार नाही. बिकॉज ही इज द करता धरता ऑफ कार्डिओकॉन. इज MBBS, MD, DM, फेलो इंटरव्हेन्शनल कार्डिओलॉजी, फ्रँकफर्ट, जर्मनी. He is honorary cardiologist at Nanavati BSCS Hospital, head of Department of Cardiology at Holy Spirit Hospital, Cath Lab and HOD of Criticare Hospital, Juhu. Owner of ISO certified Guru Krupa Heart Center, Andheri West. Doing highest number of cardiac interventions in city of Mumbai. He is actively and selflessly works from society, has adopted 6 night schools and is running free ambulance service for poor and needy people. विंदा करंदीकरांची एक कविता आहे की जी नेहमी वाचताना मला फक्त ह्याच माणसाचा चेहरा डोळ्यासमोर येतो. देणाऱ्याने देत जावे, घेणाऱ्याने घेत जावे. देणाऱ्याने देत जावे, घेणाऱ्याने घेत जावे. घेता घेता एक दिवस देणाऱ्याचे हात घ्यावेत. हां. He was awarded by देवेंद्र फडणवीस जी, उद्धव ठाकरे जी and एकनाथ शिंदे. म्हणजे तुम्ही विचार करू शकता ह्यातल्या सुद्धा कुणाला तरी CM होण्याचा चान्स आहे. सरांचा परिस्पर्श लागल्यावर आयुष्याचं सोनं हे झालंच पाहिजे. रोटी तो हर कोई कमाता है, बट बहुत कम लोग होते हैं जो अपने परिवार और समाज के साथ बांटकर वो रोटी खाते हैं. और वो है अपने जी.पी. रत्नपारखी सर. A truly हृदय सम्राट. I request a standing ovation for sir with big round of applause. Please everyone. आता आपण प्रत्येक जण जाणतो, जसं मी आत्ताच बोलले, इथे 2 यशस्वी पुरुष आहेत आणि त्यांच्याबरोबर त्यांच्या बायका आहेत. किंबहुना मी तर असं म्हणेन, बायकोची साथ असल्याशिवाय पुरुष यशस्वी होऊ शकत नाही. आणि झाला तरी त्याचे पाय जमिनीवर ठेवायचे काम फक्त बायकोच करू शकते. आपल्या सरांबरोबर आपल्या सरांबरोबर आयुष्याच्या प्रत्येक टप्प्यावर त्यांना साथ देणाऱ्या आपल्या लाडक्या डॉक्टर स्मृती रत्नपारखी. शी इज गोल्ड मेडलिस्ट इन MDS, practicing since 35 years in तक्षशिला अंधेरी ईस्ट, ट्रस्टी गुरुकृपा हार्ट फाउंडेशन चॅरिटेबल ट्रस्ट, एक उत्तम आई आणि होणारी उत्तम सासू. अतिशय नम्र, मितभाषी, मोठेपणाचा लवलेशही नसणाऱ्या आणि त्यांच्याकडून खूप काही शिकणारे आमच्या लाडक्या स्मृती मॅडम. A big round of applause for ma'am, who is always there standing silently as a strong pillar of Guru Krupa Heart Foundation. अब डॉक्टर राम चौहान, नाम ही काफ़ी है. सेकेंड टाइम इलेक्टेड प्रेसिडेंट MCVP, ट्रस्टी गुरु कृपा हार्ट फाउंडेशन अँड चॅरिटेबल ट्रस्ट. रामला बघितल्यावर मला नेहमी माझ्या मनात या दोन ओळी येतात. यारो का यार राम जैसा हो, जो सबकी हेल्प करने के लिए हमेशा तैयार होता है. A senior practitioner, Dr. Ram Chavan, and a very kind-hearted human being. I request chief guest to felicitate Dr. Ram. Dr. Ram with his wife Ashwini. प्रिया अश्विनी को भी ज्वाइन करने को है. तिला बोलवायला लागेल सर के सर. नहीं बुलाते, मैं बोलने तक बोलो ना. Now let me say a few words about Dr. Anurag Bhate, President, Andheri Medical Association, Consultant Gynecologist, Endoscopic Surgeon, Director, Shubhadeep Maternity and Nursing Home. A young dynamic man of few words, Dr. Anurag Bhate, and First Lady AMA, Dr. Meghna Bhate, please. नाही पण बोलवून ठेवा तेवढा वेळ नको. आता याच्यानंतर ते सुरू कर. झाले. Now Dr. Ashish Deshmukh, President APPA, practicing at Marol, and please Dr. Mrs. Suhasini Deshmukh. I request Dr. Vinay Rathod, IPS, Deputy Commissioner of Traffic Police Thane. He did his MBBS from Vasantrao Naik Medical College, Yavatmal. He is student of Ratnaparki sir, and he helped doctors' fraternity in a pandemic. Please welcome Dr. Vinay Rathod. Please welcome on stage our next guest of honor, Saurabh Koratkar. Saurabh. आणि चेहरा जरा ऑडियन्सकडे करा. हा चेहरा तुम्हाला ओळखीचा वाटतोय का? ABP माझाचे अँकर यांना खरं तर आपण रोज टीव्हीवर पाहतो आणि सगळ्या देशभरातल्या घटना यांच्यामुळे आपल्यापर्यंत पोहोचतात. राम राम रामला बोला. Now please welcome on stage Dr. Krishna Fadtare, President Mumbai NEMA. NEMA works for Mumbai doctors' problems. Please, sir. National Integrated Medical Association, NEMA. Now we'll felicitate Dr. Rajesh Ghatkar with Dr. Smita Ghatkar, Director of Sakan Criticare Hospital. Now I request Dr. Sanjay Ratnaparki, Director of Chiranjeev Hospital, Yavatmal. Vaini. we have another gem of a person, retired ACP Padwal Sahib, always helpful to all doctors of AMA, elder brother of Dr. Ratnaparki sir, always strongly remains behind GPR sir and AMA family. Please welcome Padwal Sahib. नाश्ता झालाय सगळ्यांचा व्यवस्थित. टाळ्या. It's time for our conveners. Please welcome Dr. Shashank sir, senior practitioner from Parla West, Vice President MCVP, who thinks and works only for betterment of AMA and MCVP. A father figure for all of us. Please welcome Dr. Shashank sir. Not all beautiful girls are models, some are doctors, and when you see her, you just wonder what a combination of beauty with brains. Let's welcome our dearest Teju, Dr. Tejaswani Ratnaparki, convener CardioCon. Our another convener of CardioCon, Dr. Anil Kumar, a non-invasive cardiologist associated with Guru Krupa Heart Center since 15 years, also works in Nanavati and Holy Spirit Hospital. Today he has big task of getting speakers on time and making them complete their lectures within given time. So I wish him all luck. Please, Dr. Anil Kumar. आपल्याबरोबर स्टेजवर आहेत श्रीयुत शंकर पटनाईकजी, सुदेशजींचे भाऊजी, त्यांचा सुद्धा सत्कार करायचा आहे. Vishal Kande. Mr. Vishal Kande, he is practicing structural engineer and licensing architect, empaneled with almost all municipal corporations. He is honored by World Book of Record London in 2021 and by International Book of Records New Delhi in 2022 for his relentless efforts in structural design and building approval field. We'll felicitate Mr. Vishal, future MLA, okay. Request Dr. Bakul Mehta sir to be on stage and our chief guest to felicitate our senior doctor, Dr. Bakul Mehta, as a MMC observer today. I request Dr. Parthiv Sanghvi sir, ex-president MCVP and ex-MMC observer, please come on stage.
Suhas Hardas, cardiologist from Pune. Suhas Hardas.
Okay.
Just put here.
I request Dr. Suhas Hardas, cardiologist, Pune, please, sir, come on stage. मला माहित आहे तुमच्या मनात आता माझ्याबद्दल राग यायला लागला असेल, ही माईक सोडते की नाही. सो नाव आय रिक्वेस्ट गोविंदाजी, दिस माईक इज ऑल युअर्स. टाळ्या.
ओम विश्वानि देव सवितुरितानि परासव यद्भद्रं तन्नासव त्र्यंबकं जजामहे सुगंधिं पुष्टिवर्धनम् उर्वारुकमय बंधनान् मृत्युर्मोक्ष्यमामृतात् कालहर दुःखहर दारिद्र्यहर कष्टहर रोगहर हर हर महादेव. मराठीत नक्की बोलतो मी. हल्ली काय मी स्पीच देत नाही, पॉलिटिक्स. हां. बाहेर पडल्यानंतर कधी स्पीच दिली नाही. आणि मैं थोड़ा अपनी औकात में भी आ जाता हूँ. बीवी के आगे किसी की चलती नहीं है. इतना हम लोग कह देते, इतना ये बहुत हम लोग बढ़ चढ़ के बात करते, किसी की नहीं चलती साहब. जो कहते हैं हमारी चलती है उसकी भी नहीं चलती. मैं सदैव ये शुरुआत करता हूँ पूजा प्रार्थना कैसे. तो मेरी वाइफ मुझे कहती है कि ज़्यादा प्रवचन नहीं दिया करो. एक्टर हो, फिल्मी गाने गाओ, डांस करो, डायलॉग वायलॉग लगा के इधर उधर हो जाया करो. हाँ, वही उनके ही उस पे इशारों पे नाच रहा हूँ मैं, वर्षानुवर्ष हो गए. मैं ईश्वर का बहुत बहुत धन्यवाद कहा करता हूँ, ख़ास तौर पे मेरी माता जी आदरणीय निर्मला देवी जी का मैं धन्यवाद दिया करता हूँ. और बच्चों की माँ हो या माँ हो, माँ तो माँ हुआ करती है. तो मुझ पे जो कृपा हुई है, मुझे कभी कभी विश्वास नहीं हुआ करता है कि मुझे जिस तरह से सम्मान मिल जाते हैं, जहाँ पे एक से एक पढ़े लिखे लोग देखने मिल जाते हैं, उनके सम्मुख में आता हूँ और मुझे इतना सम्मान मिलता है, मैं सदैव धन्यवाद ही दिया करता हूँ. वो मुझे लोग कहा करते हैं, गोविंदा इतना तुम मंत्र वगैरह सब ये करते रहते हो, ये क्या है. तो मैं डॉक्टर लोग हैं इसलिए मैं स्पेशली ये कहना चाहूँगा आज कि मैं इतना ज़्यादा बीमार मेरे बचपन में था. तो मुझे नील पड़ी हुई थी यहाँ हाथ में और मेरे इधर कमर पे इधर, और कहाँ इंजेक्शन ठोके हैं पता नहीं चलता था. तो पहले शुरू में बीमार था तो आया करते थे घर परिवार के सदस्य, फिर वो थक जाते हैं लोग, फिर सिर्फ डॉक्टर और पेशेंट, वो बीमार जो हुआ करता है वो और डॉक्टर, इन्हीं का रिश्ता रह जाता है. तो मेरे समझ में नहीं आ रहा था कि यार ऐसा क्या है, ये कभी ठीक होगा कि नहीं होगा. मैं 13 साल का था, मुझ पे कुछ ऐसी ऊपर वाले ने कृपा कर दी, ये गुरु कृपा हो गई मुझ पे. हाँ सच कह रहा हूँ, गुरु कृपा ही हुई. तो मेरा वो लोग कहते हैं जैसे माता माता व सर्वत्र मातृ देवो भव, जैसे गुरु ब्रह्मा गुरु विष्णु गुरुदेव महेश्वर गुरु साक्षात परब्रह्म तस्मै. ये जो हम लोग कहा करते हैं, इसमें ज़रा भी हम सोचे ऐसा विषय नहीं है, ऐसा विषय नहीं है. 14 साल की उम्र में मेरी माता जी ने मुझे एक माला ये दादर से ला के दी और एक आसन ला के दिया. मैंने 24 लाख गायत्री की है, 14 से 21. मैं हर मंच के माध्यम से ये बच्चे लोगों से कहा करता हूँ कि बच्चे लोग, माँ जो कह दिया करे वो कर दिया करो, क्योंकि मैं तो शुरू में बहुत बदमाश टाइप का हुआ करता था. मेरा अच्छाई में विश्वास नहीं था, मेरा भगवान में विश्वास नहीं था. हाँ, मातृ वर्ग में सदैव रहा. तो मुझे ऐसा लगता था ये क्या ये गुरु लोग करते हैं, ये क्या मम्मी कहा करती है, माला ला के दे दिया हाथ में, इसे थोड़ी दुनिया चलेगी यार, ये क्या है, ड्रामा है, सब झूठ है, फरेब है, धोखा देने वाले लोग हैं ये सब। ऐसा वृत्ति थी, क्योंकि विरार गांव में हम लोग रहा करते थे तो माहौल जो देखने मिलता था। परंतु 14 से 21 में मेरी सारी बीमारियां निकल गई, लुप्त हो गई। कहाँ गई? मैं सोचने लगा, तब समझ में आया कि जो हम लोग की लाइफ के जो सदैव जो पहले डॉक्टर हुआ करते हैं ना, वो गुरु और माँ ही हुआ करते हैं, उससे बड़ा डॉक्टर नहीं है। वो सब डॉक्टर लोग के डॉक्टर हुए और उनके बाद में अगर ईश्वर ने अपनी जगह किसी के प्रदान की है तो मुझे लगता है आप डॉक्टर लोग के प्रदान की है। क्योंकि ये जो बड़े बड़े साधु संत जो अपनी पूजा प्रार्थना पे कभी कभी उन्हें गर्व भी होता होगा, कभी घमंड भी होता होगा, सत्य हुआ करता होगा, परंतु जब चलती नहीं है तो अपने आप को डॉक्टर के सुपुर्द कर देते हैं। पर्याय नहीं है। ईश्वर ने जिसे जो विषय दिया है उस विषय के आगे पर्याय नहीं है। तो मैं धन्यवाद दिया करता हूँ कि ऐसे प्रत्यक्ष देवता जो है मेरे सामने उपस्थित है और इनको मैं सम्मान दे रहा हूँ, ये ईश्वर ने मुझे ऐसा सम्मान दिया है, मैं उसके लिए धन्यवाद दिया करता हूँ। और आदरणीय रत्न पारखी जी जो हैं वो मेरे हम लोग के घर परिवार के सदस्य जैसे हो जाते हैं, वो वैसे हो जाते हैं। कौन आदमी कैसा है मैं कभी पूछा नहीं करता हूँ, मुझे पता लग जाता है। मेरी पत्नी का रिएक्शन देखता हूँ, घर की किसी स्त्री का रिएक्शन देखता हूँ उन्हीं की रिएक्शन में मुझे पता लग जाता है कि ये आदमी अच्छा आदमी है। तो ये कहा करती है वो भाई हैं, वो भाई साहब की तरह हैं वो। अब मेरी तो सास उनके हवाले है, मतलब मेरी जो आदरणीय सासू माँ है, आप ही इलाज कर रहे हैं। तो मैं धन्यवाद दिया करता हूँ आदरणीय रत्न पारखी जी का, और आप सब लोगों का धन्यवाद देता हूँ। और हम लोग में एक खासियत है, हमें दुखती रथ पे हाथ रखना आता है, चाहे डॉक्टर हो चाहे एक्टर हो, हमें समझ में आ जाता है। दर्द आ ही गया तो निकालें कैसे, आपके समझ में आता है। और दर्द कहाँ से आ सकता है, कैसे आ सकता है, क्यों आ सकता है, उसे कैसे निकालें, ये हमें समझ में आ जाता है। बहुत लोगों को ऐसा लगता है कि एक्टर तो एक्टर आहे, आपण मराठीत म्हणतो ना काय आज हे झाला असेल रे चायला चल काय, फार असे बघितलेत आम्ही ना। पण ते खरं काय ते काय लोकांना म्हणजे मला असं वाटतं की त्यांना असं वाटतं की हा लकीली हा झाला ॲक्टर, लकीली कायच कधी काय होत नसतं। प्रत्येक माणसाला लई जीवाला जीव लावून त्याला मेहनत करावी लागते, त्याला हा काम करतो त्याच्यावर विश्वास ठेवून काम करावं लागतो, आणि त्याच्या मागे लई प्रार्थना असतात, फार पूजन असतं, फार कर्म असतात, आपल्या आईवडिलांचे असतात। आम्हाला कळत असते की बाबा आम्ही हे फार मेहनत करतो, काय मेहनत चालत नाही साहेब, फक्त मेहनत चालत नाही, लक्ष्य चाहिए, आशीर्वाद चाहिए, बहुत दुनिया में बहुत सी चीज़ चाहिए, बहुत सी प्रेरणाएं, बहुत सी आशीर्वाद एकत्र हो जाते हैं तो हम जैसे आर्टिस्ट बाहर निकलते हैं। तो मुझे ऐसा लगता है सदैव धन्यवाद दिया करिए, और ईश्वर से मैं जैसे धन्यवाद दिया करता हूँ, आज मैं सिर्फ यही चीज़ का ज़्यादा धन्यवाद देता हूँ, एक्टर से ज़्यादा। मुझे 10th पॉपुलर मैन इन द वर्ल्ड डिक्लेयर कर दिया। हाँ, ये हम लोग के यहाँ कमाल है सर, हम लोग के विरार गांव में बहुत कमाल है। जिधर इज्जत मिल जाती है, मेरी उतनी बड़ी इंसल्ट होती है, मेरी बहुत इंसल्ट होती है। तुझ्या आईला तू कसं काय झाला रे? हे काय कळत नाही, तू झाला तू हमारा MP हो गया, MP हो गया, थैंक यू सो मच है ना, राष्ट्र के लिए अब सेवा करने के लिए हम ये मला तू कसं काय MP झाला काय कळत नाही रे, तू काय असं साधारण आमचा गोंद्या तू। ये प्रेम है महाराष्ट्र का, ये मुझे जो है कि वो एक ने तुझको जन्म दिया एक ने तुझको पाला, है रे कन्हैया तू किसको कहेगा मैया, ये सत्य है। यहाँ की जो मातृत्व प्रेम है, आप देखिए, भले काशी विश्वनाथ की कृपा होने की वजह से विश्व प्रसिद्धि काशी विश्वनाथ के वो जो है वो पूरी दुनिया में मिलती है, परंतु वो निकलता किस धरती से है? निकलता वो महाराष्ट्र की धरती से ही है। 11 रुद्र की स्थापना हो गई, ऊपर पुनः स्थापना कहां से हुई? महाराष्ट्र की धरती से हुई। चित्रकूट, चित्रपट, हर तरह की जगह। तो हम बहुत लकी हैं कि हमें यहाँ ये प्रेम मिला, ये मातृत्व प्रेम मिला खास तौर पे। और उसमें हम रत्ना पारखी जी जैसे भाई मिले, मैं धन्यवाद देता हूँ। और मेरी पत्नी का धन्यवाद देता हूँ, वाकई पारखी है वो वाला। अच्छा आदमी को पहचानने के लिए ज़्यादा फर्क चाहिए ना। हाँ, आदरणीय सुदेश भोसले जी आप यहाँ पे हैं। मैं इस मामले में बहुत लकी रहा हूँ, मुंह से शब्द निकलता है तो वो सत्य हो जाता है। ये क्या है, कृपा है मुझ पे। शब्द निकलता है, सत्य हो जाता है। ऐसे बहुत से सुपरस्टार्स जो हैं मैंने देखा और कहा कि ये तो साला मुझे लगता है सुपरस्टार है, ये तो निकल पड़ी है। और थोड़े दिन बाद पता चलता है कि साला सचमुच सुपरस्टार हो जाता है। तो मैं सुदेश जी से मिला, हम लोग साथ में, अब मैं ऑर्केस्ट्रा से निकला हुआ हूँ तो मुझे थॉट वैसे ही आ जाते हैं। तो मैं कहा ये ऑर्केस्ट्रा में ये एक्टर लोग की एक्टिंग कर रहे हैं और उनके से फिल्मों के गाने गाते हैं, परंतु मुझे ऐसा लगता है कि ये सुपरस्टार के लिए गाना गाएंगे। ये सुदेश भोसले हैं यार, इज अ इनडायरेक्ट पार्टनर। और वो इनडायरेक्ट पार्टनर हैं। बहुत सारे लोगों को उसके अस्तित्व का पता नहीं चलता है। जो थोड़ा सा दिव्य दृष्टि से देखने लगता है, थोड़ा सा ध्यान से देखता है, तो उसे पता लगता है हाँ ये मेरे इनडायरेक्ट पार्टनर है। मित्रगण तो हैं ही हैं, पर इनडायरेक्ट पार्टनर है। मैं ईश्वर से ये प्रार्थना करता हूँ यहाँ पे जो लोग जहाँ जहाँ हैं, जो आर्टिस्ट हैं, जो डॉक्टर्स आए हुए हैं, मैं आप लोग के साथ में धन्यवाद देता हूँ और ईश्वर से ये प्रार्थना करता हूँ कि अपनी जब भी मुलाकात हो तो इस तरह से हो, इसके अलावा नहीं होनी चाहिए। Thank you so much. Love you all. Love you. Thank you so much. डांस तो करो बाबा।
Thank you so much.
हाँ हाँ, मैं यही कह रहा था कि कितनी भी इज्जत मिले आखिर में ऐसे ही उतारी जाती है। अब इज्जत निकल ही गई है। मैं कहा करता हूँ, मैं बहुत अच्छा हो गया, मैं बहुत ज़्यादा इंग्लिश फर्राटेदार नहीं बोलता हूँ, बहुत अच्छा हो गया। वो इसलिए नहीं कहता हूँ कि आखिर में ये डायलॉग कहना ही पड़ता है, हटा सावन की घटा खा खुजा बत्ती बुझा के सो जा गया, निंटकले पिंटुकले मंटी में खड़े ली अंटी बुझारी ली बार बार घंटी कुल्ला घुमा के पश्चिम को पलट ले, बहुत हो गया फुटले वटले शाना बन गया। लव यू ऑल, थैंक यू सो मच।
Big round of applause and a standing ovation. आज आप लोगों को सिर्फ ज्ञान की दावत नहीं है, आपको मनोरंजन की भी दावत है। अब मैं बुला रही हूँ there will be a bumper prize lucky draw after inauguration, so please be seated. आता कसे बसणार ते लोक? बंद आहे. चालू आहे. बैठे रहिए, आपका मनोरंजन अभी तक खत्म नहीं हुआ है और इसके बाद गिफ्ट भी है, तो इट्स नथिंग बेटर देन दैट. प्लीज वेलकम डॉक्टर सुदेश भोसले जी. मैं आपको भी डॉक्टर बोलने के लगी. सुदेश भोसले जी. यस. अरे सुनो सुनो, जो दर्द कम करता है वो डॉक्टर है.
ओम गोविंदाय नमः. ओम गोविंदाय नमः. ओम गोविंदाय नमः. ओम गोविंद. सर, तुमच्याकडून लहान मुलं, यंग तरुण नाही, पण आमच्यासारखे बुजुर्ग पण प्रेरणा घेतात. तुमची एनर्जी आणि जी तुमच्या शेजारी बसलेली एनर्जी आहे, दोघांना नमस्कार. सर्वप्रथम सर्व डॉक्टर्सना माझा नमस्कार. आणि डॉक्टर रत्नपारखी सर, मी इथं का आहे म्हणजे माझ्या भाऊजींचा सत्कार केला, त्याचं कारण असं आहे की माझी मोठी बहीण कला सरांची पेशंट आहे. आणि आपण नॉर्मली डॉक्टर्सकडे जातो तर कधी कधी घाबरून बाहेर निघतो, पण माझी बहीण आणि भाऊजी जेव्हा घरातून बाहेर निघतात ते डॉक्टर सरांकडे, तेव्हा अगोदरच त्यांना वाटतं की मी बरी झाले म्हणून. असं डॉक्टरांचा अप्रोच आहे. आणि आज इथं मला बोलवून एवढा सन्मान दिलात, आणि डबल थँक्स ह्याच्यासाठी की ज्या सुपरस्टारला तुम्ही बघायला तडपतात तसंच आम्ही, माझी फॅमिली तरसते, तडपते. आणि आज गोविंदाजीची पुन्हा भेट तुम्ही करून दिलीत. त्यांच्या शेजारी बसण्याचा मान मला मिळाला. थँक्यू सो मच डॉक्टर. कारण गोविंदाजी तुम्हाला बहुतेक आठवत नसेल, पण तुमचा फर्स्ट फॉरेन टूर माझ्याबरोबर झाला. आपण दोघांनी केलं होतं. आणि तेव्हापासून ॲज अन ॲक्टर तुमच्यासाठी हे गोविंदाजी असतील, पण एक प्रेमळ माणूस आणि कॉमन माणसात मिसळणारा आपला गोंद्या. तर मी जास्त वेळ घेणार नाही, सरांना खूप उशीर झाला आहे. मी 2 गाणी फक्त साहेबांसाठी, मी सरांसाठी मी लकी आहे की गायले होते ते. कोई हम प्यार करे, कोई जान निसार करे, देख के हमको तो कहते हैं लोग वल्ला, बड़े मियाँ छोटे मियाँ सुभान अल्लाह, बड़े मियाँ तो बड़े मियाँ छोटे मियाँ सुभान अल्लाह. आणि अजून एक गाणं गायलो तुम्ही. टारारा 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 टाडा टाडा नन, ओ लाल दुपट्टे वाली तेरा नाम तो बता. तारारा, अरे नाम तो बता, तेरा नाम तो बता, तेरा नाम तो बता. ओए होए बजाओ, ओए होए ओए होए ओए होए. आणि मी थँक्यू. जेव्हा कार्यक्रम करतो स्टेजवर तर एक गाणं मी दादा कोंडकेंचं गातो, आणि त्या गाण्याला जोडून मी आपला गोविंदा सरांचा आणि बच्चन साहेबांचा एक छोटासा एक कॉमेडी आयटम करतो. त्याच्यात सर्वप्रथम म्हणतो, अगो हिल हिल पोरी हिला, तुझे कपाली लाटिला. अगो हिल हिल पोरी हिला, तुझे कपाली लाटिला, तुझे कपाली लाटिला, तुझे कपाली लाटिला. न फॅशन मराठी सोबल तुला, अरे जा जार मुला का सत्तावीतच मला अरे गोविंदार गोपाळा अरे गोविंदार गोपाळा तुझ्या घरात नाही पाणी गागर होतानी रे गोविंदा अरे गोविंदार गोविंदा दिनता 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 यो अरे आमचा गोंद्या मराठी गोंद्या विरारचा गोंद्या त्याच्या घरी पाणी संपलंय आता ह्यांना पैसे कोण देणार आपले बच्चन साहेबांना लोकांना देतात फाडून फाडून म्हणजे बँकेचा चेक आपण बच्चन साहेबांकडे आपल्या गोंद्यासाठी मदत मागूया त्यांच्या घरचं पाणी संपलंय ओ अमिताभ बच्चन मला ऐकत नाही आहे ओ दाढीवाले बाबा आयला ऐकत आहे ओ कौन बनेगा किसका पति हाँ कौन बोला कौन बोलला हम बोलला गोंद्या माहिती गोंद्या कोण गोंद्या यायला बडे मिया छोटे मियामध्ये तुला गोंद लावलेला आमचा गोंद्या त्याच्या घरी पाणी संपलेलं आहे त्याच्या बघू फाड बघू लवकर लवकर उसके लिए हम और आप खेळते हैं हे माझ्यावर खेळायचं नाही माझ्यावर खेळलंस तर यायला गंगीला राग येईल बरं का लवकर लवकर सांग तुझ्या बँकेचं नाव काय बँकेचं मी बघतो मी बँक सगळं तू बघणार मग आम्ही काय करायचं खरं खरं बँकेचं नाव सांग ICICI बँक ICICI तुझ्या का माझ्या जायला मस्करी करतोय लवकर लिहि आमच्या गोविंदासाठी चेक काय लिहिलंय एक गागर पाणी आमच्या गोविंदासाठी फक्त एक गागर पाणी म्हणून म्हणतो म्हणजे तुमच्या पण बँकेत ठणाना भोमला म्हणून म्हणतो पाणी जेव्हा भरपूर असतं तेव्हा बदा वाचायचं नाही मी आणि गंगू कशी सांभाळून वापरते थेंब 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 पाणी थेंब 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 जसं जीवात जीव घुटमळ तसं पिरीत वाढतं बळ तुझ्या तोंडाला दोन माझं मिळगन हे बघून दुश्मन जळ वर ढगाला लागली कळ पाणी थेंब थेंब गळ ढगाला लागली कळ पाणी थेंब थेंब गळ थँक्यू 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 मैं भी नहीं छोड़ूंगा और ये बादशाहों की देख रहे तो सही चलो शुरू हो जाओ वही 1 2 3 4 शाबा शाबा माहिया से शाबा शाबा माहिया से शाबा शाबा माहिया से शाबा शाबा रूप तेरा सोना सोना सोन तेरे पायल धन धना छन ऐसे छन के गर्द सबको घायल है कह रहा आंखों का काजल इश्क में जीना मरना everybody shawa shawa mahiya te shawa shawa yeah thank you
तालियां अब मुझे बोलने की भी जरूरत नहीं है डॉक्टर्स प्लीज बी सीटेड आपका लकी ड्रॉ का चांस जा सकता है लवकर लवकर अगर सनत जी कैमरामैन होते तो एक फिल्म होने को 2-3 साल आराम से लग जाते नाउ विल हैव फेलिसिटेशन ऑफ आवर सेक्रेटरी MCVP डॉक्टर नीता ममतोरा सीनियर प्रैक्टिशनर फ्रॉम अंधेरी ईस्ट आई रिक्वेस्ट आवर चीफ गेस्ट एंड डॉक्टर GP रत्नपारखी सर फेलिसिटेशन हाँ Sunita Bhabhi will do the felicitation of all. Shobha Ahuja. Ahuja, of course. Sunita Ahuja. Sunita Ahuja. Yeah. त्यांचं पण करायचं आहे ना, त्यांचं पण करायचं आहे. कोण आहेत ते? Dr. Shobha Ahuja, IMA President, Western Suburb. Secretary AMA, active enthusiastic personality and smiling face of AMA, shy dancer, multi-talented and my dear friend Dr. Priyamvada Sharma. I request Dr. Sharad Dadish sir, treasurer of MCVP, a senior practitioner from Andheri East, always guiding us, a calm and composed personality. Our chief guest and Dr. GP Ratnaparki sir, please felicitate Dr. Dadich. दो जन हैं. सीमा. Please welcome Treasurer AMA, active member of AMA, Dr. Seema Tiwari, soft-spoken who works silently and shows us results. MOC. First MOC of the CardioCon, Dr. Ashwini Chauhan. जाओ ना. अरे just a second, Dr. Ram. मागे सुद्धा एक पुरुष असतो. Correct. Best critics in the world is your own husband. तेवढंच बोलतात सर फक्त. Second MOC, Dr. Mona Gandhi. Hey. Third MOC of CardioCon, Dr. Dipali Kate, with her encouraging husband, Dr. Gajanan Kate. Always supportive. रामदास स्वामी सांगून गेले, स्वतःचे कौतुक करी तो शतमूर्ख. आणि मी आता माझं स्वतःचं कौतुक न करता डायरेक्ट तिकडे जाते. मी माणसं ठेवली आहेत.
खरंच आज ज्यांनी हा मैदान गाजवलेला आहे, अशा रणरागिणी, ज्या आपले महाराष्ट्राचे कुलदैवत छत्रपती शिवाजी महाराजांच्या गावातून येतात, साताऱ्यावरून, अशा डायनामिक लेडी अंधेरी मेडिकल असोसिएशनच्या प्रत्येक प्रोग्राममध्ये अशीच कवी आणि ह्यांचे जे शब्द असतात, जे गोविंदा सर आणि सुदेश सर ऐकत बसले होते आणि आम्ही डॉक्टर लोक ऐकतो असे. त्याचबरोबर त्यांचे हजबंड डॉक्टर समीर पाटील सरांना मी इन्व्हाइट करतो. अँड इन्व्हाइट डॉक्टर रत्नपारखी सर, गोविंदाजी सर, सुदेशजी सर, फेलिसिटेटर. प्लीज क्लॅप. सर्वांची बोलती बंद त्यांनी उद्धव साहेबांसमोर केली होती. तेव्हा पण आम्ही त्यांच्याबरोबर होतो. तेव्हापासून पार्टी बंद झाली. अशा रणरांगणी डॉक्टर स्मिता पाटील, कॉंग्रॅच्युलेशन मॅम, अँड थँक्स फॉर गिविंग धिस ऑपॉर्च्युनिटी टू गुरुकृपा फाउंडेशन 6th CardioCon. थँक्यू.
आपल्या भाषणात गोविंदाजींनी सांगितलं की धन्यवाद करना बहुत जरुरी है. आणि आता जर जे करायचं ते केलं नाही तर आपण कृतज्ञ ठरू. प्लीज विल सेलिब्रेट आर करता धरता ऑफ MA CardioCon, Dr. G.P. Ratnaparkhi and Dr. Smruti Ratnaparkhi. I request Govinda ji, Sunita ji and Sudesh ji to felicitate the Ratnaparkhis. Please everyone, standing ovation for sir and ma'am. आणि हे सरांवरचं आपलं प्रेम आहे की तुम्ही एवढ्या संख्येने कार्डिओकॉनसाठी उपस्थित राहता, पूर्ण तुमचा दिवस इथे देता. याबद्दल गुरुकृपा हार्ट फाउंडेशनच्या वतीने आणि सरांच्या वतीने आम्ही तुमचे सदैव ऋणी आहोत. I request Dr. G.P. Ratnaparkhi sir to say a few words. मंगल मूर्ती, गणपती बाप्पा, उंदीर मामा की.
धन्यवाद. माझ्याकडे शब्द नाही बोलायला. आय डोंट हॅव एनी वर्ड्स टू स्पीक. आज आमचे दोन्ही फॅमिली मेंबर ज्यांनी एकाने बॉलिवूडवर राज्य केलं आहे आणि एकाने संगीत क्षेत्रावर राज्य केलं आहे, या दोघं महान व्यक्तींनी आज समा बांधला आहे. तुम्ही सकाळपासून 5-6 लेक्चर ऐकलं आहे, तर थोडं मनोरंजन का तडका पाहिजे होता, तो त्यांनी पूर्ण दिला आहे. आणि म्हणतात ना, आजकाल डॉक्टर आणि पेशंटचा किंवा डॉक्टर आणि परिवाराचा संबंध थोडासा सावर होत आहे, राईट. पण हे एक्सेप्शन्स आहेत. एका माझ्या फोनवर काही केलं नाही, मी त्यांना काही केलं नाही, त्यांचे एक रिलेटिव्ह ट्रीटमेंट केलं असेल, पण त्यांनी एका माझ्या फोनवर, एका माझ्या हाकेवर त्यांनी येतो म्हटलं. सुनीता भाभी, वो मेरी दीदी है एक्चुअली, भाभी है ना, दीदी है, ओके. और सुदेश जी की बहन ऑल्सो. ये सब मेरे पेशेंट नहीं बोलूँगा, मेरे परिवार है. एंड यू आर अवेयर दैट these people charge heavily for such attendance. लाखात असतं, पण त्यांनी आज लाखा मोलाचं प्रेम आपल्याला देऊन, आपल्या प्रेमाची आपण जी काही थोडी सेवा करतो त्याचं परतफेड केली आहे. त्यामुळे धन्यवाद. आणि मी थँक्यू म्हणत नाही त्यांना, कारण त्यांचं एक कर्ज आहे माझ्यावर. ओके, आय विल बी इन डेप ऑफ देअर लव्ह अफेक्शन थ्रू आउट माय लाईफ. ओके. आणि याच्याविषयी जास्त बोलू शकत नाही, मी भावनावेश झालो आहे. आपण आता रजा घेऊ 5 मिनटात. आता याच्यानंतर एक क्विज राहील, त्यात तुम्हाला भरपूर बक्षीस मिळतील, आणि नंतर माझं लेक्चर आहे. ठीक आहे. लेक्चरमध्ये पण आपण खूप मजा करू. धन्यवाद. थँक्यू व्हेरी मच सर. पुन्हा एकदा गोविंदाजी, सुनीता भाभीजी, सुदेश सर, पटनायक साहेब, सर्व माझ्या परिवारांना मी तुमचं आणि माझ्या परिवाराचं थँक्यू किंवा धन्यवाद नंतर लास्टला बोलणारच आहे. पण आता या आपल्या पाहुण्यांचं, यांचं आपण धन्यवाद करूया. पुन्हा एकदा ग्रेट जोरात टाळ्याने यांचं स्वागत करा आणि धन्यवाद. थँक्यू.
मन तो नहीं कर रहा है, लेकिन आपसे विदा लेने की घड़ी आ गई. आपकी दुआओं का प्यार और चाहत का सिलसिला यूं ही चलता रहे. आपकी दुआओं का, प्यार का, चाहत का सिलसिला यूं ही चलता रहे. करती हूँ मैं इबादत और सजदा, कर्म की भूमि पर कर्म यूं ही फलता रहे. थैंक यू सो मच. Here I declare inauguration function is ended, and I request our next MOC, Dr. Mona Gandhi, to be on stage, please. Thank you so much. You are a great audience.
You are a great orator. त्याच्या अगोदर पहिला आपण एक क्विज घेतो ना, तर सागर घे ना. हां, आगे फोटो. हां, शिफ्ट थोड़ा शिफ्ट.
थोड़ा आगे चले जाओ.
चलो तू ले ना भाई.
बीच में
नीचे जो
ये इधर कौन है?
ત્યારે કદાચ ક્વિઝ ચાલુ છે ને હમણાં.
હું નીચે રૂકું છું.
એ સાગર લે છે ને.
મને નથી ખબર.
ये दोनों लेक्चर में
हाँ, पर ये मेरे को नहीं चाहिए.
2 बजे.
हाँ, क्योंकि इतना हाइट है, मेरे को चलेगा.
मैं अभी थोड़ा टाइम इधर हूँ.
बहुत ज़्यादा.
हेलो, बी सीटेड. डॉक्टर रत्ना पारकी सर का दामाद मिस्टर सागर थोड़े क्विज देते हैं. हर एक क्विज पे वो बोलेंगे उस हिसाब से प्राइज मिलेगा. तो बी अटेंटिव प्लीज. प्राइज इज रेडी.
Hello everyone. Hope you are having a fun. और जैसे सुदेश सर ने हमारा छोटा सा केबीसी का एक झलक दिखलाया है, तो उसे ही कंटिन्यू करते हुए एक क्विज कंपटीशन लेते हैं. होप यू एवरीवन इज रेडी. सो जरा वर्ल्ड कप है तो रूल भी बोल देता हूँ. आई होल्ड द डिसीजन मेकिंग राइट्स. मैं चूज करता हूँ कौन आंसर करेक्ट है कौन नहीं है. सो प्लीज कोऑपरेट विथ मी, क्योंकि क्विज कंपटीशन है. एवरीवन हैज टू रेज द हैंड एंड गिव द आंसर वंस द माइक इज गिवन टू यू. प्लीज डोंट प्रॉम्प्ट द आंसर्स. सो लेट मी स्टार्ट विथ समथिंग स्पाइसी. सो द फर्स्ट क्वेश्चन इज, which spice is the most popular in the world? I saw that guy. That yeah, yes sir, yes sir. Sorry, next ma'am. In the world. No prompting please.
Black pepper.
I have to discard this question because there was prompting. Sorry, your answer was different before.
Pepper only. Black pepper.
No prompting. Unless I point to you, please don't answer. It won't be fair. Let's move on to the next question.
Hello, Mr. Sagar will see who has raised the hand. He will ask that you answer, then answer. If somebody answer on behalf of you, everyone will be discarded. So please don't answer on behalf of anyone.
Fair and square. I discard the question, please. What is the height of the net in table tennis? That person again raise the hand first.
Eight inches.
Wrong answer. So you? 6 inches is the right answer. Question 3. The International Court of Justice is seated in which? Right answer.
Don't answer, just raise the hand. Huh?
Right answer. Right. I pointed him, then he answered. Right answer. World Cup hai, so some cricket related questions. I hope everyone is ready. Let me grab a very tough question. Who hit? So cricket ka maximum run hota hai 6. So who hit the most sixes in ODI matches? Specifically ODI matches. Hey, don't prompt. Wrong answer. Wrong answer. Let me rephrase the question again. Who hit the most number of sixes in ODI cricket? Who? Let me give the question again. who hit most number of sixes in ODI cricket?
One day international.
Shahid Afridi.
Right answer. Let's move on to the next question. And to give you the details, Chris Gale is the most number of sixes, but it is in all three formats. And Shahid Afridi has scored most number of sixes in ODI specifically. Moving on to the next question.
I'll watch, don't worry. पहले से हाथ मत उठाओ.
So everyone knows Sunil Gavaskar, right? I hope everyone knows Sunil Gavaskar. Yeah. So he has scored a century in his career in World Cup, specifically in World Cup. Okay. So question is not that simple. And you're using mobile. Okay then. So Sunil Gavaskar has scored a century in World Cup in his career. It is against which country?
Country against which country? Anybody?
No. He has raised the first. Wrong answer.
Wrong answer. एकदम last.
Correct answer.
न्यूजीलैंड वाला पीछे वाले आगे वाले नहीं. वो पीछे वाले ने पहले जवाब दिया. I can see him. Come back benchers, come. ऐसा बगुन दे.
भाई देख के दे रहा हूँ. सॉरी. नहीं. गूगल में सर्च करोगे तो इतना जल्दी नहीं आएगा ये.
सिर्फ हाथ उठाइएगा, आंसर मत दीजिएगा, नहीं तो क्वेश्चन ही चला जाएगा.
Let's walk down to the memory lane. So, the next question. Which bowler has taken the first hat-trick in Cricket World Cup? Wait, let me complete the question. You have to give me the name of all three batsmen he has taken the wickets. First person to take the hat-trick in Cricket World Cup, and I need the name of three batsmen he has taken the wicket.
Come ahead, gentlemen. बोलो तीनों का नाम है ना? हाथ उठाए ना?
Anyone?
नहीं. Anyone?
Anyone?
Three.
Three batsmen of whom he has taken the wicket. Three batsmen.
हैट्रिक में कौन तीन बैट्समैन का विकेट लिया था?
I think this time is enough to do the Google. So.
Come here and answer. Question is disqualified due to our president. Please don't answer. Sorry. वो बेचारा दो बोले थे, आपने तीसरा जवाब दिया, मत दीजिए. We have asked for three. Please, sir.
Let me give you the answer. The right answer is Chetan Sharma. I hope everyone knows him. But the batsmen who were bowled out is. कौन?
Hello, gentlemen, please come. आपने दो आंसर तो दिया है. ये हमारा कमेटी की वजह से आपको नहीं मिल रहा है, नहीं तो आ जाओ.
He was right on two batsmen.
Please don't prompt. Please
Ken
don't.
Rutherford, E.M. Smith, and the third one was Sven Chatfield.
Congratulations, दो का तो नाम बरोबर दिया आपने.
This was the tough question.
Sir, please कोई बीच में मत बोलिएगा, please.
Let's move on to the next. Let me give you a bit easier one. Who scored the first double century in Cricket World Cup? That lady.
हाँ, lady, please come. आपके
Wrong.
पीछे. हाँ, बोलो. आप बोलो.
Wrong. Wrong.
Lady? Huh?
Wrong. 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 Right. The doctor in black. Chris Gayle was the person who scored first double century in Cricket World Cup.
Congratulations. अनुराग तू जवाब नहीं देने का बस. नहीं मत. नहीं वो ऐसे ही दे देगा. ये तेरा ही है. You are president, Baba.
Let me give you a question related to a cricketer who is favorite of most of us. I think should say rephrase who is the most favorite of all of us. Who has scored most number of centuries in Cricket World Cup? So let me give you, sir, your answer. Okay, so there is a trick in this question. There are two persons who have done the same record. So there is two answers to this question. Yeah, that person is right. The one in the last. Green t-shirt, green stripes. It is Rohit Sharma and Sachin Tendulkar. The number of centuries are 6. पता नहीं मेरे पास बहुत क्वेश्चन है. क्रिकेट का अलग. ओके, वर्ल्ड कप था तो मैं क्रिकेट पे गया.
बॉलीवुड पर जा, बॉलीवुड पर.
थोड़ा केमिस्ट्री हो जाए. सारे डॉक्टर से केमिस्ट्री में तो सब स्ट्रांग रहेंगे. ओके, सो द नेक्स्ट क्वेश्चन. Which gas is used in refrigerators?
जवाब दिया, question cancel. Please.
I am going to discard this question. All the answers were wrong, but prompting. Sorry, I am going to discard this question. Yeah, the right answer is Freon.
खाली हाथ ऊंचा करना है, आंसर नहीं देना है. आंसर पीछे से आ गया तो आपको तकलीफ हो गई. So that's wrong. Unity नहीं है बरोबर.
Some geographical question. Let me first look into everybody and then ask. Which is the world's highest waterfall? Sorry, wrong. Sorry. Wrong. Yeah, right. Angel Falls.
Angel Fall बोले वो आ जाओ. Congratulations, very tough question.
Moving on to the next question. Everyone must have heard about the tragic incident happened in Japan, like in the World War. So it is related to that. Which was the second atomic bomb dropped by USA in Nagasaki? Name. You are prompting, sir. But he raised a hand first. No, but he raised the hand first. Ask him, he raised hand first before you. Shashank bhai?
Yeah, sorry.
Yeah. First bomb was Fat Man. First.
Congratulations.
Fat Man. Yeah, Fat Man and Little Boy. Right. कौन कौन सा सब्जेक्ट? सारे सब्जेक्ट। Again, a geography related question. Maybe a tough one, but I hope everyone will crack it. Which is the capital city of Brazil?
Brazil.
Right. But fair and square, he raised the hand first.
अभी एक भी जवाब नहीं देना, अभी सेकंड प्राइज नहीं मिलेगा.
I thought everyone would say Rio de Janeiro, but good. We got the answer in first try only. Thank you, sir. Moving on to the next question. Which bird can look directly into the sky unwinkingly?
या बोलो मत, हाथ ऊपर करो.
Sorry, I have to discard this question. I got the answer without raising the hand. Someone says eagle, and that is the right answer. Whoever it was, it is right. Hope you had waited for 5 seconds. I would have pointed towards you and given the answer.
Raise the hand, please. Only raise the hand. अनुराग भाई, आपका हाइट बड़ा है, अभी देखो कौन रेज करता है. आप इधर खड़े रहो. यू आर गिवन ड्यूटी. देखो कौन हाथ ऊपर करता है.
The easiest question for everyone present here. Which organ is called the human body's chemical factory?
क्यों सेकंड आवाज क्यों? अरे जवाब क्यों दिया?
He raised the hand first, sir. I know, but don't answer.
Don't answer unless it is told that you answer, please. So don't answer unless it is told.
You're sitting in front of me. I would point to you first. But if I get a hand raised,
who answered and who was right? Who answered?
That guy.
हाँ दे दो. आंसर मत दो, खाली हाथ ऊपर करो. यहाँ से बोलेंगे, आप बोलो तो बोलो, नहीं तो मत बोलो. That's a request. अभी कितने जाने हो गया? एक. अभी सवाल तो आने दो. सवाल तो आने दो. अनुराग बघा तुम्ही सर.
थोड़ा पॉलिटिकल क्वेश्चन चलेगा?
हाँ, पॉलिटिक्स सबको आता है.
सब रेडी है. वाह. Which country in the world had the first woman prime minister? Sir.
अभी बरोबर है.
Sorry.
एक मिनट, जिसका एक बार हो गया वो आंसर मत दो, नहीं मिलेगा दूसरा बार गिफ्ट. आपने ले लिया है, मत बोलो.
And I need the name of the lady as well, okay?
Yes, Sirimao Bandaranaike, right. Ultimately आपको प्राइज मिला. You deserved it.
The answer is Sri Lanka and the name is
Sirimao Bandaranaike.
Yes.
अनिल भाई का लेक्चर दे दो ना.
अब सुदेश जी आके गए तो थोड़ा म्यूजिकल क्वेश्चन भी हो जाए. The name of music is called as fear. Okay, let me rephrase. The name of fear of music is called as. Fear of music is called as. Right, sir.
Great.
Sudesh ji would have feel proud of you.
Congratulations. Answer.
Melophobia. Melophobia.
You can say melophobia also.
I have a very good question. मेरा क्वेश्चन किधर गया? I hope everyone is not getting bored by my questions. Not at all. Thank you. Okay, so again, sort of a geography related question. My bad. Biology related question. Which mammal builds its nest every day? A mammal builds its nest every day. Can you name that mammal? Sorry, wrong answer. A mammal who builds its nest every day. Platypus. Sorry, no, wrong answer. No, sorry, wrong answer. Ma'am? Bat is the wrong answer.
Bat is wrong. Yeah.
Right answer.
What's that?
Mobile check कर सकते हो क्या?
No.
How do you get that answer, ma'am?
Last. दे दो. आजा.
No, I'm just making fun of you.
Come.
ठीक है?
She's correct.
Okay.
So this was the
The
last.
answer is gorilla.
Last question. Now
चालू कर मतलब.
request Mona
She
Madam
must have raised her hand first.
to come on the stage.
I was looking at that section for strong 10 seconds. No one raised the answer.
Thank you. तू वाला म्हणतो ना.
Congratulations. Here we end the quiz. Would like to hand over mic to MOC Dr. Mona and Gandhi.
Thank you,
Come,
everyone.
Please.
Hello. बंद.
Thank you, Dr. Shashank Shah. Good afternoon, everyone. And once again, a warm welcome, and I appreciate presence of each and everyone on this Sunday afternoon. First of all, I would like to extend my heartfelt gratitude to Dr. Gajanan Ratnaparki sir and Team CardioCon for placing their trust in me and giving me the opportunity for today's MOC of 6th CardioCon 2023. CardioCon's a stage of heart's delight, where science and compassion unite. A symphony of beats, a rhythm so strong. At CardioCon, we all belong. Esteemed colleagues and friends, today we gather here with a deep sense of gratitude and admiration for a remarkable individual and unique personality, Dr. Gajanan Ratnaparki sir. Sir is a fellow of Interventional Cardiology, Frankfurt, Germany, honorary cardiologist at Nanavati Hospital, BSES Hospital, head of the Department of Cardiology at Holy Spirit, director of Cath Lab and HOD of Cardiology Department, Criticare Hospital, Juhu. Dr. Ratnaparki sir owns Guru Krupa Heart Center and Guru Krupa Diagnostic Center at Andheri West, Mumbai. Doing the highest numbers of cardiac interventions in city of Mumbai, sir has written and published poetry and book of own poems in Marathi, Dur Maze Ghar. Sir has been awarded in 2017 by Maharashtra Chief Minister Devendra Fadnavis the award of Best Cardiologist. Chief Minister respected Sir, Shri Eknath Shinde felicitated Sir with award Abhiman Andhericha in 2022. Sir has also been felicitated in 2017 by the ex-Chief Minister of Goa, Mr. Digambar Kamath. Award of Jogeshwari Bhushan Puraskar awarded to Sir by Minister Shri Ravindra Vaikar, and the list goes on. As I always say, his aura of knowledge is contagious. Positive vibes that radiate from him uplift everyone in his presence. Dr. GPR sir's dedication goes beyond his demanding schedule. He delves into the minutest of details, ensuring that the perfection is the hallmark of every project he undertakes. Sir's compassion for the needy and his tireless efforts in the field of healthcare have left an indelible mark on all our hearts. This commitment has been instrumental in making our 6th CardioCon event a resounding success. A hero in white in his life-saving chase. Please welcome on stage with a big round of applause Dr. Gajanan Ratnaparki sir, a true luminary in the world of medicine and a shining example of humanity's finest qualities. Please sir.
Somebody asked, what is hypertension? जो 1 घंटे से किया ना, उससे मेरा बीपी बढ़ गया, that is hypertension. जो धक्का बुक्की किया जाते वक्त, उससे बीपी बढ़ गया, that is hypertension. That is not white code, blue code. अभी मैं मैदान में उतरता हूँ बस. तानाजी मालुसरेने म्हटलं आहे, किल्ल्याचे सर्व दोर तुटलेले आहे. परत जाण्याचे सर्व मार्ग बंद आहे, त्यामुळे लढण्याशिवाय पर्याय नाही आहे. जेवणाचे सर्व दार बंद केले आहे. माझं लेक्चर संपेपर्यंत जेवण मिळणार नाही आहे, त्यामुळे तुम्हाला जेवणाचे सर्व दार बंद केले आहेत. नवयुगाचा तानाजी, घोरपड असो की होरपड असो काही होणार नाही. So my topic is what you are dealing daily. So today is no lecture, just discussion. The quiz will continue. I will ask certain questions and you will give answers. You will get the prizes. So hypertension, what is new in 2023? Any guess? Nothing is new in this hypertension management. 140, 120, 130 जान दो, okay? Okay, so nothing is new. What we have to pick the finer aspect of the hypertension management, which we are missing. We are just behind a number, 120, 180, 140, okay? No, there is something beyond 120, 80 also, okay? And tremendous burden is there, hypertension. This is because of you people. आप लोग मैंने क्या किया? You are making people survive by better medicines. So life expectancy is increasing. What was the life expectancy in 1947? All are wrong. It is below 30. Below 40 is to 32% only. 32 was like life expectancy. What is today's? 70.2 is a life expectancy, life expectancy of today's, okay? So you are keeping the people alive till 70, and when patient crosses 60, it's age. There is graying of the hairs, there is a hardening of the arteries, there is a hypertension. So every second person after the age of 60 is hypertensive. Whatever you do, okay? So the global burden is increasing. The prevalence is almost rose to 40%. Worldwide, there are 25% of the patients of total population. कितना है world का population? Population of world कितना है? एक जन बोलो ना, प्राइस नहीं. 8 billion म्हणजे किती करोड? अरे answer is written there. 804 crores, 53 lakhs, 11,000 and 447. That was yesterday's figure. So I am well prepared, na? In spite of all this preparation of conference, I am preparing my lecture also. Because academics runs in my blood. ये बाकी शोशा ठीक है, okay? ठीक है? नहीं, आप जैसे लोग थे, retired लोग थे वहाँ, वो गिनते बैठे थे. So there is a rule of half for hypertension. Whatever good treatment you give, 50% are aware of hypertension, 50% take the treatment, and 50% are well treated, well controlled. So it means 12.5% are only well controlled. And in India, this rule is not applicable. Even in India, the things are worse. Only 25% of rural populations are aware of their hypertension. Okay, so very pity state. This is why the incidence is increasing. Life expectancy is increasing. Changes in lifestyle. Most of the time, we are sitting. कितने लोग मॉर्निंग वॉक करते हैं यहाँ? सीरियसली बोलो, जिनकी टमी बाहर आई है वो झूठ मत बोलो, हाथ नीचे करो, बरोबर है? हाँ, मैं तो नब्ज से पहचानता हूँ ना कौन झूठ बोल रहा है। तो हार्ट का डॉक्टर हो ना, नब्ज जानने वाला डॉक्टर हो यार। So sedentary life, computer, electronic gadgets making us lazy, making us obese, making us hypertensive. So this is what the epidemic of hypertension. 40% of the general population has hypertension, what the data says. 40 is very high. Let us see the 25% of the global hypertension. So why? Because of this is all genetic. We are genetically more prone to develop hypertension. Our environment is different. We are a country of spice. Namak khao, mast masala khao. So this all adds our hypertension. Spice of India is known as spice of India. Once upon a time, golden chidiya thi na? Because we were earning from the spices. Okay. So spice of India, too much spice now. Normal requirement of sodium is hardly 3 to 4 grams. And average consumption of salt is almost 12 grams. Okay, 12 grams. So तिप्पट खा रहे हैं अपन, natural BP हो रहे हैं. We welcome मुरजी पटेल साहब, हमारे MLA साहब. सर थोड़ा सुनना पड़ेगा आज, हाँ? हरदम हम आपकी सुनते हैं, आज मुझे मेरे सुनना पड़ेगा. और टॉपिक इजी है सर, बीपी बढ़ाने है क्या? Okay, too much salt. This is the universal diet of kids. All our grandfather, grandmother, or a father or mother. This is what our kids want, right? Chapati, bhaji, pohe, upma, sahasa घेत नाही ते. They all eat all these things. Burger पाहिजे. So this is not burger culture or pasta, pizza culture. So that is making us obese. Teen culture. After eating this nonsense, they don't drink water. They drink Coca-Cola, Coke, teen. Okay? So that teen, in the teenage, तीन तेरा करता है, right? So lays, आधा तो उसमें हवा रहती है. Lays down the foundation of obesity. And this is a weapon of mass destruction. You don't have to send Pakistani terrorists to kill Indians. Indians, we are very well able to kill ourselves. Okay, Atmanirbhar Bharat. Okay, all these things. Okay, this particular thing, this Chinese bhel, even China people are not aware कि ऐसे कुछ चीजें करके. And taste of India. अरे बाळा किती बारी झालं, दूध पी है ना. आणि दूध पाजतो आपण 1-1 लिटर 2-2 लिटर. दूध, milk is fine, no problem. But anything in अतिरेक, anything extra is harmful. 1-1 लिटर 2-2 लिटर दूध पीने वाले लोग हैं. Okay, so Amul, the taste of India, what it makes, it is a waste of India. So जो हाथ ऊपर किया ना उन्होंने नीचे हाथ कर लिया. So inactivity. Better not to speak on this thing because we are basically inactive people. Sitting in consulting for 4 hours, counting money, only exercise to the fingers, pocket, but this much exercise we doing. Ala patient, takle patient. Okay. So inactivity. MACD is a social symbol. Party कहाँ करना है? नहीं MACD में करेंगे. KFC में करेंगे, right? This is what the kids are doing. We are spoiling our next generation. We are better because our parents were quite nice. They have taught the things nicely to us. But we are pampering them and we are making them unhealthy. Am I right? Perfect. घर घर की कहानी है. And stress. बोलते ना सीने में जलन, आंखों में तूफान सा क्यों है? इस शहर में हर शख्स न परेशान सा क्यों? We are paying a cost of urbanization. We are paying a cost of modernization. We are inviting the stress. Entire 5-10 days were quite stressful for arranging this conference. Not only me, but my entire team, 40 people. Okay, those were felicitated. तुमको लगता होगा अरे क्यों felicit करते? But 40 दिनों ने 1-2-3 महीने ने इन्होंने जो मेहनत किया, they deserve that. Okay. So their stress they are taken. That's why they are felicitated. मैं जिंदगी का साथ निभाता चला गया, हर फिक्र को धुएं में उड़ाता चला गया, खुद की वाट लगाता चला गया. ठीक आहे, देवानंद असं हलतोय तो, ओके, पण सर्वाची वाट लावून गेला. कोणत्याही धुव्यानं प्रॉब्लेम सॉल्व होत नाही. बर्बादी का शोक मनाना जरूर था, अभी वो करो. ओके, इफ यू आस्क मी अल्कोहल छोड़ना है कि स्मोकिंग छोड़ना है, आई विल से स्टॉप स्मोकिंग. ओके, इट डजंट मीन दैट दोनों भी छोड़ सकते हैं. चॉइस देता, एक स्मोकिंग छोड़ेंगे, अरे भाई दोनों छोड़ो ना. आज अंगूर की बेटी से मोहब्बत कर ले, शेख साहब के नसीहत से बगावत कर ले. जुम बराबर ना. लोग से द सोशल ड्रिंकिंग इज क्वाइट गुड, 1 पेग अ डे कीप्स डॉक्टर अवे. कुछ ऐसा नहीं है. ओके, देर इज वेरी थीन डिमार्केशन लाइन बिटवीन सोशल एंड एंटी सोशल. ओके, एक बार 2 पेग हो गया, क्या क्या सोशल क्या क्या एंटी सोशल है ना. बीबी की जब तक मार नहीं पड़ती तब तक नॉर्मल नहीं होता है. तो ओके, एंड पीपल से देयर इज एचडीएल इंक्रीज. साइंटिफिक ऑल्सो बोलता हूँ कुछ, एचडीएल इंक्रीज होता है, एग्रीड. इफ यू मेजर टोटल एचडीएल इट विल इंक्रीज, बट देयर आर 3 टाइप्स ऑफ एचडीएल. आउट ऑफ दैट टाइप 2 इज good, rest 1 and 3 are bad. It increases type 3 HDL. So useless HDL. So no need to drink unnecessarily. Huh? So dear friend, hypertension is very common, and most important, hypertension can be prevented and delayed. Right? Can we do that? Because in America 70 to 80, they have descending trends of hypertension. But after 80s again there is ascending trend again because of the increasing life expectancy and obesity. Okay. This again you are aware that 120, 130, that I don't want to go into that. But most important, there is a concept of high normal blood pressure. We never bother about that. Anything 120, 80 we are happy. Anything 130, 80 still we are happy. Arey, chalta hai. Anything 140, 80 still you are happy. Will you treat 140, 80? No. Will you treat 136 by 86? Will you treat? No. No वाले हाथ ऊपर करो. No वाले हाथ ऊपर करो. No, will not treat. 1, 2, 3 and treat. करोगे treat वाले हाथ ऊपर करो. Only one treat करेगा. 6, 8 लोग नहीं treat करेंगे. 6 लोग treat करेंगे. बाकी क्या करोगे? Good. ऐसे लोगों की जरूरत है दुनिया में. कुछ मत करो, सब हाइपरटेंशन मेरे तरफ भेज दो. ये लोग चाहिए मुझे. परफेक्ट. अन्य ये 6 लोग ट्रीट करेंगे या 8 लोग ट्रीट करेंगे तो मैं क्या करूं? मैं बाकी टाइम में मैं प्रैक्टिस करता हूं. कॉन्फ्रेंस देना मेरा बिजनेस नहीं बाबा. ओके, वी हैव टू ट्रीट दैट. Anything between 120 to 140 we have to treat. May not treat with the medicines. You have to treat by change in lifestyle, change in diet. Agreed? So say, we will treat that. We will treat that. If not, refer to Dr. Ratnabarki. Good. Next time तेरे को सामने बिठाऊंगा. So, high normal is a new concept. I'm telling you, nothing is new in this hypertension. High normal, you have to treat that. You have to pick up that, right? So newer concept is a pre-hypertension. Between a BP between 130 and 40, 130 and 140 has to be treated by non-medical management. Has to be treated. If we don't treat, in next 5 years, all these people will become established hypertension. Again, I am repeating. If you don't treat that 130, 40, 130, 140 BP, in next 5 years, almost all will go in established hypertension. Right? So you have to treat that to prevent the hypertension. Agreed? What is new in? First new thing, the mercury is going out. Government has banned the mercury. So whatever old BP apparatus we have, they are going out of things. Unki jagah, aneroids, Doppler, electronics, electricals are coming. This was the crude method initially. James Hall has put the, what we call, glass tube in the carotid of horse and measured the height column, and that was the first attempt to measure the blood pressure. What was the height of the tube or blood column? Anybody knows? Physiology? इसका आंसर मैं क्विज दूंगा आपको, प्राइज दूंगा. Quite nearby. Price though. 8.3 feet was the column. But actually, he has to show that some pressure is there, and that is a changeable pressure. The column was coming down, up, down, up, down, up. So BP variability was constituted that time. Now BP variability is coming in a big way. Oscillometric BP रहेगा, constant high BP रहा 180 कुछ नहीं होगा, constantly रहा 4 दिन 5 दिन कुछ नहीं होगा. If it is coming down 120 एकदम 180 120 180, that will rupture the artery because artery will not get time to adapt. Getting you? Getting me? Because if persistent BP is high, body will get, arteries will get adaptation phenomena. But if it is 120 80, artery सुस्त हो जाएंगे, फटकन 180 हो जाएगा, artery फट जाएगा. Okay, so oscillometric BP is very harmful. That is what the BP variability, and it's coming in a big way. That is new in 2023. You are aware of BP variability, but that is most important. You have to give the drugs according to BP variability. Okay, it is not check 120 happy. No, that drug will act for 8 hours, 9 hours, 10 hours. What about remaining? Again, oscillometric BP, right? So patient may have problem. BP variability, right? And if patient comes to you, you measure the BP nicely, but 50% of times, that circumstances is wrong. You are not wrong, I am not telling you wrong. Patient is also not wrong. The patient comes to you for the first time, anxious, stressful, BP is always on the higher side. So we write 160 by 100, start treatment, whatever. Okay, but 50 to 60% of time, BP is normal in such patient. That is what called as perfect. White coat. Why white coat? Because white coat, because of fear of that white coat, hypertension. Fine? Exactly reverse happens. This is what a variability. Even I am giving lecture, my BP will be on the higher side. Maybe, okay, or maybe may not be also, okay, because I am used to this. आपसे गप्पा मारने में क्यों बीपी हार्ड हो ना? That depends. If I am taking lecture really, I have to give knowledge to you, तो I am stressed up. अभी तो मैं गप्पा मार रहा हूँ आपसे ना, I am relaxed. My BP will normal. So basically variability, meeting, work, changing of the blood pressure, and that is significant. You don't realize. Even driving car सामने से आता है, 2 गाले मारते इसका मतलब मेरा BP 160 के ऊपर है. अरे क्या बीच में आया? Okay, so जब गाली मारा समझ BP उड़ गया. Okay, because that high BP tells brain, अरे गाली मार, because गाली will relieve that. Human psychology. Okay, white coat, we have seen that. Exactly reverse happen. चलो बाबा, रत्नवार की क्लिनिक में जाओ, एकदम मस्त पे की चाय कॉफी मिलता है, गप्पा मारो, ओके रिलैक्स है, डॉक्टर अच्छा है, बड़े बड़े मेडल लिखे हैं वहाँ है ना, एकदम रिलैक्स होता है पेशेंट, क्या अच्छा डॉक्टर है ना, तो बीपी एकदम नॉर्मल हो जाता है. वही ऑफिस में जाओ, वही घर जाओ, वही ऑफिस का काम, वही बीबी घर की, खुद के घर जाओ तो ना, तो नेचुरली एट वर्किंग प्लेस एट होम बीपी में हाई बिकॉज द वर्किंग एनवायरमेंट्स आर सेम. बट इन डॉक्टर्स रत्नवा किस क्लिनिक, ओ सूदिंग इफेक्ट, म्यूजिक चल रहा है, अच्छे अच्छे स्टाफ नर्स रखे हैं, चाय कॉफी देती है, ओके, और तब तक फीस भी नहीं मांगता है ना, जब तक होता नहीं पूरा तब तक फीस भी नहीं मांगता, रिलैक्स. ओके, सो दैट इज इनवर्स हाइपरटेंशन. Okay, mass hypertension, right? So, dear friends, all these things, even white coat hypertension and mass hypertension are dangerous, and the mortality and morbidity is almost near to the hypertension. So, we have to treat that. This is new in the 2023. Okay, so as I have seen that BP measurement at clinic may not be right all the time. So, there is a concept of home BP monitoring. It works beautifully. Now we have to change. Everybody, the presents of the birthday should not be cakes, should not be anything else. It should be a glucometer, it should be a BP apparatus. इतना भी आज तुम करोगे, so that is good. Okay. It costs hardly 1,000, 1,500. But checking BP, you are making that gentleman survive more. Okay, so real birthday wishes. Okay, so home monitoring, ABPM, ABPM agar, of course may not be available to you right at home, but ABPM is available with cardiologist that measures the 24 hours BP. And a 24 hours BP is not constant, it is variable. दिन में थोड़ा बढ़ा रहता है, रात को as you sleep nicely, BP comes down. That is known as nocturnal dip. 10% से कम होता है, right? Okay. Sometime now this is very important. ABPM is very important because sometimes there is rise of the BP in the night. You cannot measure. Once you measure, it becomes white coat hypertension. Night you cannot measure the BP. So you have to do ABPM. And in ABPM, you notice, oh, rather than coming down of BP, BP will come up. That is known as night risers. Okay, nocturnal hypertension. Ulta bhi hota hai. Normally there is a drop of 10%. If BP falls below that, BP अगर 120/80 का BP रात को सोते हो 70/50 हो गया, अरे your coronary perfusion is hampered. There will be arrhythmia और सवेरे वो उठेगा नहीं. फिर आप जाओगे डिसीज बनने, है ना, कार्डियोजेनिक कुछ भी जो लिखे हुए, ठीक है. So extreme dippers also there. Extreme dippers and risers are both are bad. Risers particularly common cause rise होने का बताओ. Very common. रात को कहाँ स्ट्रेस? Perfect. They give obstructive sleep apnea, which is nowadays very common, but very neglected. कितने लोग अपने में से घोरना बोलता ना, snoring. घोरना is common. Everybody say, yeah, घोर तो ठीक है, is a part of life. No, it is not a part of life. Ghorna is an abnormality. Snoring is an abnormality. Okay, and whenever snore, that is, it means patient has sleep apnea syndrome, obstructive sleep apnea. Because obstruction, that's why there is Ghorna. Okay, so you have to treat that. And in this situation, BP will be on the higher side. CKD, BP will be higher. Because what happens in CKD? Patient सोने के बाद क्या होता है? Central flow increases. मतलब flow to the kidney increases. Kidney में CKD है. किडनी काम नहीं करेंगे, उसके ऊपर ज्यादा काम डाल लो, बीपी विल राइज. गॉट इट? सीकेडी में बीपी रात को ज्यादा रहेगा. सो देयर आर सर्टेन डिसीजेस टू बी पिक्ड अप बाय एबीपीएम. सो once in life, at least once you diagnose the BP hypertension, patient has to undergo IBPM. May not be the day one, but in a wheels of time, right? This we already discussed. Early morning surge. These all things are new in management. We have never discussed. IMM इतना lecture देता हूँ, होता है नहीं discuss. This is new in the. They are emphasizing early morning surge. You are aware that most of the things, 40% of the adverse things happens in the sleep or just as soon as we wakes up in the same. क्या क्यों होता है? Catechol or sorry, absolutely. Rise of cortical or adrenaline system. Okay, we will get अभी तक अच्छे सोए हैं, parasympathetic drive is there, adrenaline drive कम हुआ है. As soon as it gets up, okay, body activation चालू हो जाता है, then the adrenaline level rise, cortisol level rises, and there is a high blood pressure, right? Okay, so that is abnormal morning surge. When we call abnormal, when it crosses particular level. What is that? Because cortisol level उठने के बाद बढ़ता है, that is a common phenomena, that is the physiology, right? What level it crosses, that we can label that morning surge, abnormal morning surge. It is not a figure. It is not a one measurement of BP. You have to take two readings in the night, average it, take a reading at morning 10 o'clock, whatever, and if that is more than 25 mmHg, that is abnormal morning surge. And such patients will have abnormal. So that is new in the management, right? So BP more than 25 mmHg compared with two average measurements in the night. Clear? Response? It may be 8 o'clock, 9 o'clock, 10 o'clock. What time you gets up, what time you become active. Okay. Okay, so there are more CV event. This is the same thing, we have seen that. Okay, ABPM we have seen, newer concept we have seen, almost all patients of pre-hypertension will develop hypertension. And as I mentioned that, are you happy with BP of 130/80? Many will say yes. See the result. If your BP is less than 120/80 and that rose to 135 to 85, mortality doubles. May not be reflected directly population, but if you see the statistic, double log marte hai. So 135, 134, don't be happy. Treat it. Okay? This is what we are learning new in 2023. There are certain words in the casualty, what we face. अरे रत्नार की पेशेंट भेज रहा हूँ, BP 180/120 और कैसा तो भी कर रहा है. That is what? Crisis, hypertension crisis. Diagnosis में लिखा होगा ना, hypertension crisis. What is hypertension crisis? There are two entities. That is hypertensive emergencies and hypertensive urgencies. क्या फर्क है? हाँ, I know. This is just for reference. 7 years back. JNC बहुत आगे है, तो तुम आपको बताने के लिए बोल रहा, आप भूल जाते हो ना, इसलिए. So, but the urgency and emergency remains there, whether JNC comes or goes. This emergencies and urgency remains there. Urgency means there is high blood pressure, diastolic more than 115, 120, but there is no end organ damage. Okay, maybe some chest discomfort कैसा लग रहा, but no end organ damage. But urgency, yes, there is end organ. Patient को encephalopathy हो गई है, patient को acute renal shutdown हो गया है, patient को severe angina हो गया. Okay, so that is known as urgency, emergency. Emergency, end organ damage. Urgency, high BP. Okay, but if you don't treat it properly, it will go into that. Okay, you remember this gentleman? कौन? Kennedy. नाम बदला उसने, मालूम ना, 1200 झाला माहित ना तुम्हाला आवटी साहेब. हाँ, वाचलं का खाली? हाँ, what is the खासियत of Roosevelt? Who was he? रशिया प्रेसिडेंट बोलता है, तू यूज बोला, टॉस करो. Israel. He was 4-time president of USA. Record. More than 13 years he was president, and he died because of hypertensive encephalopathy or hemorrhage. Right? See the BP during election. His BP was 300/200, and it is in the year of 1945. That time, medicines were hardly available. Sorry? Oh, but that time during elections. Okay? So he died just because there were no treatment, only Reserpine or something diuretic was there. Right, sir? He died. And that was a big news in the paper. Okay? That is because of cerebral hemorrhage. And this was postulated because postmortems वगैरह patient का नहीं हुआ करता था that time, right? So they are postulated. So the concept of hypertensive emergency comes like this. So urgency we have already seen when there is a high BP, more than 115 diastolic or even 120, and mean pressure more than 120 again. But in such situation, may admit for observation or may not observation, call in frequently, give the drugs, reduce the BP in 24 hours. But emergency, you have to admit the patient because there is a damage to the brain or heart or kidney or eyes or all four. There is no specific criteria. High BP, even 160/100 may produce hypertensive encephalopathy in young people because they are not used to that. Their hemodynamics here, their auto-regulation system here is not regulated. What I say, oscillometric BP is very harmful. So BP of 160/100 also can produce hemorrhage, can produce encephalopathy. Okay. So whenever there is damage to the organs, high BP is high, we call emergency. So we have to treat immediately. Okay. So epidemic will not go into that. These are the various causes. You are aware that, particularly aortic dissection, coarctation, Cushing syndrome, elevated intracranial pressure, renal dysfunctions, pregnancy, eclampsia, preeclampsia, thyroidism, hyperthyroidism, fucosidemia, aldosterone. These are all basically endocrine related secondary hypertensions may produce these emergency or urgencies. Management, better refer to hospital where all these facilities are there. You are in such situations, you have to reduce the blood pressure immediately, particularly the pulmonary edema and dissection of aorta. In other cases, you can take some time, 1, 2, 3, 4, 5 hours. But you have to admit the patient in ICU, hemodynamic monitor, give intravenous drugs. These are the drugs which are to be used in hypertensive encephalopathies or hypertensive emergencies. There also, when we were doing MD, that time considered accelerated hypertension. That is gone now. But still, we people are using that. So when there is a rapid elevation of the blood pressure within last 2, 3, 4, 5 दिन में एकदम BP बढ़ गया. That causes accelerated hypertension. Do the fundoscopy, you will get grade 3 Keith Wegener's Becker's retinopathy. That is, there is a hemorrhage and there is exudate. Okay. There is also known word when we are doing MDD, malignant hypertension. We are not using nowadays malignant hypertension, but whenever there is a high BP with papilloedema, grade 4 retinopathy, that is malignant hypertension. There is now concept of resistant hypertension and refractory hypertension. What is resistant hypertension? More than 3 drugs. Perfect. BP is not coming below 140/90. In spite of 3 drugs, 1 will be diabetes. That is what resistant hypertension. And it is not coming down with 4 drugs or 5 drugs. That is called malignant. That is called a refractory hypertension. Okay, so 3 drugs, resistant hypertension, 5 drugs, refractory hypertension. It is said that resistant hypertension is because of the volume alternation or salt sensitive. ज़्यादा बोलता नहीं मैं, specific बोलता हूँ. Okay, resistance hypertension because salt sensitive volume alternation. So you have to give diuretic. Okay, and refractory hypertension is probably a mixed picture of volume plus central nervous system, adrenal nervous system, sympathetic nervous system. So you have to give other drug also. In that also you have to give 2 diuretics. Okay, thiazide-like and potassium sparing or other group of the diuretic. So 5 drugs you have to give. उसके बाद तो देते जाओ जो होता है, ठीक है? So the reasons we have known that cause of resistant hypertension is same what the urgency and emergencies are there. Now what is new in 2000? बाकी ट्रीटमेंट में बात ही नहीं करूंगा. Amlodipine, A, B, C, D of antihypertension. I don't. A for A, B, C, D of hypertension. A for ACWARB. B for beta blocker. C for calcium blocker. D for diuretic. Okay. This age group में ये देना वो सब आपको मालूम है. But what is new? I am going to tell. So pre-hypertension is new. Treat that. Okay. Morning surge is new. Treat that. Nocturnal hypertension. Treat that. रात में बेचारा सोएगा उठेगा नहीं. Right? And device theory is new. Hardas is there. We are putting device for hypertension also. You might not heard also. We all intervention cardiologists. कौन और कौन है साथ में? अपन दोनों ही है. 50% तेरे को, 50% मेरे को. बांट लेंगे. हाँ, आधे इधर के इसको भेजना, आधे इधर के मुझे भेजना. Anyways, Suhas Hardas was my senior 1 year senior in JJ Hospital while doing a DM card. Okay. So whatever I am telling, he has taught me. अच्छा लगा, credit goes to him. बुरा लगा, credit goes to him only. So device therapy, commonest is the renal artery stenosis, right? So we do renal stenting. Of course, there are specific indications of renal stenting. I will not go into that, but if there is a flush edema or rise in the renal venous system, renin system, renal venous renin system, that time that is indication of renal stenting. So we put a stent there. We do the coactoplasty. Coact patient will definitely present with hypertension. We have to put stent there. Okay, coactoplasty, BP will come down to normal. Okay, or aortoplasty, it's just like coact. If there is some block here, we do the aorto or aortoplasty. So we have to do stenting of such narrowed segments. Then comes two things are coming into big way. That is device-based therapy. One is renal denervation therapy. Second, baroreceptor activation therapy, BAT and RDN. Okay. So basically they are against the sympathetic outflow. It is said that the renal artery has a very overflow of sympathetic activity. If you contract it, if you destroy that renal sympathetic system, BP will come down. Okay. So before that, we'll discuss about the BAT therapy, baroreceptor activation therapy. There is something here. There is some baroreceptors. Okay, it is just like a pacemaker-like device. Once it's stimulated, it will reduce the sympathetic activity. Okay, this is what the baroreceptors are there. We can put pacemaker-like things there, which we can give one voltage. This same thing, pacemaker-like things wire near the baroreceptors, and we stimulate that baroreceptor. What will happen as soon as baroreceptor is stimulated, BP will come down to normal. This is what the things rightly said. Normal BP is 200 by 10 by 96. We give a one voltage small shock at baroreceptor. BP will come down to 168 by 73. Heart rate will come down. So sort of vagal activation or some sort of parasympathetic activation. So BP and heart rate comes down. Okay. If you increase the voltage, then BP will come further down. So voltage of 2, 3, that changes with the person to person. So the BP can be managed with 140 by 80, whatever, 60, 60. Okay. So it's just like a pacemaker. Put a pacemaker here and have activation wires near the carotids. So that is what the BAT therapy is. Okay, and this is what the RIOS study which has shown. In first year there is drop of 25 mm by Hg of systolic blood pressure, and after 3 years follow-up, 31 mm Hg of drop of systolic blood pressure, which is huge. So you can stop all the antihypertensive, only one device can work. Okay, of course these are in experimental or in selected patient only, not to be used routinely. There is also a unilateral carotid body resection, again related to this because it activates sympathetic activity. Okay. Renal denervation. I remember 6, 7, 8 years back, I had gone to Germany for this training, 3 years. Medtronic ne bheja tha apne ko. So we have done that course of, I had done 8 denervation. Uske aane ke baad samjha ki simplicity third has ruined that data. So we have to stop that. Anyway, there is a denervation of renal artery which will reduce the sympathetic outflow and reduce the blood pressure. There are lots of trials, simplicity 1, 2, 3, the later on radiance 1, 2, 3, later on spiral 1, 2, 3, which has shown in selected patient you can do this denervation and you can get adequate blood supply control, particularly in resistant patient. That time the simplicity criteria, those who are not getting control with more than 5 drugs, refractory. Okay, so we have to do that. Okay, so this denervation may be because of, may be done through radiofrequency or ultrasound or even by injecting the alcohol into the tissue, right? These are the various sites where activation of these sites produces increase in sympathetic activity. So these are the targets where we can do something to produce reduction in the sympathetic activity and reduction in the blood pressures. Okay, again this is theoretical. And is there any vaccine? If people will be very happy if there is vaccine to the hypertension, right? Attempts are being done since 2003. Okay, the targets are targets are RAS system only, angiotensin 2, vagare vagare vagare. Okay, so these are the various targets. Okay, I don't want to read that all these things. Okay, these are the targets where vaccine can act, produces sort of RAS inhibition and produces a reduction in the blood pressure. There are, again I mentioned angiotensin 2 vaccine against that. Okay, so DNA vaccine, angiotensin therapeutic vaccine. There are so many vaccines. The trials are still going on. Soon we may get some good news. Okay. So particular vaccine will be very important in elderly patient with dementia or patient who are not adhered to the treatment. So vaccination against angiotensin 2 may be useful. Again, this is experimental basis only, not theoretically. So experimental basis, soon we may get good news of vaccine also. And there are newer drugs coming for the hypertension, that is aminopeptidase A inhibitor, that is APA inhibitor. Second, VIP agonist, sodium hydrogen exchanger inhibitor, endothelin inhibitors, darusentan, bosentan, still available for pulmonary hypertension. Why not to use in hypertension also? So these are the newer targets where the antihypertensive can act. Again, nitrous oxide is a natural vasodilator. So we have to have target therapy for that. Okay, so many things coming. This particular SGLT2 inhibitors, they are initially came as a diabetic therapy. Now they are coming as a antihypertensive also. Even ARNI came initially for the low LVEF. Now it's coming as an antihypertensive therapy also. Right? So whatever the therapies, these are all newer things in 2023. Whatever are the therapies, use nicely, see the patient profile and reduce the blood pressure. That is the target. And while reducing, just don't see the numbers, see the organs also. The organ protection is very important. If you reduce the blood pressure significantly and giving proper medicine, you can reduce the stroke by 40%, microinfarction by 25% and heart failure by 50%. Huge difference. And don't bother, अरे 2 mm से क्या छोड़ना, 142 चलता है, no. The चलता है attitude is not good. Even 2 mm of Hg will reduce significant mortality and morbidity. 2 mm of Hg systolic blood pressure will reduce 7% risk of ischemic heart disease mortality and 10% risk of stroke. 7 and 10% is a huge amount, boss. 10%. Okay. So even 2 mm of Hg reduction is very important. Okay. Not only systolic, diastolic you have to see. Diastolic, if you reduce, again 7%, 6% reduction in the ISD and 15% in stroke. So be meticulous measuring blood pressure. And only medicine is not important. This thing has to be checked properly. So treat the patient, treat the clinical profile of the patient, and patient will survive more. He will bless you. Thank you very much. There was a study by psychiatrists, population study, that say that 80% लोगों को लगता है, बंद कर दिया slide, कि anyway, last slide. 80% people, Rendra, slide दिखा ना? 80% people think that hypertension और heart का कोई संबंध नहीं है. 60% say that hypertension मतलब stress है. जो stress कम कर दूंगा, BP will come to normal. Okay, no need to go to doctor. 40% still feel that medicine is not required, doctor is not required. Okay, so this is a Indian study by psychiatry. So there is no need of doctor, ऐसा लगता है. So that's the reason mortality and control rate is, mortality is high and control rate is low. Okay, so I was expecting this picture, but खाली पेट नींद नहीं आती ना, तो मैंने तो सब दरवाजे बंद किए थे. Anyway, now be a gentleman. We know that 800 people in the hall. If everybody goes, there will be long queue. So let the elderly people go. Let the diabetic people go. Young generation, stay with us. We will have a quiz for 20 minutes. Okay. And after 15-20 minutes, yes, question I will take. After 20 minutes, the rest of things can join. Okay? First class. Thank you very much. Bolo. हाँ बोला ना. हाँ. 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 ठीक है.
Sir,
Next lecture is on intervention only.
Okay.
Dr. Harda is going to speak on intervention block and all this. Why pumping is not improving? Okay, he will answer that question.
Okay.
Otherwise, I will answer the question. I'm here. He's going.
okay, sir. Thank you.
And before that, my friend, the leader of BJP, the MLA of this area, I invite Mr. Murji Patel ji on the stage. चालेल. इट्स अवर प्लेजर टू वेलकम हिम. सर बैठे. प्रकाश आ जाओ. ठीक है. मोमेंटो आणि 5:30. क्यों? अभी ये आने वाले अपने 3 बजे. कैसे कैसे ये ना दे. राम ये रहा. नहीं सब गणपति बाप्पा मंगल मूर्ति. सर ये एक छोटा सा दिया. थैंक यू. बोला सर. हेलो. मनोज डॉक्टर सुहास होरा सर्व फार्मा कंपनीला आतमध्ये पाठवा. मनोज ध्रुव डॉक्टर सुहास होरा सर्व फार्मा कंपनीला आतमध्ये पाठवा. सागर क्विज कुठून आली. हॅलो. फार्मा कंपनीचे सर्व लोक बोलवा. सर्व फार्मा कंपनींनी आतमध्ये यावं. त्यांचं फेलिसिटेशन करतोय आपण. नेक्स्ट क्वेश्चन. Those who are sitting, they are for the prizes. Okay, so they will get prizes. Fine. इंतजार का फल मीठा होता है. Okay, question. Just raise hand and say yes. Huh? Don't give the answer, please. हे झालं व्हायचं हे व्हायचं. Which is the most populated city in the world? बरं हा. टोक्यो. चलो फर्स्ट क्लास. हाँ दे दो. Anyway, to give an extension, really you are knowledgeable or not. Which is the second one? वापस ले लो. हाँ. No. 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 Indian नहीं है. न्यूयॉर्क is the second one. And third is very important. Mumbai. Third is Mumbai. Most crowded. फार्मावाले आले सर्व. ते लिस्ट प्रमाणे आहे का बघ. चेक कर बेटा. ब्राझील झालं. Today is a match against क्या Australia? झाला? नक्की? सांग ना मला. Yes, we respect Mother Teresa, right? Mother Teresa was born in which country? Sir. Wrong number. Spelling bata. Macedonia. Okay, the city's name is Skopje, Skopje North. Okay. You play basketball also? What is the height of that net where we put the ball? From the ground level. Basketball. डालते ना वो? Don't shout answer. Please say yes. Ten feet is absolute right correct answer. दूसरे वाला है ना ते? आले पूर्ण आले याच्याकडून काउंटर चेक करा. Very important question. And there will be extension. Answer देने पे direct मिलेगा नहीं. There will be extension because very common answer. Which country has the longest railway network in the world? अरे जाओ मत दो यार. Please. मेरा बीपी मत बढ़ाओ. अभी तो हाइपरटेंशन में लेक्चर दिया मैंने. हाँ क्या?
जिसको आता है खाली हाथ उठाओ. सर बोलेंगे ये तो उनको ही नहीं तो सबको माइनस मिलता है. सो प्लीज डोंट डू दैट. सबसे 100 रुपए लूंगा मैं. पूरा खर्चा कॉन्फ्रेंस का निकाल लूंगा. हाँ चाइना रॉन्ग आंसर. 100 रुपए ले चल. यूएस. US is the right answer, but that is not my question. Which is the second one with the highest railway network? Very good. Very good. China is the right answer. किसने दिया था? Which is the country which is producing highest रबर? कौन है? हाँ मागे मागे कौन है? हाँ मलेशिया राइट. उसने पहले हाथ दिखाया. Say shout. Sound travels fast than the visual, right? Yes. चिल्लाओ मस्त पैकी. Which planet? Say shout, हाँ मैं कस मैं इधर देखूंगा तो इधर नहीं देख पाऊंगा. Shout. I can listen. खाना लेके अंदर नहीं आ सकते. ओके फिर से दरवाजे तो दौड़ तोड़ना पड़ेगा मुझे. तानाजी मालूस पर. Which planet has more satellite than any other planet? कौन है? कौन चिल्लाया? सर मैं तब से बोल रहा हूं मत आंसर तो प्लीज. नेक्स्ट क्वेश्चन. सबका प्राइस सर के वैसे उससे लो. 100 रुपए लो. 100. प्लीज डोंट शाउट द आंसर. से यस और ओके. Saddam Hussein was captured by US. Which city? Sorry? हाँ बोल. सद्दाम इसे इराक से सीरिया गया था. हाँ तूने गाड़ी बुक किया था उसके लिए. हाँ सद्दाम हुसैन. बिन लादेन की बात कर रहे हो?
पहचान करता है तेरा? वो भी गलत आंसर है। बिन लादेन को अबाटाबाद में मारा गया उसको। हाँ, क्विज मास्टर हूं मैं, ऐसा नहीं। इराक में मारेगा ना उसको, कहाँ पकड़ेंगे वो, अमेरिका तो पकड़ेगा। इराक कहाँ पकड़ा गया उसको? अरे एक से बोलो ना यार प्लीज। हाँ हाँ, नेक्स्ट ट्रिप बगदाद में। हाँ हाँ इधर मैडम, नहीं तिरकिट, तिरकिट में पकड़ा गया। हाँ हाँ, तो मैंने बोला ना। Which country has टाउन पूछा, मैंने विलेज नहीं पूछा। तो बोलेंगे विलेज नहीं मालूम, फिर बोलेंगे कौन से एरिया में पकड़ा है ना, अंधेरी के में वो जेबी नगर में मारा गया। ऐसा नहीं हो सकता, इतना तो होशियार नहीं हुआ यार। ओके, क्रिकेट में मारा गया ऐसा न्यूज में देखा था, एबीपी माझा आया था ना वो, उसने बोला था। और बस कौन से गली में, गली नंबर 420, आई डोंट नो। हाँ सॉरी, आई वाज आस्किंग विच कंट्री हैज हाईएस्ट नंबर ऑफ ह्यूमन एंड शिप रेशो। ह्यूमन एंड शिप रेशो म्हणजे मटन खाने वाले, चिकन खाने वाले। राइट आंसर। चल, इवन इफ ही सेड फर्स्ट, ही इज पेनलाइज्ड फॉर दैट फर्स्ट मिस्टेक। सो मैडम को दे दो, आई एम वेरी स्ट्रिक्ट पर्सन। Very interesting question. Don't say into the Google. India and China share a border, right? What that border called? हाँ, आंसर क्यों दिया? आंसर क्यों दिया? हाँ मैडम। हाँ नहीं, that border is called as 100 रुपये। सच्ची ले, तब तक सुनेंगे नहीं लोग। अशोक ले पैसा ले, सो तब तो सुनेगा नहीं वो। रियली ले, हरदम क्या अपन ही देना क्या? निगेटिव मार्किंग अब यार, इसके बाद गलत आंसर और चिल्लाया तो पैसा लूंगा मैं। उसमें डालो। परफेक्ट आंसर इज मैक मोहन लाइन। मैक मोहन नाम का एक हीरो था ना, हीरो यानी नहीं, तू नहीं, नहीं वो वाला, वो आदमी नहीं हो। हाँ सांबा। हाँ सांबा को कौन सा क्वेश्चन पूछा गया था उसको? कितने आदमी थे? ये क्विज नहीं है। ओके, वील स्टॉप हियर, वील कंटिन्यू आफ्टर द रश, टिल द रश। मीनवाइल, see, no conference is possible without pharma, right? So it's our duty to say thanks to them. Relentlessly they are working on the field for the population, for the doctors. So they are the integral part of our medical practice. So they should be felicitated properly. So we'll call one by one all the companies with their entire team, with their bosses, and I will personally say thanks to all of you. Thank you.
IPCA Laboratories, IPCA, अरे बाप रे, IPCA Laboratories नहीं, सिप्ला, सिप्ला की टीम आ गई, सिप्ला, फुल सिप्ला टीम। मैं आ रही है क्या मैं घेत ना तिचा आधी हो बोलते का है ना अल्केम भी है अल्केम कुठे गेला Alembic Pharmaceutical, full team, Team Alembic, Team Lupin Limited, Alembic. हाँ. Team Lupin, Team Lupin, बहुत ही हंसी में हे काय अजून आहे का? तीन थँक यू टीम मायक्रोलॅब्स टीम मायक्रोलॅब्स टीम USV Pivoted Limited टीम USV Pivoted Private Limited सॉरी आहेत की नाही हा आहेत USV हां कोण नाहीच आहे आता टीम मॅक्लॉइड्स फार्मास्युटिकल्स टीम फुल टीम मॅक्लॉइड्स अरे येत आहेत ते Team Augmentis Healthcare Limited. Team Augmentis. और टीम ऑक्यूमेंटिस नहीं है. एमक्योर फार्मास्यूटिकल्स. फुल टीम. जल्दी जल्दी आ जाइए. आए. टीम अबॉट. टीम अबॉट नहीं है. आहे ना. जेवले. टीम बायर झायडस. टीम बायर साइडस है कि नहीं. टीम मेरिल लाइफ साइंसेस इंडिया. सन फार्मा. सन फार्मा होल टीम. होल. टीम टॉरेंट फार्मास्यूटिकल्स टीम. ये कोण आहे. हो घेतलं ना. आले ना. नाही 3 आहेत मध्ये राहिलेले. Team Glenmark. थँक्यू सो मच.
एकदम जबरदस्त म्हणजे गोविंदापेक्षा तुम्ही छावून गेला
अरे अरे थँक्यू सो मच.
इपका का है नंबर इपका का
इपका का है. अभी ग्लेनमार्क बुलाया है. 2 मिनट रुको. आप ही रह गए बस. हाँ. टीम ग्लेनमार्क. Team Ipca and Augmentis, be ready. कोण आलंय? हाँ मेरे लाइक. कौन टीम आया अभी? टीम इपका. राम इपका है ना. हे टीम ऑक्युमेंटिस. अल्केम. हाँ अल्केम एक. आप रेडी रहो. मैं अभी आपका नाम नाही या लिस्ट मध्ये नाही. मग बोला त्याला. टीम ऑक्युमेंटिस. टीम ऑक्युमेंटिस. मेरी लाइफ. मेरी लाइफ. टीम मेरी लाइफ, बी रेडी. टीम मेरी लाइफ, बी रेडी. टीम मेरी लाइफ. टीम अल्केम. मेरी लाइफ राहिली. मेरी मेरी Thank you all pharma people. Without your support, CardioCon was not possible. We thank you from our bottom of heart. सर एक मिनिट माझी क्वेरी
ते आपले ना दीपक केसर कसं येणार आहे त्यांच्याबरोबर
हेलो मी दिसतीये का?
सामने ऐसा 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 ऐसा
Hello. Hello. Those who are in the hall, they must be respected. They must be. Given a prize for their loyalty or time management, right? So we'll start with lucky draw and followed by bumper lucky draw, right? Chalo. Yeah. Hey, there. गिफ्ट किती बाहर जिसका खाना हुआ है वो अंदर आ जाइए। लकी ड्रॉ जो हॉल में है उनको ही मिलने वाला है। दोज हु आर प्रेजेंट इन द हॉल विल गेट द प्राइजेस। डॉक्टर जॉन Ask everybody to come in. Ask everybody to come inside. Dr. A.K. Pandey. Dr. A.K. Pandey. 98210. आगे का आप बताओ। नंबर बताओ। परफेक्ट। 29317, राइट? किसी ने डाउट नहीं है कि दो पांडे हो। ऐसी बातें नहीं करना। हाँ, ये बात मत करना। अंडर कवर एजेंट्स है। बेल वाजली रे बाबा। डॉक्टर इरफान पठान। नहीं है कुठे नेवर गिव अप हर टाइम मिलता है आपको, ऐसा सुना मैंने। निकाल उसका
सर मी अनाउन्स करते, तुम्ही द्या गिफ्ट्स.
है ना काजा का गजब ना। डॉक्टर गणेश जायसवाल, डॉक्टर गणेश जायसवाल, सब आप आपके दोस्त को अंदर बुला लो, अभी बम्पर प्राइज का टाइम आ गया है, इसलिए नहीं बुला रहा कोई, है ना। दोस्त को बड़ा, मुझे छोटा प्राइज मिला, लेकिन दोस्त को बड़ा मिला ज्यादा दुख लगता है ना। रमेश एलएस, रमेश एलएस कौन? सर वाउचर नंबर, हाँ मुझे लगा बाहर जा रहे क्या वो। जीरो 43 परफेक्ट, लास्ट 2। डॉक्टर मुकेश बियानी, मुकेश भाई किधर गए वो? नहीं, मोहम्मद इकबाल, ये भाई वो कौन खड़ा? नहीं आ रहे हो, इधर ही आ रहे, नहीं ना, नहीं अलाउड नहीं ना। डॉक्टर ईला शाह, ना बाहर है। मनीषा पवार, डॉक्टर मनीषा पवार कौन है?
आ रही है कि नहीं आ रही है?
मनीषा पवार, नहीं नहीं, ओके ओके, इट्स ओके, नो प्रॉब्लम। अच्छा डॉक्टर मनीषा पवार ना। डॉक्टर निशिता पुजारी, निशिता पुजारी नहीं, डॉक्टर पुजारी लास्ट है, लास्ट लास्ट फॉलोड बाय बम्पर 1। डॉक्टर केतन भट्ट, यस एकदा बाहेर अनाउन्स करून द्या की बंपर प्राइज करते आतमध्ये या म्हणा, जेवण झालं असेल तर। ये आहे ना इंट्रोडक्शन आहे ना उसका। राम कुठे आहे? इतना तो याद है मुझे, राम को बुलाओ, उसका चिढ़ा थे उसको ये गाना में, हर टाइम वही गाना बोलता है वो। राम जेवतो यार, आम्ही जेवायचं सर्वजण, उसको बुलाने के, इतना तो याद है मुझे, हाय आला आला राम देवा, ऐसा है। कुछ लोग सिर्फ एक बार बाहर अनाउंस कर दे कि बम्पर प्राइज निकालने वाले हैं। हाँ चलो ओके, it's a time to have a bumper prize worth of more than 7,000 6,500. Let us see. All the precautions are being taken. Hello, usko. बस हो हैप्पी कि और ओके टाइम फिनिश्ड बाय ओके दिल थाम के बैठो दोस्तों गजाला शेख कौन है गजाला शेख है ना
पीछे भी देख लो यार ताकि दूसरा निकालो जल्दी।
चलो थैंक यू वेरी मच ओके आई नो यू पीपल आर नॉट इंटरेस्टेड इन द गिफ्ट्स यू आर इंटरेस्टेड इन एकेडमिक्स सो ओके आपको भूख भी नहीं लगती है मैं देखा मेरे लेक्चर के वक्त आप इतने अच्छे सुन रहे थे कोई भूखा नहीं था बेचारा तो your hunger for the academics. Should we start? ज़्यादा आवाज नहीं आ रहा है Should we start? क्या नहीं है चलो My food अरे वो एटलीस्ट somebody is taking care of my food thank you very much मैं लेक्चर के साथ जैसे चालू हो जाऊंगा तो मैं खाना खाऊंगा ओके क्योंकि ही वॉज माई टीचर इन जे उसने ऑलरेडी सिखा दिया मुझे तो अभी मैं फिर से नहीं सीखूंगा ऐसे है ना हाँ हाँ तो मैं तेरा से सीख लूंगा ना रजिस्ट्रेशन में तू 3 साल मेरे को बहुत सिखाया है ओके तो अभी क्या सीखना फिर से तेरा तो सुनना नहीं है स्वाद आया लेकिन अच्छा लगा मेरा मैंने वीर बैचमेट मतलब सीनियर था मेरा 1-2 साल पर साथ में जो डिपार्टमेंट में काम करने का जो मजा आता था वेरी डिपार्टमेंट वॉज फुल ऑफ वर्क डेली 25-26 एनजीओ होते थे बाद में नाइट ड्यूटी देन इको 100 इको वगैरह होते थे और वी आर हार्डली 4 पीपल शेयरिंग ऑफ वर्क मच झापझूप शेयरिंग केयरिंग एवरीथिंग वॉज शेयर्ड बाय सुहास इज वन ऑफ द जायंट कार्डियोलॉजिस्ट पुणे का सबसे बड़ा कार्डियोलॉजिस्ट ऑफकोर्स शी विल इंट्रोड्यूस बट मैं मन से बात कर रहा हूँ ना और ही केम पर्टिकुलरली फॉर मी ओनली yesterday ही वॉज इन यूएस कल रात को यूएस से हाँ अच्छा तू कहाँ पता कहीं तो ही बाहर था बेचारा रात को 11 बजे आया और सवेरे दौड़ के आया एनीवे वी आर हाईली ओब्लाइज एंड वी आर ओब्लाइज बाय ऑल ऑफ यू ओके आप प्रेम स्नेह से ये सब चल रहा है थैंक यू एंड सुहास दिस इज 6th ईयर एवरी टाइम वी आर गेटिंग इंक्रीमेंटल नंबर्स टुडे वी आर ऑलरेडी कंप्लीटेड 960 रजिस्ट्रेशन प्लस हमारा कोर ग्रुप अलग है 50 का प्लस फार्मा वाले सब जो भी आएगा वी आर नॉट रिस्ट्रिक्टिंग द नंबर्स आओ आपका ही कॉन्फ्रेंस बिकॉज दे आर द विनर तो उनको भी आओ आपका ही कॉन्फ्रेंस है
एक फार्मा वाले ने पूछा हमारा खाना यहाँ है कि वामनी सबका साथ में
हाँ
सबका साथ में है
अरे शी वॉज टेलिंग फार्मा वाला आस्किंग कि हमारा खाना इनके डॉक्टर के साथ है कि अलग है वी सेड नो इट इज सेम फॉर एवरीबडी सो से हम साथ में सबके I mean that is what a touching moments okay ultimately see we are a family okay anyway let us start the things I will hand over mic to my sister Deepali Kate before that one last felicitation Merrill Life Sciences Subrato किधर है हाँ
और वीडियो चालू कर रहे तो
Subrato is a gentleman from the Merrill company who makes this tower walls, aortic walls. Here,
Every doctor's journey begins with a promise. I promise to care for the sick and alleviate pain and suffering. No matter how difficult the task is, they always do what's best in the interest of the patient. I recognize that the practice of medicine is a privilege, with which comes considerable responsibilities, and I will not abuse my position. To do everything it takes to fight for you and your loved ones. I will maintain the utmost respect for human life, and nothing will be more important to me than saving one. And they will stop at nothing. I will practice medicine with integrity, honesty, humility, and compassion. In every practice of my science, they promise to add more to the life of every person they treat. And as medicine, we take this promise alongside doctors and bring together the best of medical expertise and research to empower doctors to win every single time. Because when doctors win, humanity wins. Men, more to life.
Thank you, Dr. GPR, sir. Hello, everyone. Good afternoon. After a very delicious and scrumptious lunch, I am Dr. Dipali Kate, MOC for last session. Welcome you all again, and our eminent speakers, our dignitaries, and all the delegates. Without wasting much time, I would like to invite on stage Dr. Suhas Hardas. Suhas Hardas is practicing in Ruby Hall Clinic, Pune. He has earned a MBBS degree from BJ Medical College, Pune, DM from JJ Medical College, Mumbai. Dr. Hardas has performed multiple complex angioplasties and thousands of permanent pacemaker implantations, as well as complex devices such as cardiac resynchronization therapy, ICD implants, and other complex devices independently after receiving extensive training in coronary inversions and electrophysiology in India, Australia, and Germany. Dr. Hardas has awarded Complex Case Tutorial Best Performed Case of the Year, TCT, Washington, D.C. 2006, Best of ECS India 2009, and many more. Dr. Hardas has nearly 25 research papers published in prestigious medical publications all around the world. A huge round of applause for Dr. Suhas Hardas. Sir, please welcome on stage.
Good afternoon, ladies and gentlemen. I think Gajju, I would want him to be here inside. Can you please give a shout to Dr. Ratnaparki? I want him to be here at least for the initial introductory talk that I must make in commemoration of our love and affection for each other. He was actually right in saying that I was not here. I was not overseas, but I was trekking in Himalayas, and we trekked approximately 76 kilometers in 5 days, climbed a height from 9,000 until 16,000 feet. We arrived in Pune late last night, and I sorted my slides this morning. Early morning I woke up. Gaju, please sit down. So we went to Rishikesh. From Rishikesh we trekked. Then we went to a place called Jyotirmat or Joshimat, which is commonly called as Joshimat. And from there we went to Govind Ghat trekking, and from Govind Ghat to Pulna. Once again trekking. So it has been a very strenuous and effortful week for me. And when Gaju called me a couple of weeks back, and I said, yes, I will. And it is only because Gaju, I'm taking this privilege of calling you Gaju, had a very special ability of bonding people. As he said, we were just 4 or 5 of us, and we worked our guts out in the department. Hundreds of echoes, lots of angiograms, too many things to report. We had extremely demanding professors and teachers who would want the task to be completed by midnight, etc., etc. But I must congratulate all of you that you have somebody like him leading the entire clan of doctors that are present here. He has very special ability to bond people, whether it was my professor or me as a lecturer or his juniors. He kept everybody bonded extremely well. Extremely hardworking, very dexterous, very good with his hands, skills, knowledge. So for that knowledge, love that we shared, I'm here today, Gaju, after a long, long effort. Thank you very much for calling me. When he asked me to speak about a topic, I said, you tell me, and he said, you speak about tower. But if I only spoke about tower for 40 minutes, it would become too much because you are a cross-section of doctors who are family physicians. Some of them are surgeons, I believe. Some of them are gynecologists, I was told. So I must speak something which is of interest to everybody. What are the newer developments in interventional cardiology? First of all, we must know what is the interventional cardiology. It is a treatment modality. If you would want to grab a bite, please go ahead. I just wanted you inside for this introductory words. Thank you very much, Gaju. Now, nowadays we accomplish most of the intervention via a radial route. There are multiple drawbacks of carrying out an intervention through the femoral route. Retroperitoneal hematomas, there can be aneurysms, there can be pseudoaneurysms, there can be local bleeds, etc., etc. But we have, for the last 19 years, out of 23 years that I have practiced in the city of Pune, after I have had overseas training in Australia for 4 years, I was in the US for some time, I came back and took up a job in Hong Kong, then in Singapore, and finally I decided that the best place to practice and give away all this was India and to my brethren. We have been, thanks very much, we have been doing most of the interventions via the radial approach. This is a short little film which I will play here, but you know how the radial route works. Not only just angioplasty, but very, very complex interventions like left main reconstructions, triple vessel disease, rotablations, intravascular ultrasound, optical coherence, tomography, intracoronary imaging. You can name a very, very complex intervention and we do it through the radial route. Even in TAVR, that is the transcatheter aortic valve replacement, we use a filter for the carotid protection. For the prevention of cerebral emboli, we use it through the radial route. And as I said, the mobility after this intervention is immediate. The person can walk off the table and is home in the evening. I have ran a center in the city of Pune and we have analyzed the data of 700 angioplasties done consecutively, of which 649 were done through the radial route, only 51 because of the clinical indication we had to do to the femoral route, because sometimes you need to use a device called as intra-aortic balloon pump, which is a circulatory assist device, and it has to be used through the femoral route. You can see here that the patient has walked off the table, and after 4 hours, after a complex angioplasty, this lady would go home. Now, the cath labs of tomorrow need to consider interventional radiology, electrophysiology, peripheral interventions, neurovascular interventions, etc. And there has to be a wider application. Now, there is a mobile angiography system. I'm sure you have heard about this, but that is not exactly what the mobile angiography system is supposed to be. There are cath labs in Chakan, there are cath labs in Baramati, there are cath labs in smaller little places. Unfortunately, the mobile angiography system is not small little cath lab. If you want to do an intervention on a patient who is extremely sick, has got 5 pumps going, is ventilated, has got multiple hemodynamic monitors around, you can't shift that patient to the cath lab. So the cath lab has to be moved to intensive care unit where you can do the coronary intervention. That is the actual concept of a mobile angiography system. And such systems are going to be brought into India pretty soon. There is this hybrid cath lab that you can see. At the touch of the button, the entire cath lab can be moved from the table, cath lab table, and moved away, and the cath lab can be changed to an operating room. And that's because we are doing a lot of hybrid procedures. Now, these hybrid procedures are today's current practice, today's need, and therefore such cath labs are being brought in India as well. We have one such lab in Pune. 40 years of angioplasty, and what innovations have we done? There are multiple innovations. For example, the first angioplasty was dating back to 1977 when Andreas Grunzig, unfortunately he died very young in an air crash around Pakistan. We realized that following an angioplasty, the problem was thrombosis. Following an angioplasty, the problem was restenosis, and therefore we invented stents. But the initial stents were bare metal stents, and that was associated with a restenosis rate as high as 40%, which means 4 patients out of 10 who had angioplasty would have restenosis. We had to combat restenosis. I still remember, this is a story of 1996, when from Australia, from my training center, I went to US for a paper presentation. And in Washington, DC, which is the Mecca for interventional cardiologists conference, 4,000 interventional cardiologists had come. Now, of course, after 30 years, this number is growing huge. But during that time, 4,000 interventional cardiologists had gathered in a big hall because the lecture was entitled, "We have won the restenosis." And that talk was about coronary radiation. So after the placement of the stent, if you irradiated the artery, the restenosis rates would decrease because the restenosis is because of proliferation of the intimal cells. Now, unfortunately, radiation did not stand the test of time. It faded away because of multiple problems, because of the logistics of transportation of radioactive material. And then came the era of drug-eluting stents. Drug-eluting stents actually conquered the problem of restenosis to a great extent. But unfortunately, even after that, we realized that the restenosis was still occurring. And then came the era of local gene therapy. Then the restenosis was attributed to an inflammatory process within the artery due to the presence of the polymer in the drug-eluting stent. So the polymers were changed, more biodegradable polymers were used. Then came the era of biovascular scaffolds, which means there were no metallic stents. There were biovascular scaffolds, which means it completely disappeared from the artery after a period of approximately 1 year, and there was no metal left. Now, there are multiple innovations like information technologies and the cardiovascular information systems which have been integrated. This is another example of some of the innovations. This is called as the 3D rotational angiography. You can see that a normal angiography, you will have to inject contrast every time you take a areocranial, areocaudal, eleocranial, eleocaudal views, and you will land up spending a lot of time. You will give a lot of radiation, and you will give a lot of contrast which may be harmful. Now, you saw this. The entire C-arm rotated within 3 seconds from 0 degrees to 180 degrees, thereby getting an angiogram like this that is seen on the, you get a 3-day rotation in one angiographic picture. Then came the era of virtual reality. This virtual reality is currently being practiced in some of the best centers across the world. What does it tell you? It forms a 3D picture of an angiogram like this, and you get that right in front of you. You can wear the VR goggles and navigate the entire vasculature without radiation, without fluoroscopy, without contrast. So it works to the safety of the operators and people within the cath lab. Then there are certain technologies to lower the radiation. I'm not going to go into the details of this. There is also a robo called as Corindus, on which there are joysticks, and with the help of these joysticks, you can actually navigate the catheter and carry out the angioplasty. And the reason is you want to stay away from the radiation. If some of you thought that Dr. Ratnaparki makes a lot of money, but that is a huge price and huge cost that he has to pay. He is exposing himself to radiation. The average lifespan of an interventional cardiologist is supposed to be 7 to 8 years lesser as compared to people who are not exposed to radiation. And this is a scientific data. We are continuously wearing an extremely heavy lead gown. To tell you an example, my height used to be 5'11", आज से 30-35 साल पहले, but now it has reduced by 1 centimeter. That's because there is a vertebral collapse because we keep on wearing these heavy lead gowns. And we do this not once, we do this time and again. I have done close to 17,000 angioplasties so far. You can imagine, to be able to do 17,000 angioplasties, I have done close to 70,000 or probably even more than that angiographies. So this is the price that we pay, and therefore our biggest fear is malignancies, radiation related problems, radiation myelitis, etc., etc. And therefore an attempt by our fraternity is to stay away from the radiation, and therefore these innovations. There are multimodality fusion images. Like for example, here you can see that there is a transesophageal echocardiographic probe which is inserted, and there is a fusion of fluoroscopy. So if you are doing a very complex arrhythmia ablation, and it is very, very difficult to map out based on fluoroscopy alone, you can have a fusion of such images and you can be precise in locating the problem. This is a fusion of X-ray with echocardiogram, which is seen here on your screen. Then CT, coronary angiography. If coupled with a myocardial perfusion imaging, you can be quick in taking a decision that if there is a lesion seen on coronary CT angiography, whether it is an ischemia producing lesion or not. Am I making sense? At any juncture, if you feel that this is not too good, tell me, I can cut it short. But these decisions can be taken immediately and one can go ahead. Otherwise, it takes a couple of days, it takes 3 days to decide whether the angioplasty is mandatory or not. Certain options to deal with calcific lesions. NC balloons, cutting balloons, intravascular lithotripsy. I'm sure you have all heard of lithotripsy. Lithotripsy that you have heard of is used to break the stones in the renal system. What if there is a lot of calcification in the coronary artery? Our biggest enemy in angioplasty is calcification in the coronary arteries. Because you cannot expand the stent, you cannot prepare the bed properly, the stents remain underexpanded, and the underexpanded stents are a perfect recipe for having a restenosis. So you have to deal with the calcium. How do you deal with the calcium? There are many such wonderful approaches now available. The intravascular lithotripsy, which can actually break the calcium within the coronary artery. There is a rotational atherectomy, which drills the coronary. Then there is something called as excimer laser. And I'm very happy to share that I am a national proctor for the rotational atherectomy. Then this is the kind of a calcium that we deal with. The entire coronary artery is full of calcium, and we can deal with calcium because we have such wonderful devices. This is intravascular ultrasound. You can see in the lower frame the coronary artery. You see those tiger skin-like bands, white followed by dark. It is nothing but the stent which is placed inside the coronary artery. You can study the stent so very clearly. And why do you need to study that? Because it has been shown that an angioplasty assisted with intravascular ultrasound or some kind of a coronary imaging gives you a better long-term result. This is another imaging modality called as optical coherence tomography. You can see that there is the top panel. This is a continuous imaging of the coronary artery. It tells you what is the plaque made up of, whether it is made of lipids, fibrosis, calcification, etc., and helps you to take decisions in a much better fashion. This is another intracoronary imaging. This is actual journey through the coronary artery. Can you imagine? You can see the entire stent. You can see the stent struts. You can see the guide wires. You can see the side branches. You can do the optimal side branch dilatations. So this is the benefit of doing the intracoronary imaging. Now, excimer laser. There are certain lesions which are total. There are certain lesions which are non-crossable with a balloon. And if you can't cross the balloon, if you can't dilate the lesion, you can't put a stent. There are certain non-crossable lesions where the excimer laser helps. It actually evaporates the atheroma completely. The atheroma dissolves like salt, just goes away. There are no distal debris. So this is the benefit of excimer laser atherectomy. And this is how it works. The whole atheroma just gets evaporated. It makes a way for the passage of the wire, and once the wire crosses through, you can then take the balloon, do the dilatation. Now, certain innovations in the mitral valve. You have all heard of mitral regurgitation. Now, the mitral regurgitations broadly are of two types. One, where the ventricle dilates because of, say, dilated cardiomyopathy, and the annulus, where the mitral valve is attached, that gets stretched, and that causes the secondary mitral regurgitation. Whereas the primary mitral regurgitation, the prototype is mitral valve prolapse due to myxomatous involvement of the mitral valve. So how do you take care of this in a person who is inoperable or an extremely high risk for surgery? You can do what is called as mitra clip. And how does mitra clip work? Here is a small little animation which shows what is mitral regurg. You can see on the lower side is the ventricle, on the upper side is the atrium. The blue jet is the jet of mitral regurgitation going from left ventricle to left atrium, which is not supposed to be a normal flow. Across the mitral valve, those two leaflets, the black colored, are the leaflets of the mitral valve. And there is this clip which under fluoroscopy, which under transesophageal echocardiography is clipped across the leaflets, converting a single opening into double orifice mitral valve. And in fact, it causes a relative mitral stenosis, but does not matter as long as the gradients are not very high across the mitral valve. This is how the mitral valve can be repaired in patients who are not optimal for surgery. This is the actual live case. This was one of my first training case long back when I went to US to Cedars-Sinai for my first training in mitra clip. This is the transesophageal. Now coming to aortic valve replacement. There has been a lot of debate, and ultimately this particular debate got sorted long back because there is a meta-analysis of a big surgical trial. What is the mortality in case of surgical aortic valve replacement? It is 10% in people who are aged between 60 to 70 years. the mortality can be as high as 20% at the end of 5 years if you had surgery in people who are between 70 to 79, and a prohibitively high mortality in people who are octogenarians, which means if somebody is above the age of 79, the mortality can be 1 person dead every 3 people operated for surgical aortic valve replacement. And therefore, there was a need for a very, very long time. How is this carried out? We'll see that in a second. What is important for you to remember, and whenever you are sending these patients to your specialists, ask a few things. Will TAVR make a difference? Now, is the TAVR being performed for a surgically failed prosthesis? Can TAVR change a scenario in a low-risk individual? Can TAVR be extended to aortic regurgitation patients? Because typically the prototype of the patient is critical aortic stenosis only. But recently we have started doing TAVR even in people who have aortic regurgitations. Now, let's see the video. There is a sheath which is passed into the femoral artery. Unfortunately, we are not doing this through the radial route because the catheter sizes are pretty large. They can be as large as 17, 18 French. But you can see here that a catheter is passed across a very critically stenosed aortic valve, which is hardly opening. A balloon is taken there, balloon is dilated. The passage is made for the valve to go. This balloon is deflated and the balloon is removed. And the same wire which is placed across the aortic valve into the left ventricle is then used to take a balloon expandable valve in place of the native aortic valve, and then it is expanded. And as soon as you can see, it is crimped over a catheter, and that is the technology, that is the research, and that's why these valves are pretty expensive. It is taken to the site of critical narrowed aortic valve, it is deployed, and as soon as the balloon is deflated, the valve remains in place and starts functioning immediately. Now, these are some of the examples of valves. Valves can be self-expanding valve or a balloon expandable valve. And we must take a lot of pride in saying that one of the most widely used balloon expandable valves in the world, besides the first valve, is an Indian valve called My Valve. These are the timelines, how the transcatheter aortic valve implantation progressed. 2002, first man TAVI performed by Professor Cribier, Alain Cribier. 2010, the first cohort in which this particular procedure was tried was a cohort where surgery was absolutely impossible. Because of a variety of reasons, the comorbidities were so high that surgery was just not possible. So they thought, why don't we just implant a valve and see if this man survives good enough? And it actually worked. And since it actually worked, we shifted our patient indication base to people who were high risk but not prohibitively high. In 2014, the balloon self-expandable valves, then in 2016, we became bolder. Well, this technology is working in people who have prohibitively high risk for surgery. It is working in people who have high risk for surgery. Why don't we try this in people who are intermediate risk for surgery? And in them, it worked. And therefore, we became even bolder to extend these indications to people who were low risk for surgery. And surprisingly, it is working even in people who are low risk. But currently, I must tell you that it is not a good idea to consider TAVR in people who are less than 60 years of age, unless the risk for surgery is prohibitively high. Now, another valve, Indian valve. This is my timeline. I am seen with Professor Cribier. And this is Professor Raj Makkar, highest implanter of a balloon expandable valve. These are some of the tower cases. You can see this particular gentleman, when he had tower, he was 84 years old, had a previous coronary artery bypass graft surgery. After 5 years of having had tower, very recently, last month, he passed away because of non-cardiac problems. But for the last 5 years, he was well and walking close to 2.5 to 3 kilometers. So this is how it changes the quality remarkably. This is a gentleman who was on inotropic supports ventilation for a long period of time, for almost 10 to 12 days, because he had a failed bioprosthesis. He was only 70 years old, but it was very difficult to wean him off the inotropes and ventilator. He had tower, and within 24 hours, the ventilator was removed. There was no inotropic support. He started to walk around after 48 hours, and he was home after 72 hours. This is another gentleman, Mr. Khan, I think, who had a tower procedure. And that was because he was morbidly obese, 148 kgs. Surgeons had declined surgery in this gentleman because he had Pickwickian syndrome, far advanced COPD. And after many, many years, he ultimately had a tower and is doing very well after 3.5 to 4 years of tower procedure. Another tower procedure in a gentleman who had renal failure, very critical aortic stenosis. He is doing well, his renal functions have improved. Evolute, now this is a comparison between SAVR and TOWER. You will be surprised to know that TOWER achieved better gradients and TOWER achieved more larger valve areas. Heart failure, systolic heart failure, diastolic heart failure, mitral clip we have discussed, and there are certain assist devices. In case of advanced heart failure, you can use certain assist devices to support the circulatory system. These are of various types. These can be temporary, these can be long-term. Impella is kind of temporary, you can say. It can be used for a few days. Intra-aortic balloon pump can be used for a few days. Tandem heart can be used for a few days. But I have got 6 patients who have been on LVAD. LVAD is left ventricular assist device, and the longest duration that I have had my patient on LVAD is 5.5 years. It's a small little pump which the person has to carry. It can be charged. He has to maintain a specific INR to maintain the anticoagulation level, and the person can be absolutely active. I've got a patient whose ejection fraction is less than 15%, but walks 5 to 8 kilometers every day because of such assist devices. Unfortunately, they are pretty expensive, but please remember to offer these therapies to your patients. Diastolic heart failure, where the left ventricular compliance is a problem. I'm sure you have heard of this. LV ejection fraction is normal, but patient still becomes breathless. Patient has to wake up in the middle of the night extremely breathless, gasping for breath. What is the problem here? The problem is probably an uncontrolled blood pressure leading to a diastolic heart failure. There are certain devices called as partitioning devices or the parachute devices, which can be put into the ventricle through the catheter and help to relax the ventricle, help to dilate the ventricle during diastole. I won't go into the details of Impella, but this is how it works. It is introduced through the femoral artery. It crosses the aortic valve, and you can see that this particular pigtail catheter that you see here has got an inlet area from where it sucks the blood and is thrown into the aorta, thereby giving a lot of rest to the failing heart. These are the LVADs. They are as small as these and can be carried around your waist, like we used to carry pagers once upon a time. Innovations in pacemaker. I'm sure you have had patients of pacemaker who have a big pacemaker in this left or right subclavicular area, but there are multiple problems associated with these. The first pacemaker used to weigh 28 pounds. So it was not implantable. The person had to carry that in a bag and it kept on generating the pulse. In fact, even before that, there was a pacemaker where the person had to drive the handle himself as a dynamo, as a generator to kind of give the impulse to the heart. Over a period of time, the pacemakers became smaller and smaller in size. But unfortunately, even today, they have to be implanted in the subclavicular area from where an electrode will go into the heart. Now, these are the drawbacks of conventional pacemakers. Scarring can be there. There are erosions. You have seen pacemakers coming out, the pocket getting ruptured, pocket getting eroded. There are formations of the hematomas, etc., etc. Now, the time has come where we are implanting a leadless pacemaker. Let us see how this is implanted. Through the inferior vena cava, a catheter is passed, and this is a deflectable catheter. So you can change the direction of the catheter from outside by manipulation. This is made to go across the tricuspid valve into the right ventricular apex, and there are certain anchoring mechanisms whereby this particular small little capsule-like, it is actually capsule-sized. It's a very small pacemaker. It sits into the ventricle, and the entire assembly can be taken out. There are no leads, there are no pockets, there is no infection, and there are no problems associated with leaded pacemakers. I got this certification completed for my training. Innovations in the treatment of hypertension. I'm not going to go into the details of these because Gaju has discussed that, sorry, Dr. Ratnaparki has discussed that in detail. My apologies to you. Gaju is okay. Okay, every little blood pressure reduction matters, as he has rightly said. Here is a graph which shows that the relative risk reduction, even if you reduced the blood pressure by 5 millimeters extra, the relative risk reduction in all these, whether it was cardiovascular death or stroke or heart failure or ischemic heart disease or cardiovascular death of any kind, reduced so much by just additional 5 millimeters of mercury reduction in the blood pressure. Renal denervation, he has dealt with in detail. And I am a certified proctor for renal denervation, which will be commercially launched in this month at some point in time, and we have lined up many patients for this. Once again, this is not the first line therapy. Please remember that the therapy of hypertension is always number one, lifestyle modification, dietetic changes, reduction of weight, avoidance of alcohol, pharmacotherapy, 1 drug, 2 drug, 3 drug, 4 drug, and then if you have not reached the target, and the targets are ideal 120/80, if not ideal at least 130/80, not achievable, blood pressure constantly remaining above 140 even with all these things that you have implemented, then send the patient for renal denervation because it additionally will probably make a difference. And this is how it works. You must remember that why renal denervation? Because kidney is the seat of all the problems related to the hypertension. So initiation of hypertension and persistence of hypertension, the mechanisms are renal in 85% of individuals. Of course, there are multiple other mechanisms responsible for persistence of hypertension as well. But these are neurohumoral. And how? These nerves pass into the renal parenchyma through the renal artery that you see here. And all that you do is ablate all these renal nerves, which are taking the signals for the activation of the renin-angiotensin system, aldosterone-related mechanisms, sympathetic mechanisms, whatever may be responsible. But you completely denervate the renal artery. Barostim, I'm not going to go into the details of this, but by doing this, you are actually fooling the brain. How do you fool the brain? By carrying out the stimulation of the carotid baroreceptors. Why are they called baroreceptors? Because they are sensitive to pressure. And if you fool these baroreceptors by mechanical stimulation, it perceives as an increase in blood pressure, and therefore these baroreceptors send signals to the center, to the brain, and then brain thereby has its own mechanisms to reduce the heart rate, to reduce the peripheral resistance, and to reduce the blood pressure. This is how it works. There is a small little pacemaker which is there, and it is stimulating the carotid bulb externally. Shunt closures, won't go into the details of these. Gene therapy, local gene therapy, you modify the local genes, but unfortunately hasn't worked extremely well in cardiovascular therapeutics. What is the future of interventional cardiology? I think the future of interventional cardiology is actually prevention. Now, we know that the preventions can be secondary prevention, which means you have had an event, you have had a heart attack, you have had an unstable angina, you have had a pacemaker, you have had a stent already, and after that, whatever you do to prevent recurrence is called as the secondary prevention. But the primary prevention is something, let's say there is a diabetic, and the diabetic is taking statins and antiplatelets to prevent cardiovascular problems. That is called as the primary prevention. But even before that, if you do prevention, it is called as the primordial prevention, which means you modify the individual's milieu. For example, there are gentlemen sitting here who will father babies, but if you modify your genes today, how can you do that? You have your lifestyle which is pristine. You avoid smoke, you avoid alcohol, you have a great diet, you exercise regularly. Exercises in various forms. Sustenance, stamina, warm-up, cool down, stretching, all these, if you do on a very regular basis, these will modify your genes which are coming. And this is called as the primordial prevention. Now, there will be precision medicine in which there will be genomic integration. Whenever you write a prescription, you know that every prescription is not going to work the same in every individual. There are certain individuals who respond by way of hypertension for a small little antihypertensive pills. In others, the same drug may not work, and that is driven by your genetics. And therefore, there will be mapping of genes before you start giving prescriptions, and these, along with environmental factors, digital phenotyping, etc., integrated into one will give you an advantage to carry out what is called as the precision medicine. Now, what is important to remember? It is not just these therapies. It is not just these devices. It is not what is available because researchers have found out. It is important that people working behind all these gadgets and devices are equally trained, are equally knowledgeable, and are consciously taking the decision of using these devices. And therefore, the bulk production of doctors which is happening now should be avoided, and we have to hand curate the cardiologists like Dr. Ratnaparki, so you will have a much better future. Thank you very much.
Hello. Thank you, sir. Very informative. And sir, what is the treatment of HLHS, WPW, LGL, and Bargoda syndrome? HLHS.
You seem to be extremely motivated, which is a good thing. I'm going to ask rest of the people if they know about Brugada syndrome. Does everybody know what is Brugada syndrome? All right. Does everyone know what is WPW syndrome? Yes. I think many people have heard about WPW syndrome. First,
HLHS.
It is going to complicate everybody.
No. Hypoplastic left heart syndrome.
Correct. Basically, it goes into a different domain where you have hypoplastic left heart syndrome. In this particular condition, the child is born with hypoplasticity of everything on the left side. So there can be coarctation, there can be interruption of the aorta, there can be mitral valve problems, there can be severe aortic stenosis, etc. So surgery is an option in patients with hypoplastic left heart syndrome, but it depends upon what kind of a hypoplastic left heart syndrome you have. In somebody who has WPW syndrome and is manifesting very frequently with arrhythmias, electrophysiological mapping and finding out the pre-excitation and ablating that is the cure. And your last question, Brugada syndrome. Brugada syndrome is a condition in which it is familial. It tends to run in families. There are various types of inheritances described in this particular syndrome. But there's a very typical ECG abnormality. It's an incomplete right bundle branch type of a pattern with sudden deaths described in the family. So there are certain drugs which work in that, and there's a pacemaker implantation. Typically that pacemaker is called as ICD, implantable cardioverter defibrillator for such individuals. But that was a very brilliant question. Thank you.
And what types of the HOCM is there, and what is the treatment of HOCM, respiratory cardiomyopathy, dilative?
HOCM once again is a hypertrophic cardiomyopathy. There are multiple treatments. If there is a outflow obstruction, you can carry out alcohol septal ablation, which probably in Maharashtra I have done the highest number so far. So you relieve the obstruction. ICD implantation and probably surgical myomectomy. These are some of the therapies for HOCM. Very good. Rheumatic valvular heart disease once again depends on what kind of a valvular heart disease you have. But in advanced cases, valve replacements, in pure mitral stenosis, we do the balloon mitral valvuloplasty, which Dr. Ratnaparki is very good at. So there are these options. Yeah.
We were together in JJ, and every day we used to do at least 4 to 5 BMVs. And there was competition. तो कितने में करता 20 मिनट में करता मैं 19 मिनट में करता like that. I remember Anil Kumar was doing 22 minutes.
Absolutely.
Sir, what is the measurement of aortic wall and gradient of the aortic wall where you can go for the TAVI?
सर मैं उनको लेक्चर के बाद आपके बाजू में बैठाता हूँ. आप आधा घंटा उसको छोड़ने का नहीं. Okay?
You realize how he bonds people and how he is a savior for me. Thank you very much.
Sir, it was a very lucid lecture. Suhas.
Thank you, sir, for that close insight and information on tower. I would like to request AMA Treasurer Seema Tiwari, MCVP Treasurer Dr. Sarad Dadi, sir, Convener Dr. Ram Chavan, Dr. Smriti Ratnaparki, Madam, and Dr. GPR, sir, to give our speaker a token of appreciation and felicitate him. A huge round of applause, please. गणपति बाप्पा. Done? Now I would like to hand over the mic to Dr. Smita Patil.
नमस्कार. आज आपल्याबरोबर आपल्यामध्ये शालेय शिक्षण मंत्री दीपक वसंत केसरकर उपस्थित आहेत. त्यांचे जोरदार टाळ्यांनी स्वागत करूया. सर दिल्लीहून औरंगाबाद, तिकडून डायरेक्ट शिर्डी आणि तिथून डायरेक्ट आपल्या कॉन्फरन्सला आलेले आहेत. आणि त्यांनी सिद्ध केलं की या शालेय शिक्षण मंत्री या पदासाठी त्यांच्या एवढा योग्य व्यक्ती नाही. आणि अकॅडमिक फीससाठी एवढी दगदग करून येणारा हा माणूस. सावंतवाडीचे नगराध्यक्ष ते महाराष्ट्राचे कॅबिनेट मंत्री असा शून्यातून विश्वनिर्मिती करत त्यांचा प्रवास झालेला आहे. आपल्या केसरकर साहेबांचे बालपण, शिक्षण, राजकारणाची सुरुवात सर्व काही सिंधुदुर्गातील सावंतवाडीतून झाली. 18 ऑगस्ट 1955 हा त्यांचा जन्मदिवस. त्यांनी BCom पर्यंतचे शिक्षण तिकडेच पूर्ण केले. एक्सपोर्ट मॅनेजमेंटमध्ये डिप्लोमा देखील केला. बऱ्याच प्रतिष्ठित संस्थांशी त्यांचा संबंध आहे. शालेय अभ्यासक्रम, शिक्षण व शिक्षणेतर कर्मचाऱ्यांचे प्रश्न, शिक्षक भरती, विशेषतः ग्रामीण भागातील मुलांची शिक्षक भरती, मुख्याध्यापक नियुक्ती, एक राज्य एक गणवेश असे अनेक प्रश्न मार्गी लावण्यावर त्यांचा भर आहे. आणि त्यांचे मार्गदर्शन नक्कीच आपल्या राज्याच्या शैक्षणिकदृष्ट्या फायद्याचे ठरेल. जोरदार टाळ्या. शालेय शिक्षण मंत्री दीपक वसंत केसरकर. मी आपले GPR सर, स्मृती मॅडम यांना रिक्वेस्ट करते की त्यांनी आपल्या सर्व मंत्र्यांचे फेलिसिटेशन करावे. गणपती बाप्पा, मंगल मूर्ती, उंदीर मामा की. I request Dr. GPR sir and Ram Chavan to felicitate Dr. Amit Kesarkar, the good friend of Ram आणि मंत्री महोदय साहेबांचे ते पुतणे आहेत. AMAचा मेंबर आहे. Now I request Deepak Kesarkar Sahib to felicitate our team CardioCon. It starts with Dr. Meghna Bhate, Dr. Mamtora, please be ready. डॉक्टर प्रबोध मामतोरा, डॉक्टर संजनवाला, डॉक्टर मनोज पटेल, डॉक्टर अशोक सिंह, डॉक्टर सुहास वोरा, डॉक्टर ललित चोरडिया, डॉक्टर गजानन काटे, डॉक्टर राजेश तिवारी, डॉक्टर समीर पाटिल, डॉक्टर संजीव पाटिल, डॉक्टर भावना पटेल, फॉर डॉक्टर मनोज पटेल, डॉक्टर समीर पाटिल, डॉक्टर संजीव पाटिल, डॉक्टर ललित चोरडिया, डॉक्टर सुहास वोरा, डॉक्टर प्राची वोरा, सगळे झोपले का जेवून? टाळ्या वाजवा. कुठलं काय डॉक्टर प्रबोध मामतोरा, हाँ ऐसे करना चाहिए खुद. डॉक्टर शिल्पा बंसल, डॉक्टर शैलेंद्र सिंह, डॉक्टर मनोज ध्रुव, Dr. Manoj Dhruv, Mr. Sagar Pandare, Dr. Dinesh Singh, Dinesh Singh. Dr. Dheeraj Jumbar, नहीं है. Dr. Mukesh Biani, Dr. Vrunda Patil, Dr. Vrunda Patil, Dr. Deepak Desai, Dr. Sanjay Gupta, Dr. Pooja Joshi, Dr. Vaibhav Ubare, Dr. Vaibhav Ubare, and now last but not the least, whole Guru Krupa Diagnostic and Guru Krupa Heart Center staff. Please come on stage and big round of applause for these guys, please. Supportive staff for CardioCon. चला मुलींनो लवकर. मुलं पण आहेत का वर? Big round of applause for these hard-working people, please. Thank you so much, sir. Now I request our Mantri Mahoday Sahib to say a few words.
Honorable Dr. GP Ratnaparaki, Dr. Smruti, Dr. Ram Chauhan, Dr. Anil Kumar, Dr. Shankar Shaha, Dr. Tejaswini Pandre, Dr. Anurag Bhate, Ashish Deshmukh, Dr. Smruti Ratnaparaki, all other respectable doctors and dignitaries of the dais and friends. Good evening. First of all, let me offer my apologies for not being present for tomorrow morning's function. I had been to Delhi to attend a very important GST meeting, which is chaired by Finance Minister of India, and all finance ministers of states are present for every GST meeting. You are well aware because now your profession as well is covered under GST. And it is a symbol of unity of India, because every decision that is to be taken in GST meeting is to be unanimously taken. So a lot of deliberations always takes place. But you'll be surprised why I was there, because I was MOS Finance for the last 5 years. And today there is no MOS of Finance for Maharashtra state. So whether it comes to presenting of budget or when the finance minister is not able to go to GST council, I'm always given that responsibility. You will be surprised why I'm here, because I'm either related to the admissions of your grandparents or your grandchildren or children when it comes to admission. And not that way I'm not connected with medical at all, except that 4 of my family members are doctors. So I have highest respect for this profession. And I'll have to tell you one thing. When I became the Guardian Minister of Mumbai City, first thing I did was to visit all government and municipal corporation hospitals. And you are well aware that JJ was the first one to introduce angioplasty in government hospital in the whole of India. And both the machines of angioplasty, one was partially working and one was not working at all. So I was the first guardian to minister to sanction them angioplasty machine. And unfortunately that process is on. But I always feel that government hospital should give the same care and same quality of treatment, because we have the best of doctors in government hospitals as well. So next thing I did was to convert JJ's ward like a private hospital. You must, all of you should go, because it's a cardiac ward. And now work of new cardiac operation theaters is in progress in JJ. Similarly, we started IVF center, the first IVF center in government sector, because poor people, they don't have this access. And that's why first IVF center have come up at Kama Hospital. We have to do so many things for Mumbai, because Mumbai is the best city, the best corporation, not only in India, it is the richest corporation of Asia. And that's why new medical facilities are coming up. Now I have instructed to have dialysis center in each government hospitals, because you are aware that many of the patients who require dialysis could not do so because they cannot afford it. Paying 1,500 rupees every day is not possible for them. That's why we will be giving free dialysis center, free dialysis to all the needy people in government medical colleges and municipal medical colleges. We have to do many improvements, but there are certain problems about Mumbai. KEM is a heritage structure. You cannot modify the structure. So many problems are there. But I'll have to congratulate all of you because you do a divine work of giving life to the patients. I know that critical care is a very important sector where a patient comes with only 10% chances of survival. Still, the relatives feel that they should be cured, which is a very, very difficult job. And when you cannot do it, many a times they get angry. A lot of news, they come in the newspaper. And for this, it is really necessary that all the sectors of the society should know about the medical profession. मी थोडं तुमच्यावर मराठीमध्ये बोललंच पाहिजे कारण मी मराठी भाषेचा सुद्धा मंत्री आहे आणि त्याच्यामुळे मराठी भाषेचा स्वाभिमान, छत्रपती शिवाजी महाराजांचा स्वाभिमान हा प्रत्येक मराठी माणसाच्या हृदयामध्ये असतो. आपण लोकांना जीवदान देता आणि त्याच्यामध्ये सर्वात हायेस्ट रिस्पेक्ट जर कुठल्या कम्युनिटीला असला तर तो मेडिकल कम्युनिटीला आहे. आणि म्हणून आपण जे काम करता, दिवसरात्र काम करता, आमच्यासारखी लोक ज्यांना ह्याच्यातलं ABC सुद्धा कळत नाही. खरं तर आमची बिझनेस फॅमिली आहे, 4th जनरेशनचा बिझनेस आहे. मी सुद्धा सायन्सला ॲडमिशन घेतली होती, मला जबरदस्तीने काढलं आणि कॉमर्समध्ये, नाही तर हा सुद्धा त्याच बाजूने जाईल. तर मेडिकलच्याबद्दल एक अट्रॅक्शन असतं कारण मेडिकलने तुम्ही सेवा करू शकता. डॉक्टर रत्न पारेख यांचा मला अशासाठी अभिमान आहे की ही सेवा करत असताना आणि लोकांना जीवदान देत असताना त्यांनी आपलं फाउंडेशन स्थापन केलं. या फाउंडेशनच्या माध्यमातून अनेक लोकोपयोगी कामं करत असताना ज्याची सर्वात जास्त गरज ही मेडिकल प्रोफेशनला असते आणि जी सातत्याने अपग्रेडेशन ऑफ नॉलेज असतं. कारण सातत्याने टेक्नॉलॉजी बदलत जाते, स्किल्स बदलत जातात आणि त्याच्यासाठी हे अपग्रेडेशन सातत्याने चालू असतं आणि त्याच्यासाठी त्यांनी ही CardioCon परिषद घेतली. त्याच्याबद्दल मी त्यांच्या फाउंडेशनचं मनापासून कौतुक करतो. मी अंधेरी आणि विलेपार्ले मेडिकल असोसिएशनचं सुद्धा मनापासून कौतुक करतो की अनेक कार्यक्रम, माझा पुतण्यासुद्धा आपला मेंबर आहे आणि त्याच्यामुळे कार्डिओलॉजी हा असा एक सेक्टर आहे की जिथं दोन गोष्टी असतात की एकतर मनुष्याचा जीव जाऊ शकतो आणि तो वेळेवर पोचला तर त्याचा जीवसुद्धा वाचू शकतो. आणि त्याच्यामध्ये जे गोल्डन मिनिट्स असतात त्या मिनिट्समध्ये त्यांना ती मदत पोचायला लागते. आणि त्याच्यामुळे आता अनेक जे आपण चर्चा करतात त्याच्यामध्ये एकतर आपली जीवनशैली कशी बदलायची, कारण जीवनशैली आणि हार्ट डिसीज याचा खूप मोठा संबंध आहे. आणि त्याच्यामुळे जी जीवनशैली आपल्याला भारतीय विचारसरणीने शिकवली, ज्याच्यामध्ये आज जगभरामध्ये योगाबद्दल बोललं जातं, जगभराबद्दल आपल्या आहार पद्धतीबद्दल बोललं जातं, जंक फूड खाणं किती हार्मफुल आहे याच्याबद्दल जगाला आज कळलं. परंतु ही भारतीय संस्कृतीमध्ये ते चालत आलं आणि म्हणून त्या भारतीय संस्कृतीचे पाईक म्हणून आपण संपूर्ण विश्वाला सेवा देत असतात. बेस्ट ऑफ द डॉक्टर्स केवळ इंडियामध्ये नाही आहेत, तर इंडियन डॉक्टर्स जगातले सर्वोत्कृष्ट डॉक्टर्स म्हणून ओळखले जातात आणि जगभर जाऊन ते त्यांची सेवा करतात. आणि त्याच्यामुळे आमच्या डॉक्टर्सचा आम्हाला अभिमान आहे. आपल्याला मनापासून वंदन करण्यासाठी मी इथं आलो. आपल्याला भाषण देण्याची माझी खरं तर लायकी नाही. आपल्याला एकच गोष्ट सांगतो की आम्ही ज्याला मंत्री म्हणून काम करतो त्याला ॲडमिनिस्ट्रेटिव्ह बाबी ह्या आम्ही तुमच्यासाठी काय करू शकतो ह्याला फार महत्त्व असतं आणि म्हणून ते आम्ही करत होतो. मी 4 वर्ष महाराष्ट्राचा गृहराज्यमंत्रीसुद्धा होतो. अनेक वेळेला ज्यावेळेला आपल्याला इम्प्लिमेंटेशन करत असतं, एखाद्या ॲक्टचं इम्प्लिमेंटेशन करायचं असतं, जसं आपल्याला माहिती आहे की मध्यंतरीच्या काळामध्ये ज्याच्यामध्ये गायनाकॉलॉजिकल सर्व्हिसेस दिल्या जातात त्यांच्या संदर्भात काही प्रश्न टेस्टच्या संदर्भात निर्माण झालेले होते की टेस्ट करायची तुम्ही इक्विपमेंट बसवली की मग अनेक ऑथॉरिटीज त्रास द्यायच्या. मी त्यावेळेलासुद्धा हे स्ट्रीमलाईन करायचा प्रयत्न केलेला होता की प्रत्येकजण काय सेक्स आयडेंटिफिकेशनसाठी इन्स्ट्रुमेंट्सचा वापर करत नाही, त्यांना पेशंटच्या चांगलं करण्यासाठी त्याचा वापर करायचा असतो. परंतु एक मनुष्य जरी चुकीचा असला तरी संपूर्ण कम्युनिटीला त्याच्यापासून बदनाम केलं जातं. आणि म्हणून हा सुद्धा मोठा विचार हा करायला लागतो. आणि ज्या ऑथॉरिटीज याच्यावर काम करत असतात त्यांनीसुद्धा आपल्याला वेगळी ट्रीटमेंट दिली गेली पाहिजे. मग ते मेडिकल वेस्ट डिस्पोजल असेल, अनेक असतं. आपल्याकडे नर्सिंगच्या लायसन्सेस द्यायला लागतात. मी निश्चितपणे आपल्या ज्या असोसिएशन्स आहेत, खरं तर माझ्याकडे मुंबई सिटी आहे, मुंबई सबर्ब माझ्याकडे नाही आहे, परंतु याच्या संदर्भातल्या ज्या ऑथॉरिटीज असेल, रत्नपारखी साहेब आपण एकदा पुढाकार घ्या आणि त्यांच्याशी तुमचं कसं कोऑर्डिनेशन करून द्यायचं त्याचंसुद्धा गार्डियन मिनिस्टर म्हणून मी निश्चित प्रयत्न करेन, एवढं आपल्याला सांगतो. आपल्या ज्या काय सजेशन्स असतील की मेडिकल सर्व्हिसेस कशा रीतीने इम्प्रूव्ह करता येतील आपण निश्चितपणे त्या करू. आणि आता मेडिकल टुरिझम नावाचं एक नवीन सेक्टर येतं ज्याच्यामध्ये हेल्थ टुरिझम आहे, ज्याच्यामध्ये बेस्ट ऑफ द सर्व्हिसेस, मेडिकल सर्व्हिसेस कुठे मिळतात त्या ठिकाणी जायचं, कारण पेशंट रिकवरसुद्धा व्हायला लागतो आणि रिकवर होत असताना त्याला चांगलं वातावरणसुद्धा लागतं. आणि म्हणून 2-3 गोष्टी मला एवढ्याच सांगायच्या आहे की मेडिकल सेक्टरमध्ये जी प्रगती चालू आहे, भारताने जी 70 वर्षामध्ये प्रगती 60 वर्षामध्ये झालेली नव्हती, ती गेल्या 9 वर्षामध्ये होते. प्रत्येक डिस्ट्रिक्टमध्ये मेडिकल कॉलेजेस, कारण डॉक्टरचं शॉर्टेज ही भारतातली फार मोठी समस्या आहे. पण आपलं मेडिकल असोसिएशन ऑफ इंडिया एवढं त्याच्याबद्दल स्ट्रिक्ट होतं की नवीन मेडिकल कॉलेजेस होऊ शकत नव्हती. पंतप्रधान महोदयांनी निर्णय घेतला आणि आता प्रत्येक डिस्ट्रिक्टमध्ये मेडिकल कॉलेजेस सुरू झालेले आहेत आणि त्याच्यामुळे खूप बेनिफिट हा भारतामधल्या पेशंटना होणार आहे. एम्सपुरतं बोलायचं झालं तर फक्त एक एम्स भारतामध्ये होतं. आता जवळजवळ 4 एम्सची कामं पुरे झाली, ते कार्यरतसुद्धा आहेत. आणि एम्स होत आहेत की पंतप्रधान महोदयांचं असं स्वप्न आहे की प्रत्येक स्टेटमध्ये एक एम्स असलं पाहिजे, कारण एक्सलन्स इन मेडिकल हे मिळालंच पाहिजे. आणि म्हणून हे सर्व करत असताना ज्या ज्या नवीन इनिशिएटिव्स घेतल्या जात आहेत त्याच्यामुळे भारत बदलतो आहे, ही वस्तुस्थिती आहे. आणि हे बदलत्या भारताला तुमच्यासारख्या ज्येष्ठ डॉक्टर्सच्या मार्गदर्शनाची गरज आहे. आणि म्हणून आपण खूप सदृढ असा भारत निर्माण करत असताना काही टेक्निकल प्रॉब्लेमसुद्धा असतात, ज्याच्यावरसुद्धा डॉक्टरसाहेब आपण एखादा वर्कशॉप घेतलं आणि कशा रीतीने, कारण अनेक कोर्टाचे निर्णय असतात ज्याच्यामुळे प्रॉक्युरमेंट ऑफ मेडिसिन्स अँड इक्विपमेंट्स हा सुद्धा एक चॅलेंज आहे गव्हर्नमेंटसमोर. की गव्हर्नमेंट आता असा विचार करतो आहे की आम्ही कॅबिनेटमध्ये सुद्धा त्याच्यावर चर्चा केली की आपण आता रेट कॉन्ट्रॅक्ट्स द्यायची, 2-2 वर्षाची रेट कॉन्ट्रॅक्ट्स द्यायची. कारण एखादं प्रॉक्युरमेंट करायचं असेल, म्हणजे जसं मी तुम्हाला सांगितलं की जेला मी मशीन दिलं, परंतु त्या प्रॉक्युरमेंटमध्येच 6-6 महिने 8-8 महिने निघून जातात. 1 वर्षामध्ये ते मशीन आलं असतं तर अधिक त्याच्यापासून सर्व्हिसेस करता आल्या असत्या. परंतु मला खरोखर आपलं आभार मानायचे आहेत. मग ते गव्हर्नमेंट सेक्टर असून दे, प्रायव्हेट सेक्टर असून दे, मुंबईचं नाव हे आपण जगभरामध्ये केलेलं आहे आणि अनेक देशातली लोकं ही मुंबईला ट्रीटमेंटसाठी येतात. मी मनापासून डॉक्टर रत्नपारखी, त्यांचे सर्व सहकारी, त्यांच्या फाउंडेशनचं, अंधेरी मेडिकल असोसिएशन, विलेपार्ले मेडिकल असोसिएशनचं सर्वांना मनापासून सर्वांचं कौतुक करतो. मनापासून आपल्याला शुभेच्छा देतो. आणि आपलं कुठलंही छोटं मोठं काम असेल तर तुमचा एक भाऊ हा मंत्रालयामध्ये बसलेला आहे, एवढं निश्चितपणे लक्षात ठेवा. आपल्या सगळ्यांचं मनापासून आभार मानतो. मला एका दुसऱ्या महत्त्वाच्या मीटिंगसाठी आता ठाण्याला जायचं आहे आणि कदाचित रात्रीच्या फ्लाईटने गोव्याला जाऊन तिथून माझ्या मतदारसंघाचं जायचं आहे. आमचं जीवन हे असंच पळता पळता होत असतं, परंतु त्याच्यामध्ये रिलॅक्सेशनचे क्षण हे आपल्यासारख्या मान्यवरांच्या भेटीने येत असतात. तर हा क्षण आणून दिल्याबद्दल मी डॉक्टर रत्नपारखींचं मनापासून आभार मानतो आणि माझे 2 शब्द संपवतो. जय हिंद, जय महाराष्ट्र.
Thank you, Kesarkar sir, for your kind words. Sir, चालेल खाली. नाही, संजय सरांचं सर करणार आहेत बोललेत सर. आता काय क्विज घ्यायचं सर? Now I would like to request Dr. Sanjay Ratnaparki sir to please come on the dais. Sir requires no introduction. He is elder brother of our beloved Dr. G.P. Ratnaparki sir and has always been a driving force for him. I would like to call Dr. GPR sir to introduce Dr. Sanjay Ratnaparki sir.
Hello.
पाहिजे नाही पाकिट आहे
भाई ओ भाई किधर है विजय दिनानाथ
आवाज पहा ना चेक झाला इथे मला काही काम नाही पडलं पाहिजे फक्त आणि मी जेव्हा म्युझिक म्हटलं मला हॅलो
भाई इधर आओ
हाय
हाय It's my pleasure and honor to introduce my own real elder brother. Me specifically, Deepalila म्हटलं I would like to introduce my brother. त्याच्या मागे कारण आहे ती माझं खूप कौतुक केलं सकाळपासून काफी अच्छा एटलीस्ट मुंह पे तो बोला मेरे के काफ़ी अच्छा बोला सवेरे से मेरे बारे में मुंह पे ना खाते वक्त क्या क्या मालूम नहीं तो मैं आज जो भी खुश हूँ वॉट एवर आई एम टुडे इज बिकॉज ऑफ दिस जेंटलमैन दिस इज नॉट बिकॉज ही टॉट मी लॉट्स ऑफ थिंग दिस इज ऑल बिकॉज आई वॉज जेलस ऑफ हिम मैं सच बोल रहा हूँ ही ऑल्सो नोज दिस है ना मेरा और उसमें 4 साल का अंतर है तो बचपन में तो मैं मेरा बिल्ड तो दिखाऊंगा बॉडी बिल्ड ठीक है ना तो बचपन में आज टू डू कुश्ती एक्सरसाइज वगैरह वगैरह आई वांटेड टू बिकम इंस्पेक्टर क्योंकि बचपन में कैसे इंस्पेक्टर वो खादी वर्दी मस्त लगता है ना मेरे को इंस्पेक्टर बनना था या मिलिट्री में तो मिलिट्री जाता है इंस्पेक्टर वो बुलेट पे दूर 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 जाता है ना मजा आता था तो मुझे इंस्पेक्टर बनना था जब तक मैं 8वीं में था 9वीं में था तब तक मैं इंस्पेक्टर बनना चाहता था जिस दिन डॉक्टर संजय रत्नपारकी को एमबीबीएस एडमिशन मिल गई पूरी दुनिया ने उसका कौतुक करना चालू कर दिया बोला साला इसका क्यों तक कौतुक कर रहे लोग मुझे इसका मतलब है अगर एमबीबीएस में एडमिशन मिलता है तो बहुत कौतुक होता है कैंसल पुलिस बनना कैंसल अभी आपको इसको दिखाना है कि मैं भी डॉक्टर बन के रखूँगा क्योंकि मेरी छोटी छोटी कंप्लेंट छोटी छोटी बातों कंप्लेंट ये बहुत करता था एंड ही वॉज वेरी स्टूडियस और मैं बहुत मस्ती करता था फ्रैंकली स्पीकिंग ओके दिन भर खेलता था कंचे क्या ये क्या वो क्या बड़े किताबें याद है अब आप काफ़ी मेरे एज के हो भूगोल का पुस्तक है ना जियोग्राफी का बड़ा किताब रहता था उसके अंदर छोटा स्टोरी का बुक डाल के पढ़ते थे और ये बोलता था पापा इधर आओ ऐसे कहता देखो क्या कर रहा है दे दनादन ऐसे इतने किस्से इसने मेरे साथ किए तो मुझे अभी इसको तो मार भी तो नहीं सकता था ना कुछ बड़ा है कुछ कुश्ती बिस्ती नहीं कर सकता तो क्या करूँ तो इसको अपने को ये डॉक्टर बना तो मैं भी दिखा तो इसको डॉक्टर बना तो इंस्पेक्टर बनना कैंसल एमबीबीएस डॉक्टर साहब हो गए बोला चलो और भला ही मैं दिन भर खेलता था आई एम ए नॉक्चुरल मैन आज भी मैं 3 बजे तक जागा रहता हूँ प्रैक्टिस करता हूँ मेरे ओपीडी क्लोजेस एट 11:30 3 बजे 2-3 बजे तो मैं टाइम पास करता हूँ फिर सोता हूँ आराम से 8 बजे उठता हूँ तब भी मैं 10 बजे ये सब लोग सोते थे सिंसियर लोग मैं 10 से रात को 2 बजे तक पढ़ता था आई वॉज ऑलवेज टॉपर ऑफ माई ओके तो ये भी बन गया तो मैं भी एमबीबीएस को पढ़ाई करके गया चलो अभी अच्छा लगा तू एमबीबीएस मैं भी एमबीबीएस फिर इसने और एक डिग्री ली डीसीएच लिया और फिर से बड़ा हो गया मेरे एक डिग्री इसकी 2 डिग्री अरे अच्छा नहीं चलो अपन में एमडी मेडिसिन करते हैं तो मैंने एमडी मेडिसिन किया सी हाउ द पर्सन ही वाज ऐसा नहीं कि उसने मेरे को बहुत सिखाया वगैरह बट हाउ द जेलसी रादर नाउ आई कम टू नो दैट वाज माय इंस्पिरेशन जो बचपन में मैं जेलसी समझता था दैट वाज माय इंस्पिरेशन ये सच्चा ये हृदय की भावना है तो फिर इसमें मैंने एमडी किया रिसर्च किया लेवल में आ गए 2 डिग्री वाले ओके तो मैं तो खुन्नस था ना इसके बचपन में बहुत तकलीफ दिया तो बोले इससे एक ज़्यादा डिग्री लेना है, तो मैंने डीएम कर लिया। तो वो भी रुका नहीं, उसने पीजीडी जीएम कर दिया, पोस्ट ग्रेजुएट डिप्लोमा इन जेनेटिक मेडिसिन कर लिया। तो फिर से लेवल 3 डिग्री। अरे मतलब बराबर नहीं, तो मैंने एफसीएसआई कर लिया है यूरोप में जाके। तो उसने भी एक डिप्लोमा कर लिया, पीजी डीएपी, दैट इज पोस्ट ग्रेजुएट डिप्लोमा इन एडवांस पेडियाट्रिक्स। ओके, मतलब ये बराबर नहीं, चार इक्वल कैसे, इसके तो आगे जाना अपनी जिंदगी में। तो मैंने 5वीं डिग्री ले लिया, एफसीएसआई कर लिया, FESC, बाद में FCSI कर लिया। इसने भी MD इन मेडिसिन कर लिया। अरे यार लफड़ा चल रहा है, 5वीं ये भी ले रहा, 5वीं में ले, मैं क्या करूँ? तो मैंने 6वीं डिग्री ले लिया, FSCAI, F स्काई बोलते हैं, वो ले लिया। अभी इसके बाद कोई डिग्री नहीं है। अभी 5 पे रुक गया है, मैं 6वीं डिग्री लेके एक स्टेप आगे गया, इसलिए कि इसके स्टेप पे झुकने के लिए। ओके, यही इसका इंट्रोडक्शन है। आपने तारीफ बहुत किया, मैं हवा में गया, बट ये आदमी एक्चुअली हवा में रहता है। उसको डॉक्टर तो है, ही इज अ ऑफिशियल ट्रेनी ऑफ पैराग्लाइडिंग ऑल्सो। इसको प्रैक्टिस तो करता है, लेकिन कुछ लोगों को जैसे मुझे ये सब करने का शौक है या झील है, इसको अलग चीज़ है। ही स्पेंड 1.5 मंथ साल में के पैरा मेडिकल चीज़ में। तो ही इज़ अ ऑफिशियल ट्रेनर ऑफ पैराग्लाइडिंग, ही इज़ ऑफिशियल ट्रेनिंग ऑफ स्कीइंग। पैराग्लाइडिंग उसने कामशेत में किया, और स्कीइंग कहाँ से किया? मनाली में स्कीइंग करने ये और उनकी धर्मपत्नी मेरी भाभी जी, नमस्कार भाभी जी, थोड़ा वो खड़े रहो। तो ये दोनों गए थे, ये मस्तबे के नीचे घसरा, ये भी घसर के गिर गई। वो फ्रैक्चर लेके 7 दिन मजा किया, इसने 7 दिन पूरा ट्रेनिंग लिया। नाउ ही इज अ ऑथराइज्ड ट्रेनर ऑफ स्कीइंग ऑल्सो। तो जो ऊंचाई से नीचे आया स्कीइंग करके, तो साइकिल पकड़ी उसने। ओके, अब मैं एक कार ले रहा हूँ, एक साइकिल ले रहा है। साइकिल से उसने पूरा कोकन किनारा घूम के आया। सी, to take a car is easier than to buy a cycle and roam around the Konkan, right? फिर जमीन पे रहने वाला आदमी है, जमीन आसमान हो गया, जमीन हो गया, पानी कैसे छोड़ता वो? तो वो चेन्नई में गया, स्विमिंग हम दोनों साथ में सीखे, और तभी भी मैं मस्ती करता, इसलिए जल्दी मैं सीखा, ये बाद में सीखा। बराबर है ना? क्या झूठा सांग, खोटा सांग, तो ये बाद में सीखा। पर वो इतना सीख गया कि वो चेन्नई में जाके स्कूबा सीखा। उसके बाद और एडवांस ट्रेनिंग जाके लक्षद्वीप में एडवांस ट्रेनिंग किया, और ज़्यादा नीचे 60 फुट बढ़ गया। वहाँ भी रुका नहीं, मतलब रुक जा, बहुत नीचे ज़्यादा मत जा। उससे और नीचे गया, अंडमान निकोबार में जाके और एडवांस स्कूबा सीखा। नीचे जाके उसके आगे जा नहीं सकता ना, रुकना पड़ा। तो ही इज ऑफिशियल ट्रेनर फॉर स्कूबा ऑल्सो। और इतना करके भी ये आदमी ज़मीन पे है, प्रैक्टिस भी करता है। इज़ अ पेडियाट्रिशियन, हैज़ 20 bedded hospital in a district known as Yavatmal, next to Nagpur. He is a ex-president of IPA, Indian Pediatric Association. He was last year president of IMA also. And you might have heard him last 2-3 conferences. And I get 10 phone calls, 15 calls, अरे रत्न रखी, तेरा भाषण अच्छा था, लेकिन तेरे से तेरे भाई का ज़्यादा अच्छा था। मेरे से फिर से जेलसी होती है, बट लेकिन ठीक है, 1 डिग्री ज़्यादा मेरे पास, टिंग 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 करके। एनीवे, दिस इज व्हाट माय ब्रदर इज। नाउ ऑल योर्स। थैंक यू सर।
So thank you for a very touching, nice and introduction. This is what Ram Lakshman is. Okay, and Ram Lakshman is known for the brotherhood which is there. What he was telling to you all is something different. But what I developed passion is for healing. Healing is my passion. And the statement which is there, which everybody knows, any human being who is in capacity to produce a disease is also having a genuine capacity to heal yourself. So that is the passion. And in this journey, for more than 35 years, I got a very interesting secret which I am going to share you. So there is no slide, but I am going to touch your hearts. I am going to touch your hearts, my dear friends, because this is something new which is going to motivate you, and this is for the first time in any conference that we are having experiential learning. Everybody is coming showing the slide, this is there, but everybody talks that hypertension, heart disorders are growing. Are you, ask to your own heart, are you really satisfied treating the patient with medications? Are you really satisfied treating the patient interventional cardiology? And just go into your own heart, and are you having heart inside you? And do you want your heart to be healthy, yes or no? So during this next about 45 minutes, I am going to deal with how to keep your heart healthy, because you are most important for you, because you won't want to go into photo and get garlanded by you. Yes? Yes or no? So we are learning in pediatric way. Are you ready for that? We are learning in a pediatric way. Are you ready for that? With a clear slate of mind. Say, George, say yes. Yes. Once more. Yes. Those who are having heart should stay here, and those who are not having can go out. So I think everybody is having heart. And dear friends, now imagine this is a class which is occurring, and I am going to play a very interesting skits which are there. And now, being cardiologist, you have to scan my heart. Are you ready for that? You have to scan my heart here. I am going to do little skits. Okay? Now I am turning back. And you all know, when we were students, our best way was to look at our teachers and make fun of it. That was the best job we had. Yes or no? Say yes, George, say, because we want. Yes. So, and now being a cardiologist which are here, I request to them, scan my heart, how it is beating. Are you ready for that? Yes. Okay. My dear friends, today we are going to learn about heart. Heart is a very interesting organ. In the mediastinum, a fish like, it's beat beautifully and keep you alive. How is my heart? This heart is tak, 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 tak. How do you feel when I say like this? Come on. You feel because I could connect with you and you feel good. And the best life experience of your own being is when you feel connected, you feel good. Why you like this conference? What is the difference between this conference and other conference which you have attended? Anybody can come forward. What is the difference between this conference and anybody attending other conference? Lively, because you feel connected. And this is the best part of human being, when you feel connected. And just imagine, now we are learning the states which are very, very important. So this state we call as a ventral vagal state. What do you mean ventral vagal? You have very good nerve called 10 cranial nerve. That nerve is a wandering nerve. And when you talk, when you give gestures, when you smile, and when you feel that love and connection, then you are best. And you remember, when your heart is best, in picnic mode. When you are dancing mode, when you are singing mode, your heart is best. So we human beings can live better when you are in connected way. And this conference is best because we feel the connection. Are you understanding my point? And if I ask you a very interesting question, who was the best teacher in your life? Your answer will be such and such teacher, because he was not a good teacher, because he connected. Why Gaju said these few words? Because it's connected. We can sense that connection, and we are the ventral vagal people. This is the ventral vagal state. So this is what we call as a sympathetic expanded state. Can you understand? And when you are in sympathetic or easygoing expanded state, you are best healthy like this here. And what is the greatest disease in the world? What is the greatest disease in the world? Loneliness is the correct. Very good. Give a grotesque, this is loneliness in the crowd. Now, second skit. Yes, I am coming. Have you prepared your work? You are the worst batch I have seen in my class. How are you not attending? If I am going to work all the time, how do you feel? Yes. Bad, no? You can see same. Heart is same, person is same, but something different. And this heart is second. Can you see? This is something different. This is sympathetic constricted. Why I am telling you like this? You go within your own person's psyche and see. If you are all the time in that, I am the boss, I am the boss, you should listen. When what? You don't feel good here. And this is classically, you can feel the constriction like this. This is defensive state of human beings. And when you remain in defensive state of human being, there is always sense of constriction. Now, this lecture is going to make you introspect. Now, third skit is coming like this here. How are you? The heart is very important organ. It is placed in a mediastinum. It is covered by a chest wall. And you, how do you feel? How do you feel it? Something new which is there, something more different like this. Come on, scan the heart. Yes, these are the first one. Yeah. The another defensive state which is there is called anxious state, and this is called a sympath. If you are keeping yourself in a continuous sympathetic excited state, most of the cardiac disorders like arrhythmia, tachyarrhythmias, sinus tachycardia, all these things are going to there, and this we are become the pattern of that. Are you convinced of this very important? Because our whole has become very small, smelly small, so you can look with a microscope. But holistic is a big thing. Holistic is a big thing. You can look a bigger part, and when your heart is looking like this, you have different vision. Are you convinced like this here? Next. क्या आज भी लेक्चर लेना पड़ेगा मुझे? तो पता है हार्ट क्या रहता है? Heart is organ present in the chest wall, and it beats. How did you feel? Something different? Lethargic. So this is very important. There is another state called dorsal vagal. Ventral way you are connecting. Dorsal vagal is a reptile state. You don't feel good like this here. You feel depressed, sad like this. Arey lecture jana padega, and I have to take like this here. You don't feel good inside, and you submit. And this is called a low dorsal vagal state. And here the heart will be rock, 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 rock. Are you getting this clear? So heart is a soup present in the neurological network, neurochemicals, and we treat only heart, not the state. Why I am talking of state? Because you may not be able to change that, but you can change the state of yourself, and this change of the state is going to make you healthy. Are you understanding my point? This is one of very important part of taking this lecture. Okay, it's because nobody like to get ourselves intervened surgically. But you have the capacity to change your state. Are you convinced of this? Very important thing. Next thing. All the time I have to come and take the lectures for you. And you make a lot of fun of me. Are you not ashamed of teasing your teachers? Now, come on. Rigid here. So this is the thing. Next stage is what? High dorsal vagal. Your body, you can sense the body is tight. Breathing is tight. Muscles are tight. And therefore you feel constricted. And this sense of constriction which is there is called as the high dorsal vagal. And most of people, this is a very classical reptile who are try to survive. So we are having two important responses. One is survival response and one is exploratory response. When you are very easy picnic mode, your heart is very healthy. But if you are in defensive mode, fight, flight. So initially that was a fight which was there. Then I was running, that was flight here. This low dorsal means you have just submitted. And you have been compressed dynamo inside. And this state is going to make changes within you. Are you convinced of this very important physiology which is there? Our body responds to state, not to the event. Are you understanding the point? And just go introspect within yourself in what state you are always. Are you running all the time? Are you feeling depressed all the time? Are you feeling sad all the time? Are you feeling angry all the time? In what state are you are? And that state determines the state of the heart. Is it very clear? Now, there is a very interesting question where I am going to give a gift for this. Have you heard Takotsubo cardiomyopathy? Have you heard Takotsubo cardiomyopathy? Who can give? Anyone? Can you give the gift? You can come forward. Come forward. Yes, please come forward. Takotsubo cardiomyopathy. Yes, come on. Can you give the mic? Please give him the mic. Takotsubo is a pot in Japan. Yes.
Takotsubo's cardiomyopathy is simple thing. Whenever you are working under stress, your myocardium gets ischemia because of severe vasoconstriction of the myocardial microvessels. And that part of the heart becomes almost non-functioning. So that particular part, so-called apical dilatation or something like that, that is called as Takotsubo's cardiomyopathy.
Thanks
to some extent, I am not a cardiologist, but I will try to explain.
Yes. Ab bhi bolo. You can.
It occurs in young age. Genetic disease.
Up mic par sab.
It's a genetic disease.
No, Takotsubo is a pot in Japan where it is put for octopus. And it's a just ballooning pot here. And whenever sudden something happens, thank you very much. Give her a big hand. Now just imagine what is happening. So I am just talking like this here, and then something happens, and just I come like this here. What is image happening? Whenever I miss my foot, the adrenal medulla suddenly gush adrenaline, and therefore that feeling which is there, that sudden gush of adrenaline coming from adrenal medulla. Are you convinced of this? The Takotsubo cardiomyopathy, it is seen very classical. Have you heard President Bush? When President Bush's wife died, he was admitted instantly in the hospital with a Takotsubo cardiomyopathy, with a very huge heart which is there. There is sudden dilation of left ventricle, and that is where. There may not be any history of heart disease, but when it's sudden something happens, like a death of a wife or death of somebody which is very intimate, there is sudden surge of adrenaline, there is sudden surge of steroid cortisol, and that causes sudden dilation. This is how the mind and body is connected. And my dear friend, we always talk of the cardiac intervention, but we have huge capacity to understand this. And to tell you, very interesting thing, heart is an electromagnetic organ. And why Indians are suffering? Because we are very lovely, touchy people. Now, can anybody come? I can demonstrate how this happens practically. So I am going to demonstrate how this happens, how we are electromagnetic beings. Can anybody come forward? Just आइए. आप आने वाले सब, come on. And see how this happens, because everything we want to prove. Everybody is convinced of the states? Number 1, 2, 3, 4. Yes, how this works? Are you convinced this? This is something new which is coming here. Ab dekho. Madam, you are standing here. Now you came from here, and now what happened within you? Can you give the mic to her? The mic do. First give her a very big hand. She has come. कैसा लगा आपको यहाँ से आने? How you are feeling inside your body?
Anxious.
Notice anxious. How you are feeling the heart? कैसा लग रहा आपको? See, it has changed. She was comfortable there. Moment she came there, suddenly she came into defensive mode. What we call the flight mode, like this. How are you feeling your hands and feet? Cold. Notice, sir, the internal dimension change. Okay. Now see, you can face to me. Now see what is happening. Yes. I am moving close to her and notice what is happening within you. Okay, and everybody observe that how this electromagnetic field comes. And you all know there is a thought which is coming to the brain, to the body, and electromagnetic field is occurring perpendicular to the flow of current. Yes, everybody is convinced? Now I am coming to near to her and see how you are feeling. Dekho. Are you feeling something which is discomforting to you? Just feel it, feel it. When I am away, there's something different is there. When I'm coming close to you, there's something. Can you sense it? Would you like to describe? Yes, would you like to describe what you are feeling?
It's coming close.
Do you like this? No. So this is the electromagnetic field. Our heart is having electron. So you will be surprised. See, because she can see me. We'll prove this. Look at the other side. And when I am again coming to you, you say right hand stop. Okay? Look at this. I am just coming to you. You can sense it. She is not looking at me, but still her electromagnetic field is working. Okay? You can say me right hand just like stop. Huh? Are you aware of this? ये कभी देखा है? So therefore, thank you very much. Give her a very big hand. Have you understood what I said? Have you felt it internally?
Yes.
So this is the secret human being having. We human beings are electromagnetic human beings, and we always sense the person who is good to us, we don't allow anybody to come into electromagnetic field. Are you aware of this very interesting thing just now? सबको समझ में आया this is? And this is our electromagnetic field. So we are electromagnetic human beings. Okay? And this happens in our life. Now, today we are talking of very interesting thing that stop alcohol. समझो एखादे व्यक्ति ने अल्कोहल स्टॉप किया तो क्या होता है? Stop smoking, reduce weight. What will happen? A person start reducing weight. Come on, who can tell me? क्या होता है? अगर वेट कमी करना चालू, what will happen? Withdrawal आता है और क्या होता है? Is it a good thing? So weight, basically obesity is the solution to something deeper problem within. Every person experience something a deeper discomfort, and therefore obesity become the outer manifestation. Alcoholic patient have strong internal discomfort which is there, and that becomes the solution. So we are treating alcohol, we are starting stop smoking, we are saying reduce weight, but that is the outer manifestation, something which is occurring outside, and therefore what is more important? Where to deal with the difficult discomfort inside it. And this is what exactly I am going to address. Are you convinced of what exactly I am going to convey here? So everybody is having discomfort inside, and if you can deal the discomfort inside, and there, so I am going to teach you few important things. And everybody is ready to get the experimentation. The first thing which you can do to holistic in your heart is the HRV breathing, which I am going to teach you. Ready for that? Everybody ready? Good learner? First of all, what is HRV? Heart rate variability. Dr. Gajanan taught BP variability, but this is something heart rate variability. We all know. Now let us understand a very simple way. You take breathe inside. No, don't you have to understand basically. When you take breath inside here, oxygen goes inside, oxygen go to a cell level, cell metabolism increases, and there is more demand of energy. Is it okay? When there is more demand of energy, heart is going to take tuck, 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 tuck. And when you breathe out, the release of the energy which is there here, and there is no more metabolic work, so heart slows down. Tuck, 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 tuck. Got my point clear? The ability to change your heart rate according to the situation easily, just like children, what you get in sinus arrhythmia, this is called as a heart rate variability. But if you are stuck in the sympathetic constricted, or if you are stuck in dorsal vagal response, what will happen? You don't change your heart rate variability. And that becomes tough. And that is the most important part of unhealthy heart disease. Ability to change the situation become the ability to become healthy. So Are you convinced of this? सगळ्यांना पटलंय नक्की? The ability, how this can be done is we are going to learn it. Yes or no? हे सगळ्यांना पटलं का? Our heart rate change all the time, BP change all the time. So suppose you are getting a hypertension at one point, it will be normal at the point also. So everything is changing. So how to do that? The first example I am going to teach you is that HRV breathing. हे सगळं व्यवस्थित सगळे जे काय आता सांगतोय ते सगळं समजून घ्या. It's okay. Now you have to do this practically. I will show you how this can be done. So now sit comfortably. If possible, you can remove the shoes. बूट काढून ठेवा आणि आता थोडा वेळ फील करा. This is the practical training which I am going to give of the holistic. Are you ready for that? Yes. Now keep your feet on the ground. Keep your feet on the ground and just notice how your breathing is going on. Just notice it. There is no need to change anything. Just notice. If you want to close eyes, you can close. You can, if you want to keep your eyes open, you can open. And notice and just observe whether your breathing is regular or irregular. What is the answer? Most of us have irregular breathing. Yes, are you convinced about this? Most of us. So what you do, observe the inhalation and just exhalation. Observe there is gentle pause between the inhalation and exhalation. There is no need to change. And in the same chair, allow yourself to sit as comfortably as possible. Now there are four things which are happening. One, when you are inhaling, the air goes inside. And the gentle pause. And when you are exhaling, the air is going in outside and there is gentle pause. So we have four things: inhalation, pause, exhalation and pause. After becoming aware of this process, let your breathing be settled. And now scan your body, what you are feeling inside. There may be dryness of the mouth. There may be restless in the body. You may not be liking sitting idle. Just observe. By observing internally, you'll understand what type of person and pattern you are having. Sympathetically constricted, sympathetically expanded. High dorsal vagal, low dorsal vagal. Just observe the pattern which you are having. And now the healthiest thing, try to just prolong your breathing by inhalation and prolong the pause. The best healthy HRV is which can be achieved by simple breathing only. Inhaling, simply prolonging the inhale. And best way, simply prolonging the exhale and allow yourself to settle in the body. This you can do anywhere. Say 1, 2, 3, 4 you are inhaling, getting the pause, and 1, 2, 3, 4, 5, 6, 8 you are exhaling. The more you prolong your exhalation, you start becoming more easy, more relaxed, and this relaxation occurs automatically. Okay? Go within yourself, feel it experientially. And within short time you feel, this is one of very simple way to do HRV breathing. Are you convinced about this? हे तुम्ही कधी पण घरी करू शकता. Simply prolong your respiration. Okay? So Sagar, can we have that music now? Now you have to do something which is there here. Okay, now there is music which is going on, and आपण नेहमी म्हणतो ना, बैठे बैठे क्या करे काम, अंताक्षरी. So I am giving one letter H. Okay, you can stand also, you can do all, and you have to change the position. जोर से. Can we get very good music? H. Okay, and you have to change. Okay, you can stand, you can sit. Ha. Hey, come on, you have to do it. Hey. Ooh. Ha. Ha. Come on. Ha. Ha. Oh. He. Ha. Ha. Ooh. Ha. Come on. Ha. Oh. He. Ha. Oh. Come on. Ha. 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 Let your limb move. Hey. Oh. Ha. Ha. Hey. 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 Ha. 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 Ho. Ho. Ha. He. Ha. Ha. Ooh. Ha. 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 Hey. Ha. Ho. Ho. Come on. Ha. 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 Come on. Move. Ha. 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 Come on, everybody. Ha. Tap your. Ha. 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 Come on. Ha. 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 Ooh. Hey. 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 Ha. 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 Thank you. Can we stop the music? Now what happened? क्या हो गया? अभी देखो. Within 2 minutes what happened? Means up till now our right brain was thinking क्या आगे क्या है, ये क्या बता रहा है, ये क्या. So in any lecture our right brain left brain start thinking like this here. और वो हर रोज हमको बनाता है, फूल बनाता है. वी ऑलवेज बिकम जज. अरे ये ऐसा नहीं होना चाहिए, ये ड्रेस अच्छा नहीं, ये लिपस्टिक मुझे अच्छा नहीं लग रहा, ये ऑल दिस थिंग विच फूल्स विच आर करिंग ऑल द टाइम. तो ये ब्रेन हमको फूल बनाते रहता है, इसलिए स्टेट क्रिएट होती है. एंड बिकॉज स्टेट्स आर क्रिएटेड वी बिकम डिसीज. वी आर द स्लेव ऑफ आवर ओन ब्रेन. आर यू कन्विंस्ड ऑफ दिस? And these states are continued lifelong, and therefore we become. Can we make brain full? हमने brain को big full बनाया कि नहीं? Okay, why become victim of your own brain? अरे आप में capacity, you have the capacity to change. You have the capacity to transform. So it is possible. Are you convinced of this? It is possible to try to make your thinking. No problem can be thought by thinking. Okay? No problem can be thought. You are trapped in that loop of thinking. You have to pull your thinking and take out of your body to a different new state. Yes or no? Are you convinced of this very simple physiology? HRV breathing सबको समझ में आया? Simply it's a very gentle practice to prolong your breathing. और अपना breathing rate normally 14 है, वो if comes to 5, 6 like this here, by simple breathing, you start becoming healthier. You have to do 2 important things. When you are expanding your inhalation and making your body more oxygen rich, you develop a capacity to tolerate the oxygenated environment. And when you try to release your breathing, you have to train your body to remain deoxygenated environment. The ability to expand between inhalation and exhalation, ability to transform into this ability is the secret of health. And that is the secret of health. Are you convinced of this very way which you can do? सबसे easy part है. Second important point which सबने शादी की है. शादी के बाद अक्ल जो आती है 50 साल के बाद, क्या अक्ल आती है? कम ऑन. शादी के 50 साल बाद क्या अकल आती है? Who can tell me? कभी कभी आती भी नहीं है। क्या अकल आती है? क्या 50 साल में हम सबको क्या अकल आती है? क्या अकल है? बोलो, यू कैन शेयर, कम ऑन। एनीबडी कैन शेयर व्हाट इज द ग्रेटेस्ट ट्रूथ वी लर्न, जिसमें हमारा लाइफ यू कैनॉट चेंज द पर्सन, लेकिन हम सक्सेसफुल मैरिज क्या में क्या सीखते हैं? क्या एक्सेप्ट सबसे इंपॉर्टेंट बात है, वी अंडरस्टैंड द एक्सपांशन ऑफ टॉलरेंस, वी स्टार्ट टॉलरेटिंग द पार्टनर। We have two choice. We have two choice. Either tolerate with that compressed different state or tolerate with expansive state. These are choices which you have. Barabar, are you understanding this? So the secret of health is expand your emotion, expand your understanding. So which I will going to, हम जो दूसरा experiment करने वाले हैं 10 मिनट का, we are going to learn this. Okay, please give me the timings. Huh? Okay. Okay. So to and second what happens, हम जब गुस्सा होते तो क्या करते हैं? How do you feel? गुस्सा होते तो क्या करते हैं और गुस्सा होने के बाद कैसा लगता है हमको? जब थका हारा आदमी आता है, डॉक्टर आता है घर से प्रैक्टिस करके, और जब उनकी बीबी चिल्लाती है, अरे तुमने ऐसा नहीं किया, हाउ डज शी फील्स? कम ऑन, एक्साइटेड, नेक्स्ट, irate, next, she feels happy. She feels happy कि कितना अच्छा, when how the thing which was boiling inside me is vented out by somebody else. So we want to discharge the locked emotions inside. So there are two important things of healing. Number one, expanding emotions within our body, and second, discharging the emotions from the body. So healing practice in two important secrets. It will never forget the mind. Number one, expanding emotion, which we are going to learn shortly. And second part we are going to learn is the discharging the emotion. And you will be very surprised how body discharge emotion. What we are talking of acidity, yawning, बरेच आपण पहा lecture मध्ये आपल्याला खूप जांभा यायला लागतात. When you are having a boring lecture, somebody telling like this here, okay, we get lot of yawning. This yawning is nothing but discharge of energy which is occurring in the body. Okay, so now we are going to take a practice of 10 minutes to understand this. So have everybody understood HRV breathing? Yes or no? कोणाला काही विचारायचं का याच्याबद्दल HRV breathing बद्दल? And second part we are learning embodied psychology and how body release it. Yes, so this is around say 5 to 10 minutes practical, then we are going to stop it. Is okay? So this now, this is a very simple procedure. तुम्ही एक छोटंसं काम करा, बूट काढून टाका आणि पाय ग्राउंड फील करा. यू हॅव टू फील युअर ग्राउंड अँड सिट कम्फर्टेबल वेअर यू आर. दिस इज एक्सपिरियन्शियल. एव्हरीबडी, इफ यू वॉन्ट टू क्लोज द आईज, इट्स ओके. इफ यू टू ओपन द आईज, इट्स ओके. अँड जस्ट फॉलो माय व्हॉइस विच आय एम टेलिंग टू यू. आर रेडी फॉर दॅट? येस ऑर नो? तर सिट व्हेरी कम्फर्टेबल इन युअर चेअर. Sit very comfortably in your chair. And let your eyes be gently closed. Let your eyes be gently. Try to follow this because we are going to experience something new. For the first time, we are going to experience by our own human being. Let your eyes be gently closed. Keep a pin drop silence now, just because you are experiencing your own being. And just notice at the moment what is happening and feel the touch of the ground which you are touching. And allow yourself to be more settled in your own chair. As if you are allowed to be as easy as possible, relaxing in a beautiful chair with a beautiful food being served to you, and you're enjoying that moment. And feel the support which chair is offering to you. Feel it. Let the judging mind be off at the moment and feel the chair which is giving support to you. And allow yourself to settle within your own breathing. You are giving full permission to settle in your breathing and observe you are breathing in and observe you are breathing out. Just observe. You may want to sit, but judge, but at the moment you are leaving the temptation to judge and simply listening to my voice. And you are allowing yourself to settle more, just like water settles automatically. You are allowing, giving permission to settle more. And experience what is happening within your body at the moment. And if you go within your body, some parts may be tight, some parts may be relaxed, some parts, some impulses may be coming. Just be aware of it. Be aware of touch of the ground. Be aware of the support your chair is offering to you. And now for some time, imagine the best experience of your life. You may be awarded. You may be got the best opportunity, and you relive that experience. As you remember that experience, any one of the best experiences of your life, as you remember that experience, notice what change your body is bringing out. It may be automatic yawning. It may be sense of expansion in the chest. It may be sense of expansion in the head or any part of the body. Just experiencing that. At times you may not be like to close the eyes, but you can open anytime. Feel the internal environment of your own body. How it changes when you remember something pleasurable in your life. Notice how your breathing become more expansile. Notice the comfort and notice how you automatically go into a relaxed state. And notice how your body is getting adapted to this pleasurable experience. Yawning may start automatically, body is discharging that. As you progress further, you are moving out of that experience, and imagine you are experiencing something terrible in your life. Some quarrel, you may remember some quarrel. Or you may remember some discomfort which is occurring. And as you remember that, notice the change which is occurring in the body. Immediately your internal environment is changing. As you remember, a discomfortful experience. Your internal structure is changing. Your internal physiology is changing. Very minutely observe your internal being. Allowing yourself to resettle more. Feeling it. More lighter. Feeling the lightedness in your eyes. And allow your eyes to gently open. Let there be a beautiful smile on the face. Let there be enjoyment on the face. And open the eyes. Okay? And just as you go through this, first experience, expand ourselves. How it going to sympathetic expanded state. But the moment we remember something discomfort, our body constrict, and you will be surprised to know this constriction may be felt in the chest, in the heart. You feel discomfort heart. This is how emotion can bring the heart disorders. It can produce headache. How it is? Where it is coming in the head. Migraine become the in-lock emotion. I ask you very interesting questions. Have you heard any animals suffered from heart disorders? Any animal giving stent or any animal has done vulvoplasty. Have you heard this? We are the animals also. On the contrary, we are the most intelligent animals. Why we suffer? Is a very important question to be asked. Because animals, if you look at any animals, तुम्ही जर गायीच्या पाठीला हात लावला, गाय थरथर करते. What does she? She release the discomfort by simple shaking like this here. Okay? कधी लहान मुलं असे शेक करतात. They want to release. So we hold these problems for years together and fix into one particular state, and therefore we are diseased. Are you getting this very important statement? We do not release it. We hold for years. वो गुस्सा जो है वो आज भी हमारे, and therefore we either lock in the sympathetic constricted state or high dorsal vagal state. And this create whole change our whole male interior body, and that is why we are diseased. And we can change this by changing the state. And changing the state is what is the concept of holistic cardiology, and it involves the very classical state MBBS, MD and DM. You will be surprised how the MBBS. This is a very, very interesting analogy. M stands for mind, learn about the mind and how mind works in the body. Once you understand how the thought process is working and how it affects the body, you can transform yourself because you want to be healthy. Second important, B stand for breathing. If you change your breathing pattern, if you slow down your breathing, your internal environment can change. Again, B stand for brain. If you learn autonomic dysregulation, हमको सिर्फ बताया गया sympathetic parasympathetic, but it is not like that. I invite you to learn polyvagal theory. Polyvagal theory changed my life, whole life perspective. It is not simple sympathetic parasympathetic. It is ventral vagal, sympathetic and dorsal vagal. Ventral vagal we human beings, sympathetic means mammalian, and dorsal vagal means reptiles. We have all the three brains means here. So changing this configuration occurring inner level, we can change anything. Breathing, brain. So the thing should be taught to all of us doctors is autonomic dysregulation, which is very, we always talk of give beta blockers. क्या करता है beta blockers? It is only suppressing the autonomic dysregulation. We have that capacity. So learning brain. So M stand for mind, B stand for breathing, B stand for brain, and B stand for body. ये problem body में है. If you are very angry, you are holding the emotions in the joint. Okay, and that becomes dorsal vagal activity. That is the cause of rheumatoid arthritis. We are not aware of this. So this is the how body is, how we store emotion body. If you understood, you have new dimensions like this here. And S is the what is psychic energy. जेव्हा तुम्ही रात्री झोपायला जाता बऱ्याचशा सायकिक एनर्जी आपल्या बॉडी वी वॉन्ट टू रिलीज इट समथिंग विच इज डीपली कंप्रेस कम्स अँड वी दॅट कॉज यू टू अवेक रात्र रात्र आपल्याला झोप येत नाही बिकॉज दीज एनर्जी विच आर कमिंग सो सायकिक एनर्जीज which are very important, and to know those who are Ayurvedic people, the science of consciousness Ayurveda is very simple. So working on the psychic energies can give very beautiful relief, the huge field which is there. Then MD stand for meditationally directed. If you are going to learn how to change your state in a making coherent state. आता तुम्हाला थोडा वेळ वाटलं की that is a coherent state. It was very short experience. If you can bring yourself to a coherent state, your body dynamics change. Okay? So meditation directed, creating a state of alpha rhythm. If you can change the configuration, then this becomes the part you can make changes by learning this field in more and more detail. And the DM means डायरेक्टेड मेडिटेशन मीन्स ते तुम्हाला तुमच्या बॉडीमधून आजपासून इमॅजिन करा 20 वर्षांत तुम्हाला काय पाहिजे फोटोमध्ये लटकलेलं पाहिजे ओके की ऍक्टिव्ह पाहिजे इफ यू वॉन्ट टू दॅट यू डायरेक्टिव्ह मॅनिफेस्टेशन यू स्टार्ट थिंकिंग फ्रॉम टुडे की मला तसं जगायचं नाही आहे आय वॉन्ट टू मेक डेली चेंजेस आय वॉन्ट टू मेक अंडरस्टँड माय सेल्फ व्हॉट इज हॅपनिंग माय पॅटर्न अँड देन आय कॅन ट्रान्सफॉर्म माय सेल्फ दिस वॉज व्हेरी क्लासिकल फ्लो ऑफ MBBS MD and DM, and then you become holistic cardiologist. So thank you very much for this new understanding. Hope you enjoyed. सबने enjoy किया? Something new? Thank you very much. All meditation is same practically. लेकिन हम किसी गुलाम बनते हैं. Somebody become teacher. You have that potential to understand this. But I hope you understand something new which was there. Yes. Thank you very much.
Thank you so. Hours. Hello. Hello.
You can ask any question if you want. Huh? Yes.
Don't leave the hall, please. There is bumper prize coming.
Okay. Okay.
Thank you so much, sir, for such a well-informed session. Your experience and knowledge will no doubt help all of us. Now, before moving forward, I have an important announcement.
Madam,
Treasurer Dr. Seema Tiwari, MCP Treasurer Dr. Sharid Dadish, sir, Smriti Madam, Dr. GPR, sir, Convener Dr. Ram Chavan, Mrs. Sanjay Ratnaparki, Madam. A huge round of applause, please.
Thank you, thank you. Dila.
Ganpati Bappa.
Moria.
Mangal Murti.
Moria. Dila.
Before moving forward, I have an important announcement. National Integrated Medical Association, NEMA, Mumbai Division is organizing NEMA DivCon 2023. MCIM accredited conference on 29th October 2023 at Mewar Vatika, Mira Road. Conference will start from 8 a.m., will last till 5 p.m. Registration charges will be 700 only. NEMA has a team of registration. Please come near dais. There will be lots of early bird prizes, lots of bumper prizes. So register yourself with NEMA DivCon 2023 with registration committee. If you want to register, please register with them. Now moving forward to the last lecture of the CardioCon, I would like to request Dr. Aniruddha Bhuyan on dais, please. Dr. Aniruddha Bhuyan is the first qualified MCH in peripheral vascular surgery in Mumbai, specialist of both open surgery and interventional endovascular procedures. He did his MCH from Ramaiah, Bangalore after his MBBS and PG. He was selected to train at the prestigious National University, Singapore. Currently, he is working at Holy Spirit Hospital, PD Hinduja Khar, Holy Family, Bharti Arogya Nidhi, Criticare Hospitals, Mumbai, with this great motto of saving lives is saving life. He is updated to the current therapies available, including hybrid, where simultaneously both open and endovascular operations can be used to treat complex vascular disorders. A big round of applause for eminent speaker, Dr. Bhuyan.
Good afternoon, everyone. I'm Dr. Aniruddha Bhuyan. I'm a vascular surgeon. Yes, I'm not a cardiothoracic surgeon. I'm a vascular surgeon. I treat all peripheral arteries and veins, barring the heart and the brain. And Ratnaparki sir has told me to speak to you about varicose veins. All of y'all are kings and queens in your respective practices, and this talk is just to fine-tune what I know slightly more about varicose veins. Now, the topic given to me is varicose veins. It's a common problem. Is it neglected or is it overtreated? Now, everyone, just see this photo. What do you think? Is this varicose veins? You have some large veins which are seen here. And we have treated this patient. But this is what we call as a lymphovenous malformation. It is not lymphedema or hathi pair because you don't have any swelling which is there in the leg. This is only a large swelling which is there in the calf. And this is what is a malformation. We treat this with excision. We reduce the venous leakage of the varicose veins. And this patient looks like this post-op. What do you think? Is this varicose veins? What do you think it is? Anyone? Yes, this is a classical patient of lymphedema. Now, the treatment of lymphedema normally goes from lymphatic bypasses to nodovenous shunts. There is also debulking, which we do in such a way. I'm sorry, I'm probably the only surgeon here after the physicians, so my pictures may be slightly gore. But this is what we achieve as an outcome. We have a patient who comes with swelling in the leg. The swelling reduces after treating the venous and the lymphatics. And this is what we get after the surgery. Now, what do you think? This is not a varicose veins. It is a venous malformation. A venous malformation is not an arteriovenous malformation. An arteriovenous malformation has arterial blood which is pushing into the smaller veins which are there. But this is just a dilated intramuscular vein, and this is how we remove it. Now, what is varicose veins? Varicose veins are primarily dilated or large veins which is there in the body. So what does happen is, the valves which are present in the veins, these valves normally hold the blood. The good blood goes from down to up and does not leak back. When this vein dilates, it dilates to more than 3 millimeters. The valves open and close, so the blood goes up and it comes down again. And that is the reason why in varicose veins, the blood which is supposed to go to the heart does not entirely go to the heart and leaks downwards. Now, what are the common questions which probably you may have, or probably even the patients have? Are they dangerous? Yes, they are. If they clot, if there is bleeding from them, they are definitely very dangerous. How do they form? The question is normally given, the answer is given that most are genetic, or if you are standing for a long time, or if there's a gene mutation which is a CAZ gene which is there predominantly in the South Asian population, you get varicose veins. Did I inherit it? Probably. What tests we can use? That is what we'll discuss from now on, and what treatments are available, that we'll discuss. Now, the types of varicose veins are mostly primary. We see mostly in the women who are probably post-pregnancy. We see it in the elderly age group, and there's a very strong family history. In terms of the secondary varicose veins, it can be post-phlebitic or post-DVT. Any patient having a deep vein thrombosis, there is no other way to go out. Highway band hai. So what do? You take an alternate route for the blood to go up. And that is what the problem is. Patients having a DVT may get varicose veins in 2 years' time. So every time a patient comes to you with a deep vein thrombosis, give the patient a blood thinner, give the patient a stockings. These two things will help in breaking up the clot as well as preventing a post-thrombotic leg or a post-phlebitic leg which is having varicose veins. There is mechanical obstruction you can have in cancer or any other abdominal mass which compresses. There can be a high predisposition in smoking because there is irritation of the vascular wall or the intimal wall. And there can be also arteriovenous malformations. Now, this is the normal presentation which you have. This is hyperpigmentation which occurs. There can be venous ectasia, can be dilated veins in the leg. The hyperpigmentation can proceed to form a venous ulcer, or there could be just skin induration and some dilated veins here and there. Now, the patients may not come to you so early, although some may, but they end up coming with ulcers. Now, there is a difference between the left image and the right image. The left image is what we call as an arterial ulcer. An arterial ulcer is because of the blood not able to go into the legs. The image on the right is what we call as a venous ulcer. That happens in the gaiters area, that is the area which is there just at the ankle. And this is all because of the leakage. Some more images of arterial gangrene, which can form ulcers. What do you think this image is? This is primarily a mixed ulcer. It has a venous component, it also has an arterial component. And this, in this patient, is debrided, so you may not get the real sheen of the, the tissues over the ulcer which were forming. These are classical venous ulcers. They happen in the gaiters area, just above the ankle, and as you can see here, our main objective in such cases is to go from here to here in the fastest possible time. Now, the main difference between arterial and venous ulcer is that in arterial ulcer, there is no pulse. The skin is cold and clammy. There is severe pain. A patient cannot sleep. A patient cannot sleep with the legs up. The patient keeps the legs down. And because of that, there is a swelling. So if a patient having pain in the leg comes with a swelling to you, remember one thing. Venous and arterial both cause swelling. But the arterial swelling is because the patient sleeps with his leg down. The venous swelling is because the blood cannot go up. This is a normal representation of what we call as perforator incompetence. And this perforator incompetence, as you can see, the blood is going from inside to outside and down. Now, the basic difference between the types of varicose veins are the small varicose veins, what we call as spider veins, telangiectasias, reticular veins, which are less than 3 millimeter. Now, these veins normally do not require treatment. If a patient comes even to us, we tell them, see, these are small veins. They do not have that much amount of blood to cause symptoms for you. You do not require to treat them. The treatment is primarily cosmetic. But if the veins become more than 3 millimeters, they come in the category of varicose veins. And that is where the problem starts. So the problem can be cosmetic. Many patients can come, say, doctor, I don't like the look of the veins. It can be symptomatic, where there is dull aches, muscle cramps, muscle fatigue. It can be swelling in the legs. And later on, it forms an ulcer. And when it forms an ulcer, what it can do is, it causes bleeding. Bleeding, why? Because the blood can't go up, it goes down, it finds a breach in the skin, it goes out. So as I tell my patients, Jwalamukhi foot rahi hai. It's a volcano which is erupting. And that is why whenever a patient gets bleeding of varicose veins, please tell them, keep their legs up, do not walk, let the blood clot off, and you will be absolutely fine. Thrombophlebitis is basically a clot in the superficial vein. If you have blood pooling in the leg, blood at one point, if it remains, it will clot. And that is the main problem these patients have. There is something called, sir was talking about arterial hypertension, Dr. Sanjay Ratnaparke sir. This is what I'm calling is venous hypertension. Now, venous hypertension is basically the blood not being able to go up, it goes down. The leg becomes congested, it's tight. And that is why it is called venous hypertension. It has to let go. As sir was doing in holistic medicine, you try to relieve the stress. What is the relieving of stress in the leg? You keep the leg up. So probably one more exercise which you could tell the patients would be keep your legs elevated and everything will be fine. The fourth most common thing is eczematoid dermatitis. And that is the skin inflammation which happens because of the dryness, and later on it forms an ulcer as well. Now, there is a CAP classification which we follow. I will not bore you with this. But the basic thing is, Whenever the class 4 is skin changes, class 5 is ulcer healed, and class 6 is an active ulcer. We need to treat varicose veins only in these three conditions. We should not be treating or over-treating a class 2, which is just varicose veins, or a class 3, which is swelling. You do not do a laser, you do not do a radiofrequency, you do not do a venous heal for such patients. Now, there are some patients who come with too much varicose veins. As you can see here, this is not normal varicose veins. So whenever there is a problem like this which comes to you, please, this patient does not require a varicose vein surgery. This patient requires to be investigated, because mostly if the varicose veins, the blood is not able to go up, there's an obstruction here. So such patients, you should do a CT or an MR venogram to understand whether the blood is actually able to go up or it is just leaking down. So the first thing we do is we do a Doppler. Now this Doppler tells us in terms of how bad the leakage is. You tell the patient to hold the abdomen tight, and the patient feels that he's defecating, and that is when you check for junctional incompetence. The saphenofemoral, the saphenopopliteal junction, and perforated incompetence is primarily checked with reversal of flow. Now, there's another way to check for the reflux, and that is in standing position. Now, most of the people will say, why in standing? Most of the radiologists call me and tell me, boss, this is too difficult. I don't have a tilt table. What do I do? Let me do it in sleeping position. The problem is, as I can show you in one of these reports, is that you see the patient in sleeping, the great saphenous vein is 7.5 millimeters. And you see in standing, the great saphenous vein becomes around 9.5 millimeters. So that's a good 2 millimeter increase in the size of the vein. Why does this happen? Because gravity is actually playing the prank. You do not have varicose vein symptom when you're lying on the bed. You get varicose vein symptom when you're standing, and especially standing for a long time. So for these reasons, always evaluate the leg veins while standing. Do not lie down, and you can get it done. It gives a very good idea, but it is always better in standing. Another thing which I would like to tell you is that every person has a calf pump. Whenever a person stands or walks, the calf pumps and the blood goes up, even if the valves are not working. If the vein diameter goes above 5 millimeter, that is when the calf pump becomes ineffective. So these patients who are having, say, 7.5, 8.2, and then it goes down, these patients are, even if they have, although this patient has a junctional reflux, even if these patients have a normal vein or a normal junction, they will not get elevated from the symptoms, because the vein will keep on refluxing. So what are the management options? The first thing you should always offer the patient is conservative. Whenever a patient of varicose veins comes, find the options which are there. Find why the patient has got varicose veins. If the patient has visible veins like this as well, start the patients on stockings. And tell the patient to have good exercise. The main problem which we all have, especially the ladies, low in vitamin D, less of exercise, large legs, large visible veins. These patients, if they exercise, the calf pump will be much better. And if a patient is not able to walk, has some joint problems, the patient can just elevate the leg, do ankle dorsiflexion and plantar flexion. That will simulate walking, and that is what will be comfortable for the patients. Please tell all patients to wear stockings who are having varicose veins. Stockings comes in 4 types. There is class 1, class 2, class 3, and class 4. Normally, the class 4 is not available. It is only 1, 2, and 3. 1 is 10 to 15 millimeters of mercury. 2 is 20 to 30 millimeters of mercury. 3 is 30 to 40. Now, where do we use what? If you're taking a flight, if you're going from here to, say, New York or Singapore, you wear a class 1 stockings. They are anti-DVT stockings. They are 15 millimeters of mercury at the ankle, 10 millimeters above in the below knee calf area. What that does is, it closes the veins. the outer veins. You improve the circulation in the deeper veins, you do not get a clot in the flight. What class 2 does, most of the varicose veins require class 2 stocking, that is 20 to 30 millimeters of mercury. And what class 3 does for lymphedema patients, where you require even more compression, it is 30 to 40 millimeters of mercury. A note that the lymphedema patients, there are pumps which are available. These are lymphatic pumps or the lymphatic drainage pumps. And that is what helps them to reduce the swelling. But a lot of you might say, results matter. If a patient with varicose veins comes, he doesn't like the look of the veins. I don't want to offer any conservative management to the patient. He wants the vein gone, even if the symptoms are not there. Now, for the symptomatic ones, as I said, 4, 5, and 6 in category, that is discoloration, ulcer, healed ulcer. We normally, there were in the olden times open surgery where there was stripping of the veins which was done. There is endovenous surgery, which is radio frequency, laser, etc. For smaller veins, we use sclerotherapy, that is foam sclerotherapy. And the new kid on the block is VenaSeal. Now, this is what stripping looks like. You put a stripper all the way from the below knee area till the saphenofemoral junction. You strip the whole vein out. And it's a very good procedure, ideally. But it completely does not look at the below knee perforators. And that is the reason why probably the laser has taken over. Now, in terms of endovenous laser ablation, there are multiple nanometers where the fibers which we use are of different powers. The higher the wavelength, the lower the frequency. And the lower is the penetration of the laser into the skin. So now what is standard and used is the 1940 nanometer, the 1940 nanometer laser. It is more in the infrared spectrum. The higher the wavelength, lower is the frequency. A video about radio frequency ablation is what we have put here. And this is similar to laser. The basic thing is it burns it thermally. That is, it causes heat to be formed. And that heated segment, as you keep pulling back, the segment becomes blocked, and then you proceed to the next segment till the complete segment is treated. Now, these are one of my patients where we do laser for such ulcers. This is a very small venous ulcer, which I'm showing you. And when you put an ultrasound probe, you see that there is a vein which is there below the ulcer. And you know that this is the cause of the problem. And that is why that vein is connected to a leaking saphenofemoral junction. It creates a problem. So what normally we do is in laser, we puncture the vein. This is just above the ankle. And once we get blood behind, we put in a wire through. After that, this is what the fiber looks like, a laser fiber. We put the laser fiber into the vein. You can see the light of the laser in the vein. You can see those popped out veins in the way. And this goes all the way up till the saphenofemoral junction. The laser ablation basically looks like this on ultrasound. So you get a vein which is burnt. You see a fiber getting pulled back. And it completely burns. What was a tube earlier? The entire tube becomes obliterated. The entire tube becomes small, and the vein gets completely burnt off. Now we come to sclerotherapy. Now, what is sclerotherapy? There are different sclerosants or detergents like sodium tetradecyl sulfate, polydocanol, sodium morhuate. Now, these sclerosants causes irritation to the intimal lining of the vein, and that is what thromboses or clots it. There are two ways we can do it. One is a USG-guided sclerotherapy, where we have an ultrasound probe, and that guides us. These are one of my patients, where we connect a butterfly, we go into the vein, and that is USG-guided, and we make foam, and we inject it into the vein. As you can see here, the vein is completely dilated, and then it whites out. As we inject sclerosant into the vein, the entire vein thromboses. And the best thing about sclerotherapy is it's like the roots of the tree, meaning it just keeps spreading and spreading and spreading. There is no direct catheter which you need to place inside. Next, we come to foam sclerotherapy, which is more for smaller veins, direct injection, in which what we do is, there are multiple patients who come with spider veins. So this is more cosmetic. It does not cause any functional improvement in the outcome of the patient, but it's more cosmetic in nature. You see the blood coming back after the puncture. And then once we inject the sclerosant, this is a combination of air and polydocanol, and it is diluted to about 0.5%. And that is when you see the complete disappearance of the vein in this area. You see, these are black and these are white. And that is how this is the basic way we cosmetically treat the smaller spider veins, reticular varices, which are there. Okay, you can see the difference here. This is completely white. Now, the new kid on the block, Venasil. Many patients, because of company pushing the product, Medtronic especially, what has happened is many patients come and say, I want only Venasil. Yes, it's a very good modality. It does not require anesthesia. And I will show you how it looks. It basically looks like a gun. It all depends whether you use the gun like a proper gun or like a toy gun. Because at the end of the day, the glue which is there in the Venasil catheter has to reach the vein which it has to block. So how it reaches is, you see this catheter which has medical grade cyanoacrylate glue. It keeps going down as drops. And that once you pull back, the entire vein thromboses. And that is the beauty of Venasil. Now, let me talk about post-thrombotic syndrome. I had already spoken to you earlier. Any patient who is having a black leg with veins does not necessarily have only varicose veins. It can also be a blockage in the iliac vein, and that is what is called as a post-thrombotic syndrome. Any patient getting a DVT sometime earlier will present to you after, say, 6 months, 1 year, 2 years, says, doctor, my leg is becoming black. My Doppler shows I have a lot of varicose veins. What should I do? Do not do a laser for that patient. If you do a laser, if the highway is blocked, if the side roads are blocked, you're going to make it terrible for the patient. And the patient's ulcer and the wound or the swelling will completely become worse. This is one of the patients who presented to me with a post-thrombotic limb. Once we do an MR venogram, we find out that the entire common iliac vein and the external iliac vein is occluded. And the patient has so many varicose veins below. So in such a patient, we normally put a wire across, I do an angioplasty, I put a stent across, and the blood flow goes. This patient, sometimes these patients don't even require varicose vein surgery, because once you clear the highway off, everything is just cleared off. But what do you do if my wire doesn't cross? So in this patient, I've done a veno-venous bypass, which is actually, the name is Palmerdale procedure. Now, this patient had a left common iliac vein occlusion. So what I did was, I removed the great saphenous vein, I tunneled it through this tunneler from the right saphenofemoral junction to the left saphenofemoral junction, and I plugged one near the saphenofemoral junction and the other in the great saphenous vein. So basically 2 ways for the blood to enter the graft, and then that going on the other side and then going up. These patients normally tend to do well, because at the end of the day, you should also note, the life of a stent is only 2 years. After 2 years, if the stent goes ahead, it is all because of the medications you're going. Now, the second question will ask me, why then stent at all? The thing is that whenever these patients come, the problem is the wound. You treat the wound. You make sure whatever you do treats the wound. After the wound is healed, you have to keep these patients on lifelong blood thinners. And those blood thinners make sure that the collaterals form. So you give at least 2 years for the collaterals to form, so that even when the stent goes down, your patient does not have symptoms at the end. I thank Dr. Ratnaparkhi, Dr. G.P. Ratnaparkhi for the opportunity. Thank you.
Thank you, sir, for such a knowledgeable session. Questions, sir, please. Mike.
For the Moses sign for DVT, you're saying? Yes. So normally what happens is, as I told you, when you're doing a painful dorsiflexion, plantar flexion, you are increasing the venous return. So if, for example, the patient has an acute DVT, you might end up throwing the clot above. So whenever there's a patient of DVT, kindly do a Doppler first. No. The indication of IVC filter is only when there is contraindication to anticoagulation, when there is a complication to anticoagulation, or if you cannot give anticoagulation because of some reason. Now, mostly all the filters which are put earlier, many of them were unindicated. But there are strict guidelines as per the protocol of SVS. These are the 3 strong recommendations for IVC filter. Now, what are the indications of IVC filter, you might ask? Commonly, we see any thrombus in the IVC, if it is floating, or the patient has got a pulmonary embolism, in spite of being on blood thinner, you put an IVC filter.
What is an angiojet?
Okay, so an angiojet is a mechanical pharmacomechanical thrombectomy device. An angiojet, once you put it in the vein, it has a rheolytic system which sucks out the clot, and that completely removes the clot. There are other methods like trellis, which is not in India, angiojet, and there are 2-3 companies like Penumbra and Angiojet which are there in India.
And what is the treatment of bilateral iliac vein occlusion with Leydig syndrome?
Okay, so bilateral iliac vein occlusion may not really cause a problem other than in comparison to Leydig syndrome. A Leydig syndrome is an aortoiliac occlusion. Now, for aortoiliac occlusion, you might have to do an aortoiliac bypass. But for an iliac vein occlusion, remember you have collaterals. So the collaterals do the job. The pelvic collaterals goes by the internal iliac and goes up.
What is the cause of recurrence of the varicose?
Recurrence of the varicose veins normally happens because of undertreatment or because of the fact that there is already a proximal occlusion or a proximal blockage, and because of which it comes back again.
So incidence or fear of getting an air embolism after that foam sclerotherapy, because foam would contain air.
So in foam sclerotherapy, the volume of air, so you understand this, that we use a Tessari method, which is 1 ml of sclerosant with 4 ml of air. Now they are micronized, meaning it is made by 2 syringes which are pressed towards each other, so they have very small bubbles. The air, once it goes up, air embolism happens when there is a large volume going up. Because of the micronization of these particles, they really do not cause any symptoms. I will tell you even more. For peripheral angiography, when patient is having a higher creatinine, we have something called as carbon dioxide angiography. So carbon dioxide is injecting direct carbon dioxide into the arteries, not even the veins.
Thank you, sir. Thank you.
अभी पूछोगे तो चाय पे क्या है, चाय पे क्या चर्चा करोगे ना, चाय पे चर्चा करो.
Please be seated. There will be one more bumper prize and a lucky draw. 7 lucky draws are there. I would like to request AMA Treasurer Seema Tiwari, MCVP Treasurer Sarat Daji sir, if he's not there, Appa President Dr. Ashish Deshmukh sir, Dr. Smruti Ratnaparkhi and GPR sir, to felicitate Dr. Bhuyan. There will be 20 lucky draws and 1 bumper draw. Please be seated. Thank you so much, everyone. Now I would like to invite convener Dr. Tejaswini Ratnaparkhi. Moria.
Good evening, everyone. Good evening, everyone. First of all, I would like to bow down to all of you for your dynamic and divine presence, which has made this conference a huge success. Thank you is such a prayer that cannot be seen or touched. It has to be felt by heart. And I'm extremely honored and privileged to get this opportunity to propose a vote of thanks on behalf of Guru Krupa Heart Foundation and Charitable Trust, and will be in forever debt of your obligations and blessings, which I hope to get throughout my life. I'm too small to speak about our today's legends, who not only inaugurated the function, but their electrifying presence infused adrenaline in us. I'm also very thankful to our speaker, who are of international repute, who enlightened us with their fluent and lucid knowledge, which helped us to peep in our day-to-day cardiology problems, clarifying all the aspects and doubts faced by us routinely. We usually do not thank our family because it's our family. Now, when I say family, I mean AMA, MCVP, Appa, and of course, Guru Krupa family. Their selfless contribution is beyond words. They have done their job flawlessly, better than any professionals. I'm not taking any names here, but they are imprinted in my heart. Events of these dimensions cannot happen overnight. The wheel starts rolling in months advance. We have been fortunate enough to be backed by our pharma team. So thank you, pharma team. I would also like to thank the audiovisual team, Mr. Sachin and his teammate, for your excellent audio work. I would also like to thank Hotel Lalit for the wonderful hospitality, delicious food, and lip-smacking desserts. Hope you all enjoyed it. I am very thankful to the entire team of Guru Krupa Heart Center and Guru Krupa Diagnostic Center. They have been working really hard since last 3 months to make this conference a huge hit. So thank you, Guru Krupa team. Last but not the least, actually, I shouldn't be thanking Dr. Gajanan Ratnaparkhi, sir, and Dr. Smruti Ratnaparkhi, ma'am. But I wish to acknowledge the devoted endeavors of Dr. Gajanan Ratnaparkhi. He has striven really hard since last 5 years, arranging such bits, executing such conferences, making academic get-togethers, with essence of Bollywood celebrities and ministers, with a speaker of par excellence. He is epitome of Kartrutva, Vaktrutva, Netrutva, and Datrutva. He has truly translated vision into reality. And the lady, of course, is the inspiration and pillar behind this. So thank you, Dr. Ratnaparkhi, sir, and Dr. Ratnaparkhi, ma'am, for organizing such a huge, wonderful conference.
Thank you.
If time is money, then you all have spent millions on us. This conference is huge success because of all of you guys. So thank you for being such a wonderful audience. With this, I am at the end. Keep loving Guru Krupa and blessing Guru Krupa. We will meet soon until the next dazzling CardioCon. Till then, goodbye. Thank you. Take care. Sayonara.
Thank you. Thank you, Teju. Nice vote of thanks. So next generation is ready for the CardioCon. Now it's time to say goodbye. Before that, lucky draws. Okay, people are standing, but they are both interested in tea, coffee also, in the delayed gifts also, and here also, na. You might have heard sitting on the fence, standing on the fence. पहली बार देखा है. अरे बैठो comfortably, सब होने वाला है. एक फोटो बाकी. See, they are standing because they are the pillars of our Guru Krupa, pillars of CardioCon, pillars of Andheri Medical Association, Parla Medical Association, Appa. So behind every successful conference, such team is always there, such dedicated team is always there. We can hire professionals to arrange conferences like Vama and all these things, but they will not do the work what these people have done. So give a good round of applause to all these beautiful ladies and hard-working gentlemen who are working hard, giving the delicate gifts. Okay, while going, say thanks to them also. फूल है पूरा? यहाँ भी फूल है? यहाँ भी फूल है? नहीं, ऐसा मत बोलो. ठीक है. So start with.
हाँ अपना सर कृष्णा कारेकर हमेशा लेते हो.
Dr. Krishna Karekar.
अरे वाह.
अरे वाह. After 10, there will be a bumper prize. Again, after 10, there will be 2 bumper prize. 1 bumper prize, sir. Total 2 bumper prize. Okay, that is displayed there.
चेतन बाटविया.
Chetan Batavia. कौन बटाविया? बिल्डर है साहब?
बिल्डर है बहुत बड़ा.
डॉक्टर है कि नहीं फिर?
हाँ डॉक्टर. पर बिल्डिंग का काम करता है. डॉक्टर फेमिदा.
डॉक्टर फेमिदा. एक एक दे दो सब. हाँ सब एक एक लेडीज दे दो. डॉक्टर फेमिदा. क्या? डॉक्टर तरुणा कराड़क. कराड़क. क्या? तरुणा कराड़क. नहीं है? हाँ? नॉट देयर. थोड़ा स्माइल दे सकते हो, ऐसा कुछ प्रॉब्लम नहीं है. ऐसे स्टेज से क्यों देख रहे हो? मिस्टर डॉक्टर अरविंद कामत. अरविंद होता ना इधर. शैलेश तांबे. बकुलेश मेहता सर. He was MMC observer. प्रफुल्ल परमार. ध्रुमीन संघवी. संगोई. कौन संगोई? कौन गया?
सर नहीं है ना.
कोई नहीं है तो अच्छा लगता है सबको. मुग्धा समेल. मुग्धा समेळ
है कि नहीं?
है नौ क्यों बोल रहे यार? केयू महाजन, केयू डॉक्टर रामराव निळकंठे, अरे आवाज कर हा, नाही तर हे लोक नाही आहे म्हणतील. राजशी केनी, मृगांक शहा, मृगांक शहा, विजी सोळंकी, विजी सोळंकी, वायजी सोळंकी, कौन है? अरे इधर से है. भरत व्यास, डॉक्टर भरत व्यास चले गए. काढता पटापट. जयश्री शाह, डॉक्टर जयश्री शाह, डॉक्टर दीपक दल, कौन है? दीपक दल दो है. हा काय? दीपक दल DAL 425 425
दल म्हणजे तेच आहे.
भगवान ऐदासेनी, ओके. मनोज गुप्ता, मनोज शीला तुर्भे, शीला तुर्भे, शीला तुर्भे नहीं है. श्रीपाल जैन, श्रीपाल जैन नहीं है. श्रीपाल जैन आहेत?
ये बंपर है. अच्छा ये
नहीं दूसरा एक बाकी आहे. ते सोड संपले ते काढ आणखी एक काढ ना. नहीं हाँ सो जिगर थाम के बैठो. डॉक्टर 98217 6 5 6 7 3 डॉक्टर, द नेम स्टार्ट विथ DR.
उसके सिवा थोड़ी देंगे.
बाद में एस आता है.
सर केबीसी जैसा मत खेलो, सीधा सीधा खेलो.
शोभा छाबरिया, हो रिलीव्ड नहीं है. सेवन जान दो. नीलोफर पटेल है. अरे वाह वाह. चलो थैंक यू दोस्तों. every good thing has to end. So this is the end of for a new beginning. See you next year again in such a huge number. Till that time, keep blessing. एहसान मेरे दिल पे तुम्हारा है दोस्तों, ये दिल तुम्हारे प्यार का मारा है दोस्तों, ये दिल तुम्हारे प्यार का मारा है दोस्तों। यारों ने मेरे वास्ते क्या कुछ नहीं किया, 100 बार शुक्रिया, अरे 100 बार शुक्रिया। प्रैक्टिस तुम्हारे साथ बढ़ाया है दोस्तों, ये दिल तुम्हारे प्यार का मारा है दोस्तों। थैंक यू, धन्यवाद।
सर मला आज चक्कर येत आहे मला कालपासून